Καλημέρα σας. Παρακαλώ να πάρουμε όλοι τις...
Good morning. Please take your seats in order to begin.
Αξιότιμε κύριε Βουλευτά.
MP, dear guests, dear friends, ladies and gentlemen, the third and last day of our conference is on the same day as the World Cancer Day, and it is dedicated to the future, digital transformation, research, data and AI in cancer care. Today we will find out how tech applications, tech literacy can translate into better prognosis, better diagnosis, and improved care. Focusing always on people, our aim is to end this conference having as an aim to build a health system that will leave no one behind. This conference is under the auspices of the Ministry of Health, the Union for International Cancer Control, European Cancer Organization, OCA International, Association of European Cancer Leagues. Also, it is under the auspices of the Hellenic Society of Medical Oncology, Hellenic Society of Pathology, Hellenic Hematology Society, Hellenic Urinology Society, Hellenic Society of Radio-Oncology, Hellenic Surgical Oncology Society, Hellenic Nuclear and Medical Imaging Society, Hellenic Lung Cancer Society, National Association of Nurses, National Association of Health Visitors. It is also under the auspices of the Association of Pharma Companies, the Pan-Hellenic Association of the Pharma Industry, the Pharma Innovation Forus, and the Hellenic Association of CROs, the National Documentation and Electronic Content Association. Our official media partners are Oncodaily and the Athenian Macedonian News Agency. Our sponsors, platinum sponsors, Armatura, AstraZeneca, Brain, CMT Prooptiki, Gilead, MSD, Servier. Our gold sponsors are AbbVie, Bayer, Bristol Myers Squibb, Coronis, Elpen, Genesis Pharma, GSK, Integris Pharma, Johnson & Johnson, Merck, Papapostolou Varian, Sux Biopharma, Pharmaserv Lilly, Win Medica. Our silver sponsors, Affidea, Amgen, Anabiosis, Astellas, Boehringer Ingelheim, Daiichi Sankyo, GE Healthcare, Genecor, Gnomon Informatics, HIPAA, Ipsen, Nova ICT, Novartis, Pfizer, Pierre Faber, Roche, Takeda. Our media sponsors are Vuli TV, All About Health, Capital.gr, Daily Pharma News.gr, Health Daily, Health Mag, Health Pharma, Health Update, Health Web, Iatronet, iDisease, Medley, Health Next Generation, Plan B, OnMed, Daily Health, The Tomorrow of Health, virus.com.gr. Our audiovisual partner is Connect Elas. We would also like to thank our volunteers from the Pan-Hellenic Association of Women with Breast Cancer, Alma Zois. Now, I would like to launch this third day of our conference by inviting on stage Mr. Michail Livanos, MP at the 2nd Constituency of Piraeus, member of the New Democracy Party and representative of the chairman of the Greek Parliament. Good morning to everybody. First of all, I would like to convey the warm thanks of the chairman of the Greek Parliament, Mr. Nikitas Kaklamanis, who is a person really sensitive to cancer thanks to his professional capacity. He is a physician. I'm a physician as well. I'm a cardiologist. So I would like to express his deep and heartfelt thank you on his part. He would also like me to say to you that he is a fervent supporter of your work. Your work keeps developing and becoming more and more important. You are now an important partner, not only an institutional partner, but most importantly, an actual partner that helps shape policies that promote health and cancer care. Therefore, the President of the Parliament and me, as his representative, we would like to tell you that we are standing by you. Quite often, these are just words, but no politician and no political party, even if they have a background in healthcare, they don't know in depth and in detail many things that are relevant to the everyday lives of patients, and particularly cancer patients, the problems that come up and how these can be solved. So it is very good that we have an organization that can help us understand and provide the right solutions. Today it is the World Cancer Day. On this day, we remember those that have suffered from cancer. In Greece, it is the number 2 cause of death, with about 65,000 new cases per year. Behind each cancer case, there is an important human story, the story of the patient and of their family, of their friends, lives that are turned upside down once the person receives a diagnosis, regardless of their age. So the World Cancer Day is not only about highlighting the importance of this disease, but also the humanitarian aspect and how important it is for those patients to have equal and quality access to healthcare services and receive the healthcare they deserve. Because each one of these patients is a particular case faced with their own emotional difficulties. Let's think where we used to be a few years ago. For many years, we've been talking in Greece endlessly about prevention programs. Prevention programs that were designed on paper. We used to discuss them in panel discussions and round tables, but they were never implemented in practice. Finally, we now have an organized manner, an organized method, and 3 to 4 prevention programs under the Προλαμβάνω program, and 3 of them are about types of cancer: cervical cancer, colon cancer. So therefore, now large parts of the population are screened. This is a small victory with too many benefits, even though there might have been certain problems in its implementation. But it was a very serious and good start. Right after the COVID pandemic, Imagine how difficult this seemed, but we managed to do it. In the past years, there have been other interventions important for patients in order to improve the facilities of our hospitals and the healthcare centers, improve the equipment, improve the accommodation facilities. Yes, we do know that there are still major problems, but imagine that we are a country that exited a 10-year crisis with austerity measures, and it wasn't that easy to allocate funds to public health, but step by step we are having our small victories to the benefit of our patients. So, since today you will be focusing on the digital transformation of health and the introduction of AI into healthcare, which has both positive and negative implications, but a lot of things to offer, not only for treatments per se, but also into our operations. It is a huge challenge, and we welcome your help. Please show us the way. I don't want to waste more time. I believe that previous speakers in this conference, such as the minister who was here yesterday, but other physicians and patients as well, I think all the speakers recognize that if we join forces, we can solve problems, we can identify gaps, we can identify weaknesses and prioritize their resolution. And once this is done by joining forces, I do believe that we will be successful in our endeavor, because life is a dynamic journey, and the same applies to the fight against cancer. The same applies to our fight to create pathways and services for our patients. Thank you very much for your invitation. I wish the best of luck to the works of your conference, and I wish to all of you health in order for us to be able to keep fighting, keep working. Thank you very much.
Ευχαριστούμε θερμά τον κύριο Λιβανό.
Thank you, Mr. Livanos. As every year, this year, we join our voices with cancer patients from all over the world through our participation in the work campaign of UICC. The message for this year is united for unique. Let's hear the message by Ulrika Kagström.
In Athens. On behalf of UICC, I'm delighted to welcome you to today's session. As you know, today is also World Cancer Day. This year's theme, United by Unique, perfectly reflects the focus of your conference, keeping people at the center of everything we do. It reminds us of a simple yet profound idea. Behind each cancer statistic, there is a person with a unique story and unique needs. I wish you engaging discussions, and I look forward to seeing many of you at the World Cancer Congress in Hong Kong later this year.
And now, let's start with our first topic. This session is entitled Shaping a Digital Era in Healthcare, and I would like to give the floor to Mr. Ioannis Karagiannis, President of the Board of the Social Security Electric Governance, to deliver his speech. Good morning, speaker, members of the board of ELLOK, ladies and gentlemen. Thank you for this very honoring invitation to address you at this very important conference on this landmark date. And let me focus on the title of the conference, People at the Center, Bridging Pathways of Care. This title speaks at the heart of modern healthcare, meaning connecting healthcare professional, patients, data, and care with the actual needs of people. I want to congratulate ELLOK for their ongoing and documented work for fighting for the rights of cancer patients, for raising awareness and talking about prevention, for highlighting the inequalities in access and its contribution to the shaping of policies which make the patient journey more humane, safer, and more dignified. I represent IDICA, the Social Security Electronic Governance Agency. We've been trying to serve people through digital tools that will limit red tape, enhance and facilitate access, and ensure safety, transparency, and better coordination throughout this journey in the healthcare system. So by participating in your conference today, which is focused on digital transformation, I must say that this field can be greatly helped by technology. Technology can provide better diagnosis, better organization of the patient journey, improve continuity and coordination amongst facilities and levels of care, support reliable use of data, and help reduce inequalities so that geography or the financial status do not determine access to care. But in order for this digital transformation to be successful, we need something that you are very well aware of: cooperation and involvement of patients. Patients are not mere receivers of services. They should be involved in the design of services. People should always be at the center. Digital technology has already started transforming the health sector, providing new opportunities for diagnosis, treatment, and follow-up. IDICA, through its executives, has been assigned the main part of the digital transformation of health by utilizing these technologies to improve the quality of healthcare and the efficiency of healthcare services. So, it is important to talk about the huge project implemented today by IDICA under the guidance of the Ministry of Digital Governance and the Ministry of Health. We are supervised by both ministries. It is a project funded by the Recovery Fund and the Public Investment Program. This project involves the integration and completion of an electronic health record at the national level. So, the medical community and citizens have now the opportunity to have access to all their medical data through one app. We are also focusing on the digital transformation of cancer care through an integrated system for the care of hematology cancer patients, with the ultimate goal to improve life expectancy, improve quality of life, and the chances to be cured. Right now, there is a project underway about making our hospitals more digitally prepared in all 127 hospitals of the country. The budget is over 139 million. There is now a system being installed about automated transcript of medical procedures. There is also the modernization of the e-prescription system, the national screening programs that the MP talked about, such as the breast cancer screening program, the cervical cancer program, the colorectal cancer program, the cardiovascular diseases screening program, and the obesity screening program. And there is a new program for renal dysfunction, for renal failure. It is important to give some statistics today. 5.21 million citizens have already undergone screening tests thanks to the Prolambano program, which is basically the first comprehensive prevention program in our country. The aim is to achieve an early diagnosis. About 900,000 mammograms have been conducted, more than 900,000 tests for colorectal cancer, 2,500 tests for cardiovascular diseases, while many patients have received free of charge care for obesity so far. IDICA participates in a series of EU projects such as My Health EU, which allows to Greece and other 26 member states to provide high-quality cross-border healthcare services through seamless and secure exchange of medical documents. Today, we are in the process of interconnecting our systems with France, Luxembourg, Portugal, Finland, and we are already interconnected with Spain, Cyprus, Estonia, Lithuania, the Czech Republic, both when it comes to the filling in of prescriptions and the transfer of the health record and the history of each patient. Also, there are horizontal interventions of digital transformation in the bodies supervised by the Ministry of Health. I'm not going to go into details, but I would like to stress that it goes without saying now that digital transformation in health redefines the way in which health services will be provided from now on to citizens. Technology opens up new paths for a more efficient medicine, reducing inequalities. At the same time, there are certain challenges. The first major challenge is digital exclusion. Since we are in a patient representatives conference, the lack of access and the lack of digital skills leave certain groups excluded from the healthcare system. In our times, digital health literacy becomes ever more important, and I'm talking about the ability of the patient, of the citizen, to look for, understand, and use medical information from electronic sources to solve their problems. So the lack of digital skills and the distrust towards electronic services intensify this type of exclusion. No use of AI is enough when citizens themselves are not trained in using digital apps. Thanks to the consistent and ongoing cooperation between IDICA and the Ministry of Digital Transformation, we are now providing more than 1,500 digital services. The My Health app, where the electronic health record of the patient is uploaded, has now 1,200,000 users. That's a small number, while The e-prescription system is now being used by more than 6 million people according to yesterday's data. The percentages of use, training. If we enhance training in digital skills, screening will become more efficient, because in the national screening programs, more than 40% of citizens that have the prescription systems participate, but we have a single-digit percentage of those that participate without having the prescription system activated. And this is all relevant to digital literacy. A second challenge is data security. That's a very big discussion about the European health data area. Of course, it is very important to ensure data security. Now, IDICA, for the past 2 months, has entered a new era. Under a new law that was passed at the end of 2025, our articles of association were amended to adjust to the new provisions of the relevant regulation. We are the organizational and technical portal for the exchange of cross-border data. At the same time, we are preparing ourselves to undertake the role of providing health data for secondary use, always respecting the privacy regulations. This data will only be used for specific, well-defined purposes. And we will make sure that our IT systems will be secure and protected. Access to those secondary data will be granted only to the necessary staff after a very strict process, and those people will have confidentiality obligations. Finally, the processing for secondary purposes such as research and health policies will be conducted by separate units in order to avoid conflicts of interest as required by the regulation on the European health data space. And they cannot be used for any marketing or commercial purposes. To conclude, I would like to stress that it becomes clear that digital transformation is it's not just a tech challenge, it is a social opportunity. Digital technology is the key to improve healthcare services. To this end, we support citizen empowerment, improvement of services, and the sustainability of the healthcare system, always under the guidance of the 2 ministries, in order to build a secure system, future-oriented, the adoption of AI solutions, the management of big data, and the interoperability of systems are decisive factors in strengthening efficiency and accessibility. The footprint of this strategy, the impact of this strategy, will be a system tailor-made to the needs of society. Ladies and gentlemen, the digital era in health is not simply technological development. It is an opportunity to redefine the way in which we provide healthcare by placing patients at the center of everything, at the heart of everything. If we join forces, we can create a more accessible, more efficient, and more humane healthcare system. I know that you have talked a lot about this in this conference, so I would like to congratulate the organizational committee. Thank you for your patience and your attention.
Ευχαριστούμε θερμά και είμαστε έτοιμοι να περάσουμε στο πρώτο στρογγυλό τραπέζι της ημέρας με θέμα τις ψηφιακές εφαρμογές στην υπηρεσία των πολιτών. Θα ήθελα να καλέσω στη σκηνή τον συντονιστή του τραπεζιού, τον κύριο Ιωάννη Κοτσιόπουλο, Γενικό Διευθυντή του Pharma Innovation Forum.
Καλημέρα λοιπόν και από μένα.
Good morning, everybody. I would also like to thank each and every one of you here today. We are at the third day of this annual conference, a very successful conference, and thank you to all participants. So, I need to personally thank the organizing committee for the kind invitation to moderate this panel. It is at the heart of what we are discussing. We are going to be talking about digital applications that are at the service of citizens. And today we have with us a wonderful panel. I would like to invite the members to join me. Ms. Niki Tsuma, CEO of EVICA, the E-Government Center for Social Security, Mr. Nikos Iosif, who is the CEO of Brains ICS and chair of HHI.org, which reminds us that digital transformation is not a motto, but rather an experience, and Mr. Nikos Steriou, senior ICT sales manager of Nova ICT. So all panelists kindly join me on stage on the panel so that we can have a discussion about digital applications.
Ελπίζω να ακουγόμαστε.
Ναι.
I hope that everybody can hear us. So today we will be discussing digital tools, digital applications, and how these can serve by helping the day-to-day living, not just of patients, but of the entire ecosystem. Caregivers, people accompanying patients, healthcare professionals, so that we can speak of a substantial approach on how digital applications can facilitate this ecosystem. So let's start with a very specific question. Can digital applications truly make a difference in the day-to-day life of patients, of citizens? And Ms. Tsuma, you have accumulated years of experience, of highly specialized experience, and it would be amazing if I had the time to speak about all that you have done. You have managed both large-scale projects and highly difficult projects. Lots has become in the digitization, has happened in the digitization of health in Greece in the past few years, and you have accumulated an experience that can be very helpful for our conference. So according to you, how can these digital applications truly make a difference for citizens? First of all, good day. Thank you, Yannis, for your kind words, for your kind introduction. Let me just say that Mr. Kotsiopoulos, the Secretary General, with whom we co-designed the project regarding cancer patients. And this is quite indicative when there is consistency and continuity in the administration field, because we are talking about a project that was designed 3 to 4 years ago, and we are now very, very proud to be able to say that we have already implemented this project. So the people who designed it, the people who went on being part of the ministry, EVICA as the technological assistant, we have been there from day one. And this is very important because this is at the heart of a project's success. A project is not successful when a contractor delivers something and we can tell the recovery fund that we have our deliverable and we have the funds from the recovery fund. This is the financial aspect that has to do with investment, but a project is truly successful when it becomes productively operational, when it starts providing services to citizens. And at this conjuncture in time, ever since 2019, we are very happy, very proud as IDICA, as the Ministry of Digital Governance, to be able to boast that we have provided systems and services to citizens. Very often I say that I hate the word will when I'm talking in conferences. I prefer to say what has been achieved and not what will be achieved. This to me is the gospel. I want to be able to say what has been given as a service to citizens. This means that the audience knows what we're talking about. Patients know it. Physicians have used it in one way or the other. It has been used. We have provided digital services. I will not restrict myself to the oncology applications alone, but we have provided services like the digital service of the health record of patients, My Health applications, what I'm talking about. We have services, we have a folder that is at the disposal, at the hands of the citizen. And this is not just the technological success of an application provided by the state. Just think, applications to us are the apps that we use for takeout, delivery, for shopping online, for getting things from supermarkets. But there are two apps from the public state, gov.gr and My Health application, which means that the Greek government has provided citizens with applications. I mean, think about it. If we just focus on that, it crystallizes, it brings together all the success stories of our services. What does it mean? Practically speaking, we no longer have to carry bags of drugs to the physician. No longer do we face patients going to visit a new doctor and the doctor asks, what kind of medication are you on? I'm not sure of the name, it's the pack with the red line. What kind of milligram? I'm not sure, I've been through many changes. Now, it's also psychologically charging and for a patient to go to a hospital saying, I am a cancer patient. When were you diagnosed? A year ago, approximately. These are all real life stories. And it's about the patient who now can go to a hospital in full dignity to a new physician saying, here I am, you have access to my folder. Use it to see what kind of medication I'm on. And it's about dignity and it's about reliability also. The physician has direct access to the medication, the precise medication, precise dosing regime. And that is at the heart of the service provided to the citizen. Thank you very much for this first remark. I believe that we are highlighting the first pieces of the puzzle. I would like the other two panelists for a couple of minutes, very briefly, to speak about how they believe that digital applications can truly make a difference in health. Let's start with Mr. Youssef. We've heard you say many times, and in many different conferences, that digital transformation is not a slogan. It is something that changes the way people live. First of all, good day to all. Thank you for the invitation. It is a honor for me to be with you here today. Congratulations to ELLOK, congratulations to Mr. Kapetanakis for yet another successful event. And it is an honor for me to be placed in between people that have played a critical role in what we call digital transformation in health in Greece, meaning shifting services from analog and physical to digital services. Especially Mr. Kotsiopoulos on behalf of the private sector, Mrs. Tsuma on behalf of the public sector, you have found yourselves at the heart of many questions that we will be discussing today. Can digital health services make a difference for patients? Yes, they can. For citizens, excuse me. Yes, they can. Whether that difference is factual or just on paper, maybe not even positive, then this is something that now we need to focus on. We need to examine, investigate, because no, not all digital services have a positive impact, make a positive difference on the day-to-day life of the citizen. Which digital application makes a positive impact? The one that gives the citizen dignity, safety, and convenience. Because if an application does not undergo a 10-second test, whereby within these 10 seconds the citizen can understand how to use this application, then they will not use it. There will not be a positive impact. It will be a lost user of that digital application. So an application that simply portrays actions or announces actions, it's not an application, it is a poster sign. An application that you need your grandchild to help you navigate probably requires the establishment of an AI grandchild so that everybody can navigate that application. So I think that a way to move forward is to shift to different metrics. Let's stop measuring downloads and clicks. Let's start measuring how much time is returned to the citizen and how much quality of life is returned to the citizen. Thank you. Moving on to the senior ICT sales manager of Nova ICT, Mr. Nikos Stergiou. Nova ICT has offered many digital applications to patients. How do you feel that you can make a difference in the lives of citizens and patients? Thank you very much. Thank you for inviting me to this conference, and good day. Personally speaking, as a representative of Nova ICT, I would like to talk about specific things. Digital applications need to be useful for users, need to supply access to data. Let me give you an apt, a tangible example. A friend of mine, a relative of mine, after a cycle of 3 chemotherapy treatments, had to get the results of tests, and we went to get the results with lots of stress. We want to see whether the tumor had shrunk, and our first reaction was to send an SMS to the doctor, but because we didn't want to call them, but we had a good physician, and we could text them. Now imagine that nowadays this would no longer be the case, because the physician, the treating physician, has immediate access to the same results that the patient has. So yes, what is the extent of usefulness? I cannot tell you, but to me, they are useful. do you believe that they can make an actual difference in the way patients perceive their pathway, their journey, especially for cancer patients? It is a convoluted, complicated journey. Yes, it will not only ensure direct communication with the physician, it will also ensure access to a community facing the same problems as the patient, which is a huge, important psychological support network and an important source of information. Ms. Tsuma, I think that you are coming close to enriching, broadening the cancer registry. It is online, it is operational, it has been announced. How are we doing with that? The registry of cancer patients is one aspect of the overarching action of cancer hospitals, focused on cancer hospitals. It is a side action because the registry is in fact something created by physicians who enter the data of the patients of cancer hospitals. I know that you are fully aware of what I'm talking about, but I feel that I need to explain some things for the audience in case they do not know. So there are co-creators. Physicians enter data, and then this platform is shared among all cancer hospitals that enrich the databases, and access to this registry and to the data kept within cancer hospitals and by extension in the patient folder. Technologically now we have the capacity to do so, but in order to upload this application we need to have more data. So as we are reaching completion of this project, the interconnection of hospitals, we already have accumulated some data. There has been a time where the data was entered, and now we can figure out who the patients are that can utilize this application, so that all services provided by the application, via the application, be factual, be based on each individual patient's data. So we are focusing primarily on the relationship between the cancer patient and the treating physician. It's not just about the folder. That's not the goal of my health application. It is specializing more and more so on the relationship between treating physician and patient, communication between patients and physicians, communication between tumor boards. So it is specializing service in a tailor-made way, adjusted to the day-to-day life of a cancer patient. We are looking into how cancer patients can communicate with physicians, with caregivers, how caregivers can communicate with one another, and all that within a new technological framework, which is not yet ready, but we have concluded the core part, the back office of hospitals, meaning that we have connected hospitals, they share data, they exchange data, so that the history of the patient is immediately accessible to all cancer hospitals and treating and physicians. So once we have concluded, and we're very close to doing so, as I said, the core part, it will be, I believe, very, very easy to provide the service to patients. We're doing the fine-tuning now. So if I read you correctly, the application for the cancer patient will be more about the relationship between patients and physicians and carers, whereas my health application will be for other patients as well. Well, it's the same rationale, the same approach. We're just creating different services depending on the user, the beneficiary of those services. Okay. We are clarifying things for people who are invested in finding out what is going on. Are those systems operational? Yes. Every patient should have access now to their own folder from their own computer. They don't need to have downloaded the app on their smartphone. All citizens have access to their electronic health folder, which is built on data from various registries, including the cancer registry, which means that already all citizens have access to their health folder, and all physicians. Let's start using that. So you're saying that physicians need to enter more data. Is that the challenge of the day to come? I believe that the key challenge is use. We need to prove both to physicians and patients that this is a useful tool, because once we truly prove that, physicians will go back to it again and again, use it again and again. If they realize that within that application they've got all the information they need for the patient, they will also enter their own data because they want that to be visible next time they visit the folder. Because it's no longer about keeping paper copies of what is happening to my customers, let's call it that. It is a waste of time, it is redundant, and definitely not efficient for the physician, because that restricts their knowledge to what they learn from the patient, whereas the electronic folder is rich with the input of all specialties that have come into contact with that patient, and that allows for better diagnosis, better prognosis, better treatments.
I can see that Ms. Mitru is here, who has helped a lot design the National Registry. Thank you very much, Ms. Mitru, for your hard work. Without your assistance, we wouldn't have been able to design it in the right way. So it's good to give credit to those that help, especially public employees who don't that often get credit. Nova ICT has undertaken a big task, a big project. What about your project, Mr. Stegiou? How do you think it will help? At what stage we are at, and what we will see through this IT system that you've been developing? As in all other digital health transformation projects, we are at the final stage of adjustments in order to deliver them at the end of May. We want systems to be interoperable in order to deliver the result we want. I remember quite a few years ago when before e-prescription, we used to go to the physician carrying a bag full of documents, full of tests, and in serious cases, it was a very heavy bag. Sometimes you forgot your tests at home. It was very confusing. Physicians were spending a lot of time to browse through these tests to find the ones that were relevant to the actual examination. So this is no longer the case thanks to e-prescription, thanks to the electronic health record. Thanks to all these systems, you don't need to bring anything with you as a patient, and then the physician gets the right information. Now, thanks to the registry, physicians have direct access to your medical history. You don't have to browse through the documents you have at home and bring the right document. It's the physician that browses through the record and finds the right information. Also, communication. We will have a digital app for patient communication, and this aims at bridging a gap between patients and treating physicians. It is troublesome for a cancer patient or the family to having to communicate, to book an appointment, or to ask something about insurance. Now, all this communication will be recorded in the app, and you can let the physician know very easily what were the various steps of communication. So quite often we go to the physician and we have so much to tell them that we forget some. So can you please elaborate further on that, how this program will work? Well, hypothetically speaking, after a chemotherapy, there are certain side effects, and you can record them in this app in your mobile phone in real time. I remember saying to my family, to a relative, please write down what you're feeling to let the doctor know. But they didn't, so every time we went to the doctor, we forgot what we would like to say. It is much easier to write down everything in this app once you feel it, so next time it will be there. It won't be a piece of paper that you cannot find. It's in your mobile phone, and you can show it to the treating physician. I want to ask the next question. We've been designing all these things, but how do we take into account the actual needs of patients, and what makes the difference between a successful app and a not that successful app that won't be used by patients? So how can we ensure that our app will actually meet the needs of patients, will be used by both patients and healthcare professionals? What makes the difference? Who would like to answer that? Well, we'll have to keep getting feedback from the community, from patients, physicians, about the user-friendliness of the app. When it comes to the app, we've already organized a workshop with ELLOK, and we are willing, once the app is in operation, we can organize trainings, 2 to 3 online trainings, so that citizens, patients, get the information they need on this digital app and use it rather easily. Yes, we've already received feedback from ELLOK, and once the app is actually being used, we will again get feedback. We will train users on how to use the app. This is a commitment by Nova ICT, because we want to be sure that the app is easy to use and it helps patients. Mr. Yusuf, you said that some apps are more successful than others. What makes the difference between the successful apps and the not so successful apps? How can we make sure that everything we've designed is successful? I will repeat something already mentioned by Nikos. It's important to get feedback by the people. It's important to involve people in the design. Their input can be very useful for our tech guys and girls. I will repeat something Ms. Tuma keeps reiterating in these big meetings with ministers, etc. She keeps saying that I'm an IT expert, but on the other hand, at the same time, I'm still human. I can see the app from the user perspective, not the developer's perspective. I will choose a word mentioned by Nikos as well. Sometimes even our way of thinking is not helpful. When it comes to health apps, we shouldn't forget about the user. Well, maybe we have to stop using the word user and using the word people, individuals, people that have feelings, that look for solutions through these apps. So we need empathy. We need to be able to develop intuitive, easy-to-use apps in these apps it should be easy for the patients, for the people, to find their way through it easily. It shouldn't waste time. It should be a trustworthy app that allows them to keep their dignity. Trust is created through the use of the app when the user feels well about it, about using it. For example, the patient feels protected by using the app, feels that taken care of. And this is not a theoretical exercise. There is the infamous rule 1-1-1. One screen, one action, one way of assistance. If we have busy screens, complex screens, stuffed with too many things, it might be a great app, but it's not people-centered, it's not easy to use by citizens. I'm really happy we are having this conversation because Ms. Touma keeps saying that there are many systems being developed that are not actually used. So it's very nice to hear what you are saying, that patient associations are involved in the design. Ms. Touma, is that right? Yes. Yes. And dear Yannis, we've discussed a lot about the project management organization and scheme. In IDICA, for these big projects, we worked with a project management team that doesn't involve only developers and contractors. The project management team involves a patient representative from ELLOK, also Ms. Mitru. She is an official member of the project management team, the representative of the Ministry of Health, who has the operational knowledge about the registries. And so, IT experts, patient representatives, ministry representatives, and doctor representatives. There are different perspectives. A developer will give a different perspective, and Ms. Mitru will give a different perspective for this registry. User-friendliness is something we should always have in mind. Intuitiveness, and why is that? Because usually we've learned to create apps that are easy to understand by a public servant. For example, you've probably submitted your tax return online. What you read on your tax return is something that can easily be understood by public servants working at the tax office only. No, now we want users, people, patients to understand it, not only developers, not only physicians, not only experts in patient registries. What I keep telling my associates and my partners is that when I develop a form, I read it and I'm saying to myself, do I get what it says? Does it say, type your name, or does it use a more complex phrase that it's not easy to understand? So when what I say to my partners is, when you develop an app, invite your husband, your wife, your children to read it and tell you whether they get it. If they get it, everybody gets it. Not us who are involved in the design. People shouldn't know the amazing technological tools that we've used. Well, okay, well done for us, congratulations, we've used the latest technology. But the service we provide, is it user-friendly? I've known you for many years, and I was certain that you would be asking these questions. I was certain that you would see the patient's perspective, and I'm happy to hear it being confirmed. There have been projects in the past that have not been successful because they lacked this perspective. Maybe because the head of this project is a woman, it is a more empathy-filled project. And it's not only patients. Let's think about healthcare professionals as well. They are very busy. They don't have a lot of time to waste. So let's look at all types of users, all members of this ecosystem. Yes, and what kind of workload we add to these people. Because when we develop systems, everybody looks vertically at their own system. And they say, okay, well, physicians will log in and we'll tell them to do this and that. Why should we make patients, physicians, and pharmacists type in again data that already exists? Since the main systems are already in place, we can use technology so that the physician, the pharmacist, the citizen can give the piece of information that's necessary at the moment and retrieve the piece of information they need promptly. So we don't want more data entry. And we developers need to understand this in order to build something that's user-friendly towards physicians. Physicians should know that they will enter this data once and they will be able to retrieve it tomorrow, after tomorrow, when using another system because there is interoperability. This is how we will make it attractive and user-friendly. This is how we will turn the opportunities of technology into user-friendly systems for citizens, not for technology per se. And a quick comment from everybody, Mr. Stegiou and Mr. Yosif. Are these tools an inextricable part of patient care? Because it is a tool for patients, but for healthcare professionals as well. Do you see this app becoming an inextricable part of holistic care towards the patient? I believe that digital health is the future. It is the development of services, but the degree of complexity increases. We've talked at length about applications. You used a very nice word, both you and Ms. Tsuma. We live in digital ecosystems, and each one alone and all of them together do not address patients or physicians or the health system. They address all three groups at the same time. And especially for patients and people, we need to keep in mind that what they experience is a journey. They have a concern, then there is a diagnosis, a treatment, a follow-up. If they have to log in different systems throughout this journey and enter data again and again, then we don't make their lives easier. We turn this into escape room challenge. Yes, we've built the tools, rightly so. Some of them had to be developed very quickly, but the next step is to streamline them and to make them more humane. And always remember we are not talking about users, we are talking about people. People don't use systems as we design them in an ideal situation, as they are at home and feeling perfectly. No, they use it at hospital, while driving, while in pain, while they're in a hurry. So there is increased complexity. We have to take the next step and make it more humane, more easy to use. We don't have a lot of time. Mr. Stagiou, a final comment on what we've just discussed. These systems that are developed and are going to be delivered in a few months by Nova ICT, quite a few systems, not only the cancer file, are they inextricable part of the care of patients? Let me confirm that Ms. Tsuma has indeed made interventions in order to request simplicity in the use of these systems. As Mr. Yosif said, we should look at users as people, as patients, and by using these apps, they should not feel stressed, they should feel safe to use it. This is very important. Nova ICT should be able to provide training to users, but also when these systems become part of public structures and hospitals, we want to receive feedback from treating physicians. Are they able to use them? Do they make their everyday life easier? The same applies to treatment protocols. When we need feedback to adjust them to make treating physicians and patients' lives easier, we will intervene and make the right adjustment. And a final question, Ms. Tsuma, about the hotline 1566. The 1566 hotline has been created by the Ministry of Health. It is operating, yes. We are not responsible for it, but as far as I know, it is fully functional, and it will be the first communication center with the single communication method with the system. And it has been designed, I imagine, in a way that it is interoperable with all the points where information can be retrieved. This question has been asked by a lot of people from the audience. Okay, this hotline 1566 is how the citizen and the patient can communicate with the health system apart from the app. Yes, as far as I know, that's true. We are not responsible for that, but that's what the Ministry of Health says. It's another way for citizens to access the system. Is there any question from the audience? I can see that we're running out of time. We've run out of time, so I would like to thank all three speakers because they clarified many points related to the success of these digital health apps. Thank you. I would like to thank Mr. Kapetanakis and ELLOK for the invitation. And hopefully in next year's conference, we will have important developments to talk about.
Σε χρήση.
Ευχαριστούμε θερμά και περνάμε ευθύς αμέσως.
Thank you very much. Now we can move straight on to the implementation, the realization of digital transformation in cancer care. Mr. Kapetanakis will be moderating this panel.
Λοιπόν, ένα τραπέζι στο οποίο ήθελα να είμαι κι εγώ. Είναι αλήθεια αυτό. Ήθελα να είμαι μαζί τους, λέω πριν.
I have to admit that I wanted to be on this panel, and I wanted to be on the previous panel as well because I wanted the voice of patients to be heard as well. But I amazingly, somehow, Ms. Tsuma, Mr. Yu, they mentioned exactly what patients want. Now we will be deep diving into the cancer patients folder, this new service, this new development in cancer care. Lots of what you mentioned will be revisited, but hopefully through a different lens. And I would like to invite Ms. Mitru, Panayota Mitru, GP, diabetes mellitus expert, head of the Independent Department of Therapeutic Protocols and Patient Registries of the Ministry of Health. Mr. Konstantinos Michalitsis, head of the systems of the secondary health care in the Ministry of Health. We've got Mr. Kostis Kagelidis, CEO of Gnomon Informatics SA, Mr. Miltiadis Trihas, radiation oncologist, scientific advisor to ESO Hospital, and Mr. Konstantinos Kostikas, co-founder and managing partner of HIPA SA. A year ago, within this conference, there was an announcement, a very important, very powerful announcement regarding the creation of the registry for cancer. And yesterday, the minister actually here spoke of the importance laid on the patient. And we're constantly getting communication from stakeholders who are trying to figure out how to better support patients in their journey. Ever since there is detection of a finding all the way up to full rehabilitation, reintegration into society. So how do we build, how do we bridge pathways of care so as to create a different landscape? And it is with great joy that I come back to what we talked about earlier on. In the past, we didn't have people coming from the system, healthcare professionals, physicians. But now we have with us people that will share their perspective, share what they need, what they anticipate seeing, what they wish to see, what will be helpful to their world. So, let's start with you. And then Ms. Mitru, and then we can have some time for a discussion. So, thank you very much for the honorary invitation. Now, we'll start with figures and data. That's how I like to approach things. As Ms. Tsuma said, there's lots that has been designed. I will be focusing on the registry of patients with cancer, with neoplasties. We have managed to come up with various registries that are fully operational. We have created the rare disease registry. We have consolidated also the children cancer patients that now holds 100% of the patients, and this has been assisted by the fact that children with neoplasties are channeled to very specific clinics within very specific hospitals. So the 10 physicians that are in those departments, in fact, have access to the entire population of children patients. This is not the case with adults. For example, we may have prostate cancer patient that may never receive a treatment and have a great outcome. So in this case, we have a system that includes all physicians. When we're implementing a project, we need to be certain about what we want to achieve. We want to reach this point. Cystic fibrosis with 100% of patients, 100% of data, 8 parameters filled in, all of them. So what we do, each year we manage to get data for all patients in Greece, data regarding patients in Europe, which is updated, and thus we have a comprehensive understanding of what is happening. It's not just quantitative data, how many boys, how many girls, what ages. We also want data that has to do with the outcome of the treatment. With cystic fibrosis, if we see good respiratory function, for example, this indicates how well physicians and clinics in Greece have managed this patient. So we are extrapolating such data, and it is with great joy that I can announce that the indicators regarding disease treatment are exceptional. And this is precisely what we want to see happening with cancer. But in order to do that, we need reliable data. What is the current state of play? These are data from last night. I would like to encourage all of you to use the link that you see top right. It is true that data entry is not just about physicians. Each and every one of us, with no need of a code of access, you can go online using this link and see how many patients are logged in. Right now we have 10,000 patients included in this database. And back in December, it was only 3,000 patients. A few months ago, it was less than 1,000 patients. So as Ms. Tsuma very rightfully said, it is important to realize that a project is not complete when it is delivered, but rather when it is utilized and serving its purpose. So one might say anyone can have access to this site using this link, and they can look at the cancer type allocation, age group allocation, population distribution. It's very important because if we see something on an island, we need to look more into it. Why is it that I've got more cancer cases on this island? So this data is extremely reliable and extremely useful, especially if more and more data is entered. We can look at the most prevalent cancer type per gender. And prior to December, we looked at that and we realized that although the patient number had tripled, prostate cancer was 4th or 5th cause for male subjects. And there was a large campaign in order to raise awareness among physicians that this might be a cancer that might not be fatal to the patient. The patient will die of another cause, but it is a very prevalent cancer, so it's important to enter the data. Otherwise, the data that the state gets is unreliable. And there was amazing work done, and data was entered, and we see nowadays that the first cause of cancer for men is prostate cancer. The first most prevalent cancer type for women is breast cancer. We're still struggling to ensure that this registry will be completed, filled in properly. And we're also looking at which percentage of patients is undergoing chemotherapy, radiation therapy, immunotherapy, and so on and so forth. We had a task force with representatives from HESMO, ELLOK, the Hematology Society, the Urology Society. Let me thank Mr. Kapetanakis. Without his contribution, we wouldn't have been able to do anything of what I'm saying right now. And we can have users even have access to a comment section. We heard Mr. Yosif say that we need to measure how much time patients spend using this application. We also, allow me to say so, need to measure the time doctors spend using this app, because we are bombarding doctors and physicians with protocols, algorithms, applications, data entry, DRGs, what have you. We need to provide them enough time to enter data on these applications. If this data is not entered, then the outcomes, the data we get is unreliable. And the Hellenic Society of Medical Oncology, the Hellenic Hematology Society, ELLOK, Hellenic Cancer Federation have helped us a lot in raising awareness, and now physicians know that they can log in, and if they don't have much time, they can only fill out ICD-10 and ICD-03 morphology and topology, the diagnosis. This can be all that they enter. We don't need all information on a single visit. We need to stress also that we are ensuring safety and validity of the data entered. There is a whole mechanism behind this platform focusing on that. All physicians can enter data. Laboratory users can also enter data. If a prostate cancer is not entered by the urologist oncologist, the radiation oncologist can enter this data, and please do so that the information is not lost. Resources are restricted, and I'm not talking about money, I'm talking about physicians and their limited time availability. But we keep trying to improve this registry. It's not by chance that within a month we went from 3,000 to 10,000 patients. We implemented an application whereby when you're prescribing a drug or a test with a cancer starting with an ICD-10 starting with C, cancer, you will get a pop-up that this patient has not been entered in the registry. And at that point, you can enter the prescription. So there's a reminder to the physician that at least note down ICD-10 so that it is visible that this patient suffers from this disease. What we're trying to implement, to realize right now with HESMO as well, we're trying to standardize the system in such a way as to automatically include the cath lab findings. And then the oncologist will enter any other finding. Therapeutic protocols, both in oncology and hematology, protocols have been concluded. They are being digitized by Vika and the contracting party. It is going to be highly beneficial because it will allow us to improve the selection options, meaning that the right patient will get the right drug for the right stage of the disease. We want to conclude interoperability with SIP, with the e-folder. It is inadmissible, inexcusable that a doctor might need to enter the same data 3 times for 3 different recipients, and I will be very happy to see when this actually manifests, and I'm speaking as a physician myself. We want physicians to enter data only once. We want to reach the point where interoperability is a fact. It allows access to information and to information entry with the least possible hassle. We want this to help with personalized treatments. With cystic fibrosis, I'm using this example because we had an example. We detected a specific mutation and we were able to help save those people. And we want to be able to also include specific performance indicators for quality that can also help with the financial schemes. Financing is very important, and of course the conclusion of interoperability with the European Cancer Registry is going to be truly vital. I need to stop at some point. Benefits are important, are remarkable. We still have a ways ahead of us, but we have raised the bar when it comes to expectations, and we will continue to pursue them. Thank you. Thank you, Ms. Mitru. You have raised a lot of wishes to be discussed. We see that something that started last year is shaping up. It is still in pilot stage, and we all realize that a registry needs to come with a mandatory aspect, and we know that this is a task that will increase the workload, especially of physicians. But given the time that this registry has been up and running, and we know that Viveka has done lots of work, lots of projects are up and running simultaneously, and we had say that you can't have a data entry take place 10 times so that it can be addressed to 10 different recipients. It needs to be entered only once, but we also know how important it is to have this data entered. So I'm not fully satisfied. I believe that every different kind of data needs to be entered. Cystic fibrosis is an excellent example, but we're talking about 900 patients versus thousands, tens of thousands of patients. Of course, it can serve as a paradigm in order to showcase the benefits of this procedure. So, Mr. Michailidis, is coming to you. What are the obstacles you're faced with? What do you believe needs to be done? What sort of intervention? And how much patience will it require before this is truly functional? I've asked a lot of questions. Don't worry, I'll provide lots of answers. Thank you, first of all, to Ms. Mitru for this presentation. This is data that is broadly known and available. Last year, let me remind you, I told you that there's only 1,200 people in the registry, and within 3 months, we are up to 10,118 patients. And every day, there's a constant data entry. Why is this happening? Because this is an application which is friendly to the physician. It only requires minimum data entry for them to conclude their tasks. So we have accomplished one purpose, which was not to burden physicians given their workload. We've also reached 988 data entry points. So you see that acceptance of this registry has been reinforced. It has become, physicians seem to have embraced it. We also, as Ms. Mitru said, placed a switch, a pop-up switch. We didn't stop physicians from concluding their entry, but we remind them that with a simple click, you enrich the database while continuing the data entry that you needed to actually undertake. And this is an aspect of the information system. We have more points that need to be digitized. We've digitized cancer hospitals, hematology, and we have another 10 that is about benign diseases that need to be included, because the registry will not just look upon the malignancies but also on benign conditions, and this will increase not just the volume of data within the registry, the volume of patients, but also the volume of data regarding treatments, regarding histories that will allow physicians to move to better diagnosis and better treatments. So as regards implementation, we're at a satisfactory level. We're about to conclude with 4 more hospitals. User friendliness, yes, each new system comes with some difficulty to adapt and embrace, but within a short period of time it has become accepted and is used. Let's not forget that we're talking about physicians that throughout the day are faced with serious conditions, patients with severe conditions, and the fact that they are entering data, it might not be for all 10,000 within a day, but they are entering data, and it shows that physicians have understood this therapeutic protocol system within the hospital at least. And this will increase entry into therapeutic protocols if we can connect that you cannot move forward if this patient, if you have not ascribed a therapeutic protocol for this patient, a therapeutic protocol which is accepted by the ministry. We can prepare patients from the previous day. Many physicians prepare folders the day prior to the treatment, whatever that treatment is, because that allows them on the day when the patient is at the hospital, they don't have to do anything. Everything is already on the digital folder. This is what has been done so far. Technology does not stop moving forward, though. And that is also the case for demands and needs, patient demands and patient needs. So we're taking future steps. We're moving on. We are expanding the registry to include benign conditions, increasing the use of therapeutic protocols for all physicians throughout the country. Using this system, we are integrating AI in prevention models and risk assessment or models. We're also integrating AI in models regarding diagnostic tests so that hospital physicians, oncologists, radiologists can be informed at all time on how the condition is progressing in order to make decisions. The Ministry of Health, which is now gathering all this data, will also publicize data soon. So we are on a we're constantly working, bearing in mind how we can best help both physicians and patients. Thank you. I understand the challenges are huge. Lots need to be achieved in a very short period of time, and all of this needs to utilize the same language. And maybe the main challenge is, in the same way as we have a registry open to all physicians, in the same way the cancer patients folder should also be accessible to all, because we have patients that move and we cannot discontinue treatment. Precisely, this is why I mentioned the use of folders by all physicians. This is what we're fighting to do now. An oncologist, be it at Laiko Hospital or INRG or ESO or a private physician, will have access to the therapeutic protocol, to the registry, will see what has happened. You mean they will have access to the cancer patients folder? All folders, all e-health folders, irrespective of the specialization, will provide all information to all physicians, be it dentists, oncologists, or what have you. They will have access to the history, to the folder of the patient, within their field of interest. A dentist cannot have access to the oncological data, but an oncologist can see every step that has been taken in the treatment so far within the therapeutic protocol. What did we look at in the past? We viewed all this as independent blocks of information. Now we have a holistic approach. And interoperability allows for what? To be able to look into other systems, take information and use this information. So we as EVICA, we have unified, integrated those systems so that physicians have access to all the data without having to move from one system to the other. It is no easy task. We've reached a satisfactory level. It is already a folder that is used by many physicians that also enter data, that a system that is interoperable with the prescription system, which means that the physician with one access will navigate the system and get the information that physician needs in order to do their job without logging in, without passwords, without what have you. Thank you very much. That is amazing. As patients, that's exactly what we want to see. We want to have a look at this access, but I don't want us to lose time. So let me ask Mr. Trias. There is a time until the procedure was completed. Have there been interventions? Have there been in between? Has there been a need identified for this platform? Yesterday, that's my second question, we spoke of cancer and mental health, and specialists said that we need to also have data that can help us as psychiatrists, psycho-oncologists to play a part, a helpful part in the overall procedure. Do you believe that this is data that can be included in the procedure? Or what else do you see when talking to the world of physicians as a need to be integrated?
The answer is yes to both questions, but before that, before going into detail, I would like to thank you for the invitation, for giving us the floor. Congratulations to ELLOK and to you personally for your exceptional work. I would also like to thank my associates from Nova ICT, from Dataverse, from HIPAA, from all the companies, and a big thank you to the people from EVICA, the people from the Ministry of Health, such as Ms. Mitru. I know it might be a cliché, but it's true. Their contribution is of major importance, and I would like to thank the oncologists and hematologists in our working group, in our task force, because without their eye for detail, without the time they have dedicated, this registry wouldn't be in place, the National Cancer Registry. A lot of things already said by Ms. Mitru and Mr. Michailidis have covered what I would like to say. No need to repeat. Indeed, 1 year ago, the registry was launched. It was, as always in the beginning, a pilot phase. There was a pilot phase, but now it's being used by all oncology specialists in our country. Thousands of doctors have registered. It doesn't mean that they have registered all their patients, but it shows that they're interested in it. And in the past 2.5 months, we had the interconnection with the prescription system, and the number of new entries and new users has skyrocketed. At this point, I would like to say that even there is increased participation and data entry, there are few data entries related to support. So there are not many tickets for support. This means that it is a user-friendly system, that an easy-to-use system. This means that we've done our job as we should. And I would like to thank Ms. Tsuma because she talked about user-friendliness. User-friendliness is the key element to all IT systems, although tech people sometimes forget about that. A system that is not being used is a useless system. And then, now, to answer your questions. Indeed, Mr. Dimitrelis talked yesterday about how nice it would be to have mental health data in the registry. Now, with the extension of the registry that is underway, it can now have more data, including mental health data. Mr. Dimitrelis said verbatim that it is a lost opportunity. No, it's not lost. It's an opportunity we've utilized. This data is part of the extension of the system. Another panel talked about obesity data. The obesity-related data will become part of the registry. And now let me talk about the new functions. Now the registry is used, but it's now being extended in order to become an everyday tool for physicians and to be the heart and the system from which you can receive all cancer care related information. And there is a new functionality based on which treating physicians will be able to see full analysis of the treatment history and manage it. This is very important, particularly in oncology and cancer care, because details are so important in treatment, because there are very tight pharma thresholds and limits. So through the registry, the physician will be able to follow up and manage the treatment provided to the patient. And I'm talking about all physicians of the country, since they all have access to the National Cancer Registry, both doctors from the private and the public sector. Both categories could benefit from it, and the patients could benefit from it. And we have also new prognosis and risk management tools, risk assessment tools. So once there is a diagnosis, once we have a cancer patient registered, then these tools provide useful information to the physician as to the progress of treatment, whether the treatment needs to be adjusted. And these tools will be available for physicians to use them once they feel this is necessary. But we are exploring the possibility of automation. So if the system identifies that there is a problem with a certain patient, for example, that if a therapeutic action has been outdated, is now outdated, then an automated warning will be activated for the physicians. Of course, this is important only if data is registered, is entered. If there is no data entry, the system cannot imagine the answers. So this is why we need easy-to-use systems. The users shouldn't log into multiple systems. Data and information should be entered just once, and interoperability is of major significance. In 2026, with the existing tools that are provided by the Greek state and are paid by the Greek state, this interoperability shouldn't be a problem. So the cancer registry and the oncology systems have embedded technology that ensures interoperability. But of course, interoperability is not mainly a technical issue. It is an issue in which many stakeholders are involved, and this creates difficulties. Of course, this is not only a Greek problem, it is an international problem. But when it comes to the tech part, we're there, we've ensured interoperability, and the systems keep maturing. So, interoperability becomes better and better to the benefit of patients. And as this technology matures, data will be used and presented, displayed to the physician in order for patients to receive the necessary treatment. Great. We might be one of the last countries to have a registry, but this allows us to have a very modern registry that will be very helpful in the future. And all these extensions and adjustments are necessary. It just takes a little patience. Thank you, Mr. Kostikis. Now, a question to Mr. Kangelidis. Mr. Kangelidis, we've organized workshops together, we've worked together, we've invited physicians. This app, which might be even a European best case study, there are not many EU countries that have managed to do that. Please let me know if you know such a country. But I do know that it is a priority of the European Commission. They understood that it is very important for patients to be able to communicate. Is very important. So in this context, this app is now being developed that puts patients at the center, tries to promote interdisciplinarity and make things easier. And of course, what we've already said is that this application can be useful and valuable under certain conditions. 1, it is available to all patients. 2, it is useful for both patients, physicians, and hospitals. Where do we stand now? Well, first of all, I'm very happy to be here, as every year. This is a think tank about cancer, and your work is amazing. I'm part of a team that have dedicated a lot of time to generate these results together with Nova ICT and other colleagues who are in the room. And of course, under the guidance of Idika, Ms. Touma, Mr. Michalitsis, in order to make this happen. And it's not easy, it's difficult, because digital transformation shifts the agenda of every stakeholder involved. At the heart of this transformation, patients should always lie. That's a problem because it didn't used to be like that. It's a paradigm shift. Now the ministry adopts more and more techniques where patients can report, and this creates a completely new context, a necessary context in order for the health system to meet the challenges ahead. Because if we don't utilize this major public investment, given the aging population, given the increasing cancer cases, if we are not productive, we will fail. So, why do these digital tools and how these digital tools are people-centered in an innovative, rather, way? Well, first of all, They guide the patient correctly through the first steps in order not to lose time, provide metrics that the health system can use in relation to the patient pathway. So the medical community should work on this data. It's very important to have codified data, and we should have physicians that can understand and codify data, because AI-based technologies are based on data. So we should generate and use data correctly. This is why this is a monumental effort that also ensures interoperability. This means that the health system shouldn't be trapped with a single provider. No, it is fully interoperable and it can be further developed in the future. So these data are provided, and through this app you can follow up on survivorship. It is also a platform where other services can be added on, such as psychological support. There are various ways for the ministry to use this as a platform for support services. Through teleconference, for example. It can also boost and include more specialists in the treating team, such as a cardiologist. So, through this system, we can become more productive, and it is an affordable system that will help us ensure productivity. Also, patient safety. This system takes into account the patient diary, the SPCs of the drugs that he is being administered. This can help treating physicians to do their job. And it will be easier to automate communication with patients using technology. Thank you very much. Now, I would like to go to Mr. Trijas. On purpose, you are the last to be speaking, because I want you to tell us where you used to be, where we are now, what's the future, and how all these things that are happening can serve the needs of healthcare professionals as well. What are your needs? What would make your life easier today? Everything we've talked about, do they make your life easier? We are together in this journey. If they don't help you, they don't help us neither. So the system should be helpful to everybody involved. Thank you, George, for paying me the honor to participate in this panel discussion. Well, I'm looking for solutions to patient problems and my problems as well. Patients go to physicians not to have a cup of coffee, but to find a solution to their health problem. So we need to provide the right answer on what to do. And in order to provide the right answer, I have to have the full picture, full knowledge of what's happening. Quite often, patients cannot give full information, so it should be recorded and easily retrievable. Patients are not static. They are in a dynamic situation, so this system should be enriched all the time, and I should know also the family history. There might be a genetic background to his disease. If a patient has a problem, they will find a physician, let's say, at midnight. They might call 10 physicians and nobody answers for various reasons. So we need to have this information as well collected in the system. Now, I don't pick up the phone anymore because George is going to call me I had an appointment with him 3 years ago, and he's going to tell me, George, I have this problem. I don't remember him. I don't know who he is. So the best thing to do is not to answer anything. The worst answer is to give a random answer. If my secretary picks up the phone, she finds the patient record, and I can have the right information in order to give an answer to the patient faster. And it's not only that. Physicians should self-assess through this app. It's very easy through this app to ensure follow-up, to record everything related to follow-up in this app. There is also a quality of life leaflet that proves whether I've done things correctly or whether I can do something else to improve the quality of life. So if everything is gathered in the same place, I can give better answers faster. I do hope, though, that all this data is protected by GDPR regulations and data security mechanisms. We should also stress that everything we're doing is to the benefit of patients. If patients don't use it, this is not useful for physicians as well. So we need an easy-to-use app that can be individualized per patient, because it might be simple for me, but it's not simple for somebody who's lying on a bed in pain. So we might need the ability to have voice commands for the people in pain. And we should involve more people that need this information: social workers, dietitians, the physical trainer of the patient, the physiotherapist. So, and also there should be a chat box in which all teams of the interdisciplinary team can send a message, and we can track the answers or the lack of answers. What you told us is what Mr. Iosif told us. We should look from the patient's perspective, we should explore their needs and build on them. There are, of course, legal complications, technical difficulties, but we should identify the needs and use the right processes to meet these needs and help the entire system, hospitals, physicians. Well, the patients should define their environment of care. It shouldn't be as it used to be in the past, my patient. No. The patients who say, my physician, my psychologist, my social worker, and I will have the initiative to initiate contact with them. Thank you very much.
I am grateful to all of you. We have seen that a year ago we were announcing, we were starting on a journey, we were hopeful, we were talking about a time of implementation that has already provided us with important data and feedback. And that's not something that can happen overnight. We are trying to accelerate things. We are trying to change the mindset of an entire ecosystem and look at things differently and look at how we can construct new services. You've all done an amazing job, and I'm always honored to be in the same panel with you. And we will have the opportunity in the future to look at what is happening again and at what can be done so that things that are happening can be improved. Thank you all very, very much.
Ευχαριστούμε πολύ και μπορούμε να περάσουμε αμέσως στο επόμενο τραπέζι για την έρευνα και την καινοτομία. Και παρακαλώ τον κύριο Παναγιώτη Μπαμπίδη, καθηγητή Ιατρικής Φυσικής και Πληροφορικής στην Ιατρική Εκπαίδευση, εργαστήριο Ιατρικής Φυσικής της Ιατρικής.
The interpreters have been informed by ELLOK that there will be no coffee break, and we have been requested to break for 15 minutes in order to preserve the quality of our job. So we will, the interpreting will assume in 15 minutes from now. Thank you.
Καλημέρα και από μένα. Θα ξεκινήσουμε ευθύς αμέσως για να κερδίσουμε το χαμένο χρόνο. Στην τράπεζα αυτή για την έρευνα και την καινοτομία θα ήθελα να καλέσω τον κύριο Τάσο Γαϊτάνη, που είναι τέος Γενικός Γραμματέας Έρευνας και Καινοτομίας, τον κύριο Δημήτρη Φωτιάδη, που είναι καθηγητής Βιοιατρικής Τεχνολογίας στο Πανεπιστήμιο Ιωαννίνων, τον κύριο Νίκο Κωστάρα, που είναι από την COS Biotechnology Partners, τον κύριο Δημοσθένη Σαριάννη, που είναι Διευθυντής και Πρόεδρος του Διοικητικού Συμβουλίου του Εθνικού Ιδρύματος Ερευνών και καθηγητής του ΑΠΙΘΙΤΑ, και Σαριάννης. Τον κύριο Γιώργο Μέγα, που είναι Innovation Ecosystems και Health Affairs του Ινστιτούτου Επικοινωνιών και Υπολογιστών του Εθνικού Μετσόβιου Πολυτεχνείου, και τον κύριο Άλεξ Πενσενούση, που είναι Senior Project Manager και Business Developer στην Enigma Technologies. Καταρχήν σας ευχαριστούμε που είστε μαζί μας. Θα προσπαθήσουμε, κεντρικός άξονας αυτής της τράπεζας είναι η έρευνα και η καινοτομία. Προφανώς όλοι μιλάμε για καινοτομία στην ογκολογία και την έρευνα του καρκίνου ευρύτερα. Θα προσπαθήσουμε να διερευνήσουμε τι χρειάζεται να αλλάξει, έτσι ώστε η καινοτομία να μην μένει στο επίπεδο των πιλωτικών έργων ή των δημοσιεύσεων, και πώς μπορεί το κράτος να λειτουργήσει ως επιταχυντής και όχι ως φρένο ουσιαστικά στην καινοτομία και την έρευνα του καρκίνου. Υπάρχει χώρος για ευελιξία, ρυθμιστική ή άλλου επίπεδου? Είμαστε έτοιμοι να αποδεχτούμε ότι η καινοτομία έχει και κόστος, αλλά και το κόστος υπάρχει όταν δεν υιοθετούμε την καινοτομία? Τι θα χρειαζόμασταν αύριο το πρωί για να μεταφέρουμε μια πιο γρήγορα την έρευνά μας στον ασθενή? Υποδομές, δεδομένα, συνεργασίας, αλλαγή κουλτούρας, ποια είναι αυτά που θα είναι τα προεξάρχοντα χαρακτηριστικά μας? Ποια θα πρέπει να είναι η βέλτιστη αξιοποίηση των ψηφιακών τεχνολογιών για έρευνα, καινοτομία και δεδομένα και τεκμηριωμένες αποφάσεις? Θέτοντας έτσι αυτό το πλαίσιο, θα ήθελα όλους τους πανελίστες να τοποθετηθούν για μερικά λεπτά, 2 με 3 λεπτά, 4 λεπτά το μεγαλύτερο, γύρω από αυτό το θέμα, προτάσσοντας τις δικές τους θέσεις σχετικά με το πώς θα μπορούσε να βελτιωθεί η έρευνα και η καινοτομία στον καρκίνο. Θα ξεκινήσουμε με τον κύριο Γαϊτάνη.
Καλημέρα. Να συγχαρώ το ΕΛΛΟΚ για την πρωτοβουλία να διοργανώσει το 10ο Συνέδριο. Ευχαριστήσω για την πρόσκληση να είμαι και φέτος εδώ. Και νομίζω σήμερα, αν δεν κάνω λάθος, είναι η Παγκόσμια ημέρα κατά του καρκίνου, 4 Φεβρουαρίου, οπότε είναι διπλά συμβολικό το γεγονός ότι διοργανώνεται και φέτος αυτό το συνέδριο. Θα ξεκινήσω από τη μεγάλη εικόνα, αγαπητέ Παναγιώτη. Πράγματι, η χώρα μας υστερεί στη μετατροπή των ερευνητικών αποτελεσμάτων σε καινοτομικά προϊόντα ή διαδικασίες. Πρέπει φυσικά να ενισχύσουμε και την έρευνα, αλλά και την έρευνα την οποία παράγουμε σήμερα στην Ελλάδα δεν τη μετατρέπουμε αποτελεσματικά. Αυτό είναι ένα κενό το οποίο η πολιτεία έχει εντοπίσει και γι' αυτό το λόγο έχει ανακοινώσει ο Πρωθυπουργός, ένας από τους λόγους, τους βασικούς, την δημιουργία ενός νέου Υπουργείου Έρευνας και Ανώτατης Εκπαίδευσης, μετά τις επόμενες εκλογές. Αυτή την περίοδο έχει συγκροτηθεί μια ομάδα εργασίας, στην οποία είμαι μέλος, για να μελετήσουμε τη δομή, τις αρμοδιότητες, τις διαδικασίες που θα πρέπει να έχει αυτό το νέο Υπουργείο, ώστε μετά τις επόμενες εκλογές, και εφόσον οι πολίτες φυσικά επιλέξουν τη Νέα Δημοκρατία για τη διακυβέρνηση του τόπου, να γίνει πράξη, ώστε αυτή η διαδικασία να μπορέσει να επιταχυνθεί και να ενισχυθεί. Τώρα, μιλώντας πιο συγκεκριμένα για τον καρκίνο και για την καινοτομία στην ογκολογία, θα μπορούσε κανείς να βάλει 2-3 τίτλους. Τι χρειαζόμαστε πολύ περισσότερο. Σίγουρα χρειαζόμαστε δεδομένα. Γίνεται μια συστηματική δουλειά από το Υπουργείο Ψηφιακής Πολιτικής. Νομίζω και ο πρόεδρος του ΙΔΙΚΑ, ο Γιάννης ο Καραγιάννης, ήταν προηγουμένως ομιλητής σε κάποιο πάνελ. Υπάρχει λοιπόν αυτή η κουλτούρα στο να δημιουργήσουμε σωστά δεδομένα, σωστά επισημασμένα δεδομένα που να μπορούν να χρησιμοποιηθούν στον καρκίνο. Έχουμε τις τεχνολογικές υποδομές, θα έχουμε πιο σωστά τουλάχιστον για την τεχνητή νοημοσύνη, με το φάρο. Η υγεία είναι ένα από τους 3 άξονες για να χρησιμοποιήσει τεχνητή νοημοσύνη. Μας λείπουν χρηματοδοτικά εργαλεία για περισσότερο ίσως proof of concept. Θα πρέπει να δούμε πολύ καλύτερα και πιο συστηματικά όλο το πλαίσιο των κλινικών μελετών, για να μπορέσουμε αποτελεσματικά και γρήγορα να διεξάγουμε κλινικές μελέτες. Θα πρέπει να συνεργαστούμε πολύ περισσότερο εμείς ως επιστήμονες. Εγώ ασχολούμαι επιστημονικά, ερευνητικά με την ιατρική απεικόνηση, αλλά συνεργάζομαι με τους κλινικούς γιατρούς, το οποίο είναι σχετικά δύσκολο να συμβαίνει στην πράξη, γιατί και οι κλινικοί γιατροί είναι άνθρωποι οι οποίοι έχουν επιβαρημένο πρόγραμμα. Είναι δύσκολο από το κλινικό τους έργο να τους αποσπάσεις και να τους βάλεις στην έρευνα, παρόλο που θέλουν να το κάνουν. Άρα πρέπει να δούμε τον τρόπο περισσότερο και καλύτερα πώς θα συνεργαστούμε, και προφανώς όλοι οι stakeholders αυτού του οικοσυστήματος, δηλαδή από τους κλινικούς γιατρούς, τους ερευνητές των άλλων ειδικοτήτων, τους ασθενείς, ο ρόλος του ΕΛΛΟΚ, η πολιτεία προφανώς, οι εταιρείες, να κάτσουμε γύρω και από ένα τραπέζι, να δούμε τις συνέργειες που μπορούμε να αναπτύξουμε, τα προβλήματα που πρέπει να ξεπεράσουμε για να καταφέρουμε να γίνουμε πιο αποτελεσματικοί. Κλείνοντας αυτή την πρώτη τοποθέτηση, και να δώσω και στους συνομιλητές μου το χρόνο να ακούσουμε και τις δικές τους τοποθετήσεις, θέλω να πω ότι είμαι αισιόδοξος. Δεν είμαι απαισιόδοξος, είμαι αισιόδοξος για τους εξής λόγους. Πρώτον, γιατί έχουμε ένα καλά εκπαιδευμένο επιστημονικό δυναμικό. Το δεύτερο είναι ότι αναπτύσσουμε σημαντικές υποδομές που τουλάχιστον για τις επόμενες δεκαετίες, και το Ταμείο Ανάκαμψης ήταν μια μεγάλη ευκαιρία, θα μας δώσουν τη δυνατότητα να έχουμε τα κατάλληλα θεσμικά εργαλεία. Έχουμε μια κυβέρνηση η οποία σε αυτά τα θέματα ακούει, συνεργάζεται, έχει ανοιχτούς ορίζοντες. Προφανώς δεν έχουν λυθεί όλα τα ζητήματα, αλλά υπάρχει μια θετική αντίληψη. Πρέπει φυσικά να επιταχύνουμε, να τρέξουμε πιο γρήγορα, και νομίζω ότι όλα θα πάνε καλά.
Παναγιώτη, ευχαριστώ. Ευχαριστώ πάρα πολύ την ΕΛΛΟΚ για την οργάνωση, και ιδιαίτερα τον Γιώργο τον Καπετανάκη για την οργάνωση και την πρόσκληση σε αυτό το meeting, για να μιλήσουμε για τα προβλήματα τα οποία υπάρχουν. Κοιτώντας την ανάλυση που έκανε ο Παναγιώτης, που ήταν πάρα πολύ καλή νομίζω, σαν τοποθέτηση που βρισκόμαστε, για την έρευνα, την καινοτομία και τα ψηφιακά θέματα που κοιτάμε σε αυτή την ενότητα. Εγώ θα ήθελα μερικά πράγματα να σας βάλω σε ένα ευρωπαϊκό επίπεδο, και κυρίως αυτά τα οποία αφορούν την έρευνα την οποία κάνουμε εμείς. Πρώτα απ' όλα, η Ευρώπη αυτή τη στιγμή προχωράει πάρα πολύ καλά νομίζω, και το European Health Data Space είναι πιο μπροστά από τα υπόλοιπα data spaces τα οποία υπάρχουν, το οποίο είναι πάρα πολύ θετικό. Σε αυτό το πλαίσιο, λοιπόν, η μεγάλη έμφαση δίνεται σήμερα στον καρκίνο, και μάλιστα η Ευρώπη δίνει ιδιαίτερη συμμετοχή, εφόσον έχει καθορίσει ειδικό, και το έχει ένα από τα 5 missions τα οποία έχει σήμερα η Ευρώπη, είναι και ο καρκίνος. Σε αυτό το πλαίσιο, λοιπόν, για το European Health Data Space, τι πάμε να κάνουμε? Ουσιαστικά πάμε να χτίσουμε εφαρμογές σαν δευτερογενή χρήση AI, οι οποίες μπορούν να χρησιμοποιηθούν ως προβλεπτικά μοντέλα για το καρκίνο. Έτσι, το UKIM, το οποίο προχωράει, έχει σήμερα ένα τεράστιο αποθετήριο κυρίως δεδομένων απεικονιστικών και εκεί, αν θέλουν εταιρείες ή οποιοσδήποτε έτσι, οργανισμός, μπορεί να βρει δεδομένα, τα οποία είναι και labeled. Έτσι, για να μπορέσει να κάνει τα μοντέλα τεχνητής νοημοσύνης, τα οποία κατά κύριο λόγο είναι προβλεπτικά. Απ' την άλλη μεριά, έτσι, σε αυτό αρχίζουν και προσθέτονται τώρα δεδομένα από τα EHR, λύνοντας θέματα του EHR, κυρίως έτσι, με το format το οποίο έχουμε, αλλά και με το CE marking των EHR suppliers, μπορούμε να αναβάζουμε δεδομένα στα οποία θα έχει πρόσβαση ο ασθενής, έτσι, να λύσουμε και τη διασυνοριακότητα. Αυτό είναι το European Health Data Space. Ακούσατε νωρίτερα τις εθνικές δραστηριότητες, αλλά ξέρετε πρέπει να πάμε και σε ευρωπαϊκό επίπεδο. Τώρα βεβαίως, έτσι όσον αφορά τον καρκίνο, ένα ακόμα μεγάλο έτσι, flagship project στην κοινότητα, το uncan.eu, προχωράει αυτή τη στιγμή έτσι, και πηγαίνει και σε άλλου τύπου δεδομένα, τα οποία επίσης είναι πάρα πολύ χρήσιμα για να πάμε πάλι στην ίδια κατεύθυνση. Βεβαίως, από την άλλη μεριά, κάποιος μπορεί να πει γιατί δεν έχουμε φτάσει ακόμα στον ασθενή ή δεν έχουμε φτάσει στην ιατρική πράξη με αυτά τα οποία έχουμε. Ερώτημα το οποίο μας απασχολεί. Στην Ελλάδα πολλές φορές αποδίδεται στο ότι δεν υπάρχουν αρκετά χρήματα, ότι μας εμποδίζει κάτι το οποίο είναι ένα σύννεφο το οποίο δεν ξέρουμε, αλλά ξέρετε, όπως έχουμε πει, το κανονιστικό πλαίσιο, το διεθνές, είναι θέμα για αυτά τα πράγματα. Σήμερα όμως, στην ακτινολογία, που μεγάλο μέρος των εφαρμογών αφορά και το καρκίνο, οι περισσότερες εφαρμογές οι οποίες έχουν περάσει σε AI στο FDA αφορούν αυτό το κομμάτι. Πάνω από 75%, πάνω από 80%. Αλλά δεν είναι τεράστιος ο αριθμός, είναι περίπου στα 1000. Έτσι, όταν έχουμε αυτή τη στιγμή περίπου 250.000 ιατρικές συσκευές σε όλη την Ευρώπη. Άρα 1000 συσκευές, καταλαβαίνετε, δεν λένε πολλά πράγματα και ιδιαίτερα όταν αυτό είναι στην Αμερική. Βεβαίως, όταν κάποιος κοιτάζει το καρκίνο, κοιτάζει διάφορα πράγματα, τα οποία είναι το progression, η μετάσταση και ουσιαστικά, αν το θέλετε, η επανεμφάνιση. Αυτά είναι προβλήματα τα οποία σήμερα δουλεύει πάρα πολύ η ερευνητική κοινότητα για να σας δώσω και την κατεύθυνση προς την οποία πάει. Όμως κοιτάζει και άλλα προβλήματα τα οποία σχετίζονται με side effects των στοχευμένων θεραπείων, για παράδειγμα. Όταν κάποιος υφίσταται μια θεραπεία στοχευμένη, πηγαίνει ένα βήμα παρακάτω και βλέπει, ας πούμε, καρδιοτοξικότητα, το οποίο σήμερα απασχολεί τον τρόπο με τον οποίο θα χειριστούμε έναν ασθενή. Έτσι, το οποίο είναι πάρα πολύ σημαντικό, πολύ συχνό φαινόμενο, έτσι, και μάλιστα έτσι, άλλος οργανισμός, η Ευρωπαϊκή Καρδιολογική Εταιρεία, προχώρησε σε έναν νέο ορισμό της καρδιοτοξικότητας που συλλαμβάνει και πολύ αδύναμες μορφές, πολύ mild καρδιοτοξικότητα, δηλαδή από το Σεπτέμβριο του 2022. Έτσι, επομένως, και αυτό έχει αλλάξει και δίνει μεγάλη έμφαση στο τι γίνεται γύρω από το φάρμακο. Όμως, υπάρχουν και παράγοντες, στους οποίους το καρκίνο μπορούμε να ρυθμίσουμε. Και αυτοί οι παράγοντες είναι το lifestyle, είναι τα exposomics, τα οποία μιλάμε όλοι μας, η διατροφή, ο τρόπος με τον οποίο χειριζόμαστε ψυχολογικά έναν ασθενή και όλα αυτά τα πράγματα. Αυτά γενικά έτσι, δεν καταγράφονται εύκολα και πραγματικά είναι εκεί που σήμερα έχουμε τη μεγάλη αδυναμία στα δεδομένα για να φτιάξουμε προβλεπτικά μοντέλα. Και εκεί πρέπει να επιμείνουμε αρκετά κατά την άποψή μου, διότι είναι παράγοντες ρίσκου, τους οποίους μπορούμε εν τέλει να αποφύγουμε. Άρα, σε αυτό το τομέα, τουλάχιστον που ασχολούμαι εγώ, έτσι βλέπετε ότι υπάρχουν διάφορες μορφές εξέλιξης έρευνας. Ελπίζουμε σύντομα έτσι να έχετε πολύ απτά αποτελέσματα, αλλά δεν είναι, ξέρετε, στο μέλλον αυτά έτσι να πούμε ότι είναι 1 μηνός, 2 μηνών δουλειά. Είναι χρόνο δουλειά. Παναγιώτη, αυτά από μένα. Έτσι.
Καλησπέρα. Γεια σας. Λοιπόν, καταρχάς σας ευχαριστώ για την πρόσκληση. Συγχαρητήρια. Και ευχαριστώ και τον Γιώργο. Και συγχαρητήρια, Γιώργο. Λοιπόν, καταρχάς να κάνω μια μικρή σύσταση, γιατί μπορεί να με γνωρίζετε σαν φυσικό πρόσωπο κάποιοι, αλλά δεν γνωρίζετε τον οργανισμό που εκπροσωπώ. Είμαι ο Νίκος Κωστάρας και είμαι partner στο COS, Biotechnology Partners. Είμαστε ένα fund, venture capital, το οποίο επενδύουμε στον χώρο της υγείας αποκλειστικά. Είμαστε το πρώτο fund στην Ελλάδα που επενδύουμε στον χώρο της υγείας. Σε 3 τομείς. Ο ένας είναι βιοτεχνολογία, ο άλλος είναι pharma services και ο άλλος είναι medical technology. Φτιάχτηκε αυτό το fund με στόχο να χρηματοδοτήσουμε start-up εταιρείες, οι οποίες κάνουν κάποιες καινοτομίες σε ένα από αυτούς τους 3 τομείς που προείπα. Ακόμα και αν αυτές οι εταιρείες βρίσκονται στο εξωτερικό, θα φέρουν ένα κομμάτι από τις λειτουργίες τους στην Ελλάδα, ούτως ώστε να βοηθήσουμε την ελληνική οικονομία και την ελληνική επιστημονική κοινότητα, άρα διατηρώντας τους Έλληνες ερευνητές και επιστήμονες εδώ. Και αυτό είναι πάρα πολύ σημαντικό. Τώρα, στον χώρο της έρευνας η Ελλάδα δίνει περίπου το 1,54% του ΑΕΠ στην έρευνα, στο R&D. Δεν είμαστε στις χαμηλότερες θέσεις, χωρίς να είμαστε βέβαια και στις ψηλότερες. Είμαστε περίπου στο μέσο της Ευρωπαϊκής Ένωσης. Μπορούμε να πάμε καλύτερα και έχουμε βελτιωθεί τα τελευταία χρόνια, που σημαίνει ότι έχουν γίνει βήματα προόδου. Αυτό βέβαια συνολικά σαν R&D, αν πάμε στον χώρο της υγείας, είμαστε αρκετά πίσω, δηλαδή οι 3 πρώτες χώροι, οι 3 πρώτες βιομηχανίες που είναι για αυτό το R&D, δεν είναι μέσα στο χώρο της υγείας. Στον χώρο της υγείας τα πράγματα στην έρευνα είναι αρκετά πίσω και στην ερώτηση σας, κύριε Παμίδη, για το τι μπορεί να αλλάξει, τι ευθύνεται γι' αυτό, είναι θέμα κυρίως, γιατί είπατε κάποια πράγματα, δεν είναι τόσο πολύ χρηματοδότηση, είναι και χρηματοδότηση, αλλά περισσότερο νομίζω είναι θέμα κουλτούρας και βούλησης, με την έννοια ότι ίσως θα έπρεπε, μια ιδέα θα μπορούσε να είναι να υπάρχει ένας φορέας ο οποίος να συντονίζει όλες τις έρευνες στον χώρο της υγείας, γιατί είμαστε...
Let us not forget that we are a medium to small-sized country, so it's not like anyone can do whatever they want. It's not like, I've got an idea, I'll run this research. We need coordination of the parties involved. We need a coordinating body in order to ensure better results and no overlapping of spending. And this also, at a later stage, needs to be coordinated with foreign countries, with other countries. So we need to look at the coordinators, the parties involved, and the funds. And funds are the last issue of concern. It's primarily the people who are important. As a fund, I think that we would be willing to finance efforts looking for solutions to specific needs. We don't care about the degree of innovation. We care about how linked it is, how to what extent it is associated with an actual need. There used to be a distinction in between the academia and the market, and this is definitely wrong. Throughout the world, we see that the contrary is happening. If we want a framework that is agile, that is helpful, in this case, an idea born in a university translates into a spin-off, is financed, and then either fails or succeeds. It's not like, I'm a university, I'll have a grant, I'll develop an idea, and then it will be shelved. This does not make investors happy, this does not make universities happy, this does not help improve Greek economy. And this means that we will continue to experience a brain drain, people moving abroad and staying there. And a third result, so people move abroad, if they don't see any future prospects here. What we do is we try to import brains. In order to convince them that it's worth the effort, we need to be certain that the idea we're going to be discussing will be implemented. We're not going to be able to convince them to come over if we tell them, come here, work on a lab, and if you get an idea, if you produce something, who cares? And that's also an issue for the legislative framework, the legislation. Thank you very much. On behalf of the National Research Center, Institute, I would also like to thank ELLOK for your constant work, for the organization of all these conferences. On Monday, with Yoros Kapitanakis, we will be signing a strategic MOU between ELLOK and our institute, because I believe that as researchers we are called upon to provide answers to questions like the ones already mentioned by my fellow panelists. How can we move from ideas, concepts to clinical practice? If we want innovation and technology to truly have an impact on our patient, if we don't want ideas to be a one-off firework, we need to shift our interest from the project itself to the system, which means that we need to look at a clinical adoption routine with measurable outcomes as the success. This needs to be defined as the success of a project. We need to have a pipeline that will be for translational research, which means that there will be a connection in between research protocols, scientific communities, population at large, something that is fully comprehensive. In the EU, this is also legislated since 2025. All new cancer drugs will fall under joint clinical assessments. We know that, which means that we need to have well-documented procedures and procedures that can be anticipated. Secondly, innovation cannot produce results without data. This is something that has been mentioned by many panelists. We need benchmarks, we need milestones for both primary and secondary use. Anything that we build here in Greece today will need to interlock, to interact with the European framework that has been established. And I'm not just talking about cancer care. And the bit is not just about creating a platform. Yes, we want a main platform of information. We also, however, need to look into the quality of the information, the range of the information as regards pathologies, outcomes, biomarkers, so that we truly have real-world evidence. And last but not least, we need to change motivation and accountability. We need to reward implementation, not just publication of a new idea. It's not just papers to grants, but also time in between conception of an idea, all the way down to findings regarding toxicity, quality of life of the patient, financial efficacy. And this is where the state comes into play, I feel. Because the state can serve as an accelerator or as a platform builder in perfect Greek, with clear rules, with clear decision-making pathways, so that it is not necessary for each and every oncology cancer hospital to reinvent the wheel. So we need a one-stop shop for data integration. Right now we've got AI developments, and this all raises questions regarding progress, quality. I believe that we need to be flexible, but at the same time always take into consideration security of the data. Regulatory sandbox is what we need. We want AI models that will be implemented in real life clinical settings. And here, smart reimbursement is an issue, so that we can pay but also learn from what we paid for. And let me close by saying that in clinical practice we're always discussing the cost of innovation. It has been mentioned in this panel as well. Funds are here to bridge this gap. But what about the cost of inertia, of inactivity? The non-adoption of innovative practices causes delays, causes loss of life, causes senseless spending. And I believe that this can be estimated as 80% more costly than the cost of innovation, cumulatively. So it is very important for us to overcome the cost of inactivity. And being a chemist, it's like activation energy leading us to a novel, better situation. Thank you very much. And now let's move on. Mr. Yannis? I am with the Technical University of Athens in a laboratory regarding digital innovation. We've got 4 cancer mission projects, one of which we will be coordinating. One is about diagnosis and prior to diagnosis, pancreatic cancer. We were looking into biomarkers, a very difficult task. We need to look into the infrastructure for AI, data spaces, and of course, hospitals. So when I ask my colleagues what more do they need in order to move out of the pilot stage and start implementing, they typically tell me what all startups say: we need seed money, we need money. If we have money, everything will work. We will get data down the line. And the next issue, they mention at a 50% coverage of such schemes. We see financing and grants aiming at creating data spaces for cancer that will be new. This is a 50% funding, so we will not submit our candidature there. But we see other opportunities. Horizon Europe has interesting challenges regarding the cancer mission, but also other conditions within the classical, let's call it, project. And there we have 100% financing. So a budget is important because it supports such European initiatives. Alex can say more about that. Thank you. Alex Benzenusi, business developer at Enigma Technologies. I have a technical background, but now I'm in research and innovation for the advancement of technologies. Most panelists have already praised the advantages of innovation and how innovation can be implemented in Greece in a way that is sustainable. I would like to begin by what you said, Yorgos, financing and the cost of innovation. And then I would like to move on to the framework that might be implemented as regards cancer and the Greek market. We're talking about an innovation cost and a technology cost. As a business developer, I need to point out that technology and innovation do not come with a cost. They come with a cost if they are not adopted, if they are not developed. So what does this entail? You either pay for technology when you're developing it, or you pay it multiple times over when you are the 5th, 6th, 7th to adopt this technology, or even more if you're among the latest that adopt this technology. The last. Guess who are strong players in that field and where Greece stands. We need to adopt innovation. We need to adopt technology more easily. Why do I speak of innovation at no cost? And let me be philosophical about it. First of all, let us ask ourselves, what is the cost of innovation for a person who died 5 years before penicillin was discovered. Let us discuss about the cost of technology for my grandmother who grew up without a washing machine. It's not about money, it's not about grants, it's not about developments. It's a multifaceted, multifactorial issue. As Nico said, who represents a fund, we cannot just throw money around and expect to see innovation arise. So let's look at it bottom up, or top to bottom, whatever you prefer. There are factors that need to come into play in order to have innovation, adoption of innovation from universities, clinics, and the patients. But let's start with the legislative framework, which is moving on fairly well, especially here in Greece now with Evika, say, with other players. I will go on saying that we need to have a legislative framework, otherwise money is poured down a black hole. There are researchers in Greece and a research framework which is truly amazing compared to other European member states. We get ideas, great ideas, and they are financed. They are receiving grants to be implemented. But all this needs to be framed until it reaches the patient. So this is a workflow, as IT guys used to say, tend to say. And first of all, we need to identify gaps, mistakes, errors, and work in that direction so that innovation is easily and swiftly accessible to all. Thank you very much. What do you think nowadays most hinders translation of innovation into cancer care? Is it the framework, the legislation, the culture? If you're asking me personally, all of what you mentioned. It's not just about financing. I said it before. It's about the culture, the mindset. It is about infrastructure. Now we are developing the National Registry of Cancer. We need to have access to that data. We've been shouting it from the rooftops for a year now. When researchers have access to data, any size, of any size, I'm talking institutes, scientists, this will be accelerated. And then there is also the issue of culture, in the sense that we need to develop a culture within clinical centers in favor of development of technology. We don't want the miraculous solution of AI because we discovered a problem. We want a solution for that problem. Keep it simple. So we need to identify the problem. And I will go on with what I was about to say about culture. I'm sure the rest of the panelists will touch upon all other issues. We as millennials, you as boomers, then we've got Gen Z coming on. We talk a lot about education and training of people working within the healthcare system. Because as a previous panelist said, I don't remember who it was exactly, I think it was Mr. Yosef, we cannot develop an AI grandchild to navigate a digital application. Thank you very much. Question to the gentleman next to me. Do you feel that there are changes that need to take place before we can move on? Well, in short, the issue has been raised both by myself in my first comment and my first position statement and by other panelists. What do we do about problems? We don't want to conduct research for the sake of research. We want to be next to specialists, identify actual needs and work systematically. Perhaps a national strategy on this could be helpful, in the sense of what the role of the state should be, what the role of researchers and scientists should be, what the role of the patients should be, their associations, their representatives. Of course, infrastructure is very important, but we also need to have a strategy and we also need to have a target, an objective. In oncology, we say that oncology is a notion in itself. So we need to focus on something. For example, we need to have epidemiological studies and surveys. We need to know what population we're talking about, and in our population, what are the 3 top cancer types that we will be facing in the years to come. Perhaps work more on prevention, perhaps take more into consideration personalized medicine. There are so many important factors, which is why I want to focus on 2 things. First of all, a national strategy on how we can better accomplish this shift, and of course, improved collaborations between all stakeholders. Thank you very much. Mr. Fotiadis, the floor is yours.
We've been talking about data. Are we ready to trust this ecosystem of data and use it constructively? Are we ready to trust this entire framework of partnership and patient involvement? I would say that, of course, we should always ensure data quality and identify their biases, ensure fairness, but there are 2 issues. There's something called trustworthiness, which is the property of a system, of a technology we are using, and another thing that's called trust. These are 2 separate things. So scientists, when they develop a new technology, must make sure that it is trustworthy. But this has various dimensions. This is a huge matter. Especially in IT systems, it has 7 different dimensions. But on the other hand, there is the trust issue. When you have a new technology and you give it to somebody, that person tries to see whether it can trust it and use it for its own purposes. So we have to persuade healthcare professionals and patients that they can trust the technology. For example, electric cars, e-mobility. Do we trust it? Some people, yes, that use it inside the city. I don't trust it in order to go from Athens to Yanina. At least so far. Nevertheless, it is a trustworthy technology. So, there is the level of data, which should be useful and trustworthy, quality data. Then there are the systems that should be trustworthy as well. And this is something the researcher, the developer does. But when it comes to trust, this comes afterward, after its use. These are 3 separate things. Thank you very much. We are running out of time, so I will try to go to the last part of our discussion. Very short comments on what can change, assuming that each one of you becomes the Minister of Research and Innovation. How did we call him? Research and Higher Education. Okay. What would be the one single thing that you would change? One single thing that you would change in order to accelerate implementation of tech and research in cancer? Let's start with Nikos. The comments are off the microphone. Well, I wasn't born to be a politician. I wouldn't be any good at it. But anyway, I would say that we need an agency to coordinate research, allocate budgets, and staff it with people both from Greece and abroad. There are many Greeks abroad, living abroad, that are more than willing to chip in. So to bring their know-how and their culture from abroad to move on. Now it's the right timing. There is will from the state, but we need to speed up because Europe is lagging behind, as we can all see, compared to the US and China. So no time to waste. Let's do it. Thank you. Dennis? Well, in terms of time, things that we can do now or tomorrow, we can create a one-stop shop. So a single point for approvals, contracts, safe access to registries, because right now we lose speed, not with science, but throughout this journey until we reach the end. It's very critical to simplify the entire process. And yes, it's a political thing. It's up to the minister. It's not a technical problem. There is, of course, another issue, which is again political. We need universal coverage and inclusion in the registry with all hospitals, with an annual quality reporting in order to build this trust, as Mr. Fotiadis said. And last but not least, something that will have direct impact on the patient, include clinical trials and the reporting of outcomes as part of the routine care, with administrative and support staff, which usually is non-existent in cancer hospitals. That will help patients access innovation here and now. And a last part that is actually being put into practice, we've signed a memorandum of agreement with Agios, one of the largest cancer hospitals in Greece, to implement the CCC, Comprehensive Cancer Center. So Agios is the clinical comprehensive cancer center, and the National Research Foundation is its research counterparty, let's say. So we want to reduce the time needed to go from the lab to patient. Yorgos, I think most things have already been mentioned, but I will focus on test beds. So research findings should be treated as fast tracks. We need fast tracks in order for research to become part of the system. By using financial instruments, digital solutions, we need a faster process and use the already existing structures. We have Fosprint, and we needed 6 years in order to get the 30% of the fund for its accelerator. Alex? Mr. Bamidis, I'm not a politician, so I'm going to focus on the technical part. Well, I would change the IT systems that would be of high technical specifications, that use the best IT systems of the planet and at the same time fit in the National Cancer Registry so that it can be easily used by physicians, citizens, and researchers. Well, I would first give money to ensure my re-election. But anyway, I think a Minister of Research and Technology should, first of all, appeal to critical masses and teams and direct them to specific directions. Greece on its own cannot do anything alone. Even in cancer, we need a strategic decision to do something which will be rather small, well-targeted, well-funded, having first solved problems with clinical data, clinical studies, etc. It's an easy thing to say, not easy to do. But we need one thing only about cancer. Very well. I left you, Tassos, I left you for the end. And of course, wish you all the best of luck if you do undertake this role. Well, I would say three things based on my experience and the other people's opinion. Well, a national strategy which would set priorities. The country cannot do everything. We should have a national strategy implemented by the competent ministries and the private sector. Secondly, the second thing I would do was to ensure consistent and ongoing funding for research programs, so annual periodical tenders, so that continuity is not lost, people don't leave. And the third thing to do is to focus on speed and elimination of red tape. Research requires speed. That's the problem of Europe in general. This is where we lag behind compared to the US. We have to invest much more in such fast decision-making methods to fund research when it's still state-of-the-art. A research idea is state-of-the-art when it is drafted for 5 to 6 months. If there is not a quick answer, then we lose this momentum. And there is a motto underpinning this effort: innovation for all. Innovation requires quality research, but when innovative products are developed, it is to the benefit of citizens, to the benefit of researchers which find jobs in their own country, and it is beneficial for the Greek economy. So it's relevant to the entire society. Thank you very much. Dear George, dear ELLOK, thank you for the invitation. I do hope that this discussion shed light in many things relevant to today and tomorrow. And those that need to take them into account, please do. Thank you very much, all the panelists, and all of you who listened to our discussion.
Ευχαριστούμε θερμότατα.
Thank you for this very interesting discussion. We will have a very, very short break, 10 minutes. We will be back in 10 minutes. Please be back. Let's not waste more time from the next panel.
Ξέρω ότι το διάλειμμα ήταν πολύ σύντομο, όμως ήταν κάτι και αυτό.
We know that the break was quite brief, but remembering the past couple of days, having a small break is better than having no break at all. Please resume your seats because we've got ahead of us a round table that's very, very interesting about the power of words, what it's like to speak of cancer respectfully. We are very happy to have with us the moderator, Ms. Pisti Christalidou, Chair of Win Cancer. She will be moderating this round table.
Καλημέρα και από μένα.
So, good morning. Thank you very much for your punctuality in organizing this wonderful annual conference. In Win Cancer, we, on a daily basis, come into contact with personal experiences of patients, caregivers, and very often we hear the same things, that words are not neutral. Words can be harmful, can be hurtful, and they can be empowering. So this round table is not a theoretical discussion on morality. It is an action of care, a deed of care for both patients and caregivers. And this is also corroborated by science itself. We know that words have an impact on the state of health of the patient. We know that words can lead to increased or prolonged stigma. And we know that words will shape the relationship between a patient and their treatment. And that's very important. Quite recently, September 2025, we launched a more targeted and dynamic procedure in collaboration with ELLOK. Civil society has always fought for respect both towards patients and caregivers as regards terms and words used. And we launched a wonderful effort, and today from this podium we will take this effort one step further. So I would like to invite Secretary General of Communication and Information, Mr. Kirmikiroglou, also Ms. Agatsa, first Vice Chair of the Confederation of People with Disabilities and member of the board of the Athens news agency, APE, and of course Mr. Kapatanakis. Please join me on the panel. This is the first time that the state is so close to our joint effort, the effort that we have begun regarding the power of words. We have heard Mr. Marinakis, state spokesperson, commit to that back in 2025 in September, as I said before, and the spokesperson also sent us a message for which we are grateful. But I will now give the floor to the Secretary General so that he can tell us, based on his institutional capacity, how all that has begun can stand, institutionally speaking, moving forward. Thank you very much for the honorary invitation. It's very important for me to be here among you discussing a very important topic because it is true that there is power in words. Before I take a look into institutional issues and how we as a Secretariat General can work along with other stakeholders to achieve specific results, I would like to mention some examples that I came across during my research before I came here. And I believe they reflect what we are discussing here today. I was looking for data or information on how cancer disease is linked to words. And I realized that there are important studies and surveys all coming down to one key finding, that metaphors from warfare, the victory, the battle, the struggle, operation create stigma, create fear in patients, and this is directly linked to rights and how we perceive them. So very often, words used in the fields of communication and information and awareness raising by journalists, for example, of course, this is not malevolent, but this can lead to stigma and even social exclusion and marginalization. So this is a reality that we in the Secretariat General have identified, and I am announcing today that we can move forward with a specific action targeting the eradication of this discourse. We want, therefore, to start an initiative regarding a code of ethics, let's call it that, for reasons of concision, regarding discourse around patients and towards cancer patients. There was a collaboration that started last year, and in cooperation with the Journalism and Equality Laboratory of the Pandion University that we recently entered into an MOU with, and in collaboration with Mr. Triadofilou and Ms. Agatsa and ELLOK, we will soon be able to put forth a code to be embraced, first of all, by the journalistic community, because we want anything that we suggest to be implemented as of the day after. It's not a code that should remain a theoretical paper. We want it also embraced by the academic community, because the academia is strongly influencing the drafting of this code. And of course, the patient and healthcare community. I believe that this is a recommendation that can come under the National Action Plan that has been announced by the government and which is underway, under examination, and we're moving swiftly towards implementing this vision. In the Secretariat General, our overarching vision is to not delay in addressing such issues, because we believe that there is a huge footprint, a huge impact on society, and this is why we want to stand by you in all such efforts. I was actually hoping to conclude this discussion with such a commitment on behalf of the political leadership, and I thank you for initiating this discussion with such a commitment and an engagement. Chair, Mr. Kapatanakis, we all know the importance of your role here, but I want first to address Ms. Agatsa. You have been fundamental in the launching of this effort, and in the event that we hosted back in September, you spoke, and it was very moving, and we realized that it's not just an institutional issue for you. You are a journalist, you have experienced things personally, and you have lots to say. First of all, thank you kindly for the invitation, and congratulations to all of you for the amazing work that you have been undertaking. For the past few days, very recently, I took on the role of chair in the Athens news agency, and soon I will be concluding my mandate of people with disabilities, where we have worked on terminology, because many people with disabilities are against the discourse, the journalistic discourse. For example, people with disabilities have often been described as lions fighting in the jungle. We are not lions, we are not fighting, we are people with disabilities. This was my first experience of how powerful words can be, especially in everyday living, in society, in sports. The Athenian News Agency is a very important player in journalism, and as such, we are responsible when it comes to the discourse, the rhetoric used, the narrative used, and it is true that words are powerful, and they can also bring forth negative feelings within people who are striving to come out of cancer. Cancer is no longer a disease which is immediately correlated to a negative outcome. Cancer can become a chronic disease. Cancer can become something that is treated, cured, fought against, and overcome. However, the journalistic narrative, because we are the ones to convey news, can lead to the creation of stereotypes, and this is where we need to be very, very cautious. And I would like to speak to this audience again, address this audience and say, as I said in the previous event, that I have personal experience having lost both my parents to cancer after a difficult journey. And I have also been the recipient of words and expressions when my father and then 10 years later my mother became cancer patients and struggled for a better tomorrow. So I can relate to the families of patients, and I want us, both as a journalist and as a vice chair and as the chair of a public news agencies, which is highly responsible, I want to help debunk myths, break down stereotypes, and I'm very happy that the Secretary General, Mr. Kiroglu, has made this important announcement today. We need a code of communication that needs to be communicated in terms as swiftly on as possible, and we will help in that. So we shoulder the responsibility of changing the narrative, of changing the discourse. We need to communicate that cancer is a disease that requires both attention and respect. And at the same time, there is a light at the end of the tunnel. Nowadays, finally, science has evolved to such an extent that it is possible to be cancer-free, to ensure cancer-free survival. Developments over the past decades have been tremendous. Patients are no longer doomed, but they do still require understanding and support in their journey, throughout their journey. Now, when it comes to journalistic coverage, there are some issues that journalists need to take on to tackle with empathy, understanding, and sensitivity, because ignorance very often goes hand in hand with fear, and it can lead to awkwardness when we're talking about reporting about cancer. And this is a behavior that is not right, because it isolates the person we are discussing with. It makes them discouraged at the very same point where they need to be encouraged. And being respectful of what we say means that once again we focus on the person and prioritize the person over the disease. It is a person with cancer, not a cancer patient. It is a citizen with cancer. We understand the complexity of this experience. We try to avoid generalizing or oversimplifying. And I was going to recommend that we create a code of communication, but here we have the Secretary General that has announced a very important initiative on behalf of the state. It was actually one of the demands that we voiced, the requests that we voiced in the end of our previous conference back in September. And now the floor is yours, Mr. Kapadanakis. First of all, let me thank you for a wonderful, amazing collaboration all those years. This effort that we undertook together seems to be coming close to bearing fruit. And I would like to ask you a question. As regards patients and what was mentioned in the beginning, can you confirm that words are truly powerful and that they have an impact on patients and their loved ones? First of all, thank you for being here. Let me say that this effort, which is reflected in this panel, started off with Ms. Christodoulou. Ms. Agatsa embraced it, the Minister, the Secretary General embraced it, and I am deeply thankful and grateful to all of you, and to many others. Quite often I thought to myself, why have we come to the point of utilizing words, expressions that hurt, that cause a problem, instead of helping treat a problem, face a problem, even if it's all done in the best of intentions? What is the reason behind it? And I realized that science moves much faster than stereotypes, than social beliefs, biases. Some things at some time were different. There was fear, there was terror, there was lack of treatment, there was lack of support, and this laid the foundation for an environment, for a terminology. We mentioned the term cancer patient. What is a cancer patient? What is a heart patient? A patient with a problem, an issue with their heart. What is a cancer patient? A patient suffering from cancer, some type of cancer. Some patients suffer from both. And unfortunately, even us, associations, we have adopted this. There are associations of cancer patients, because at the time when we began working, there was no true understanding. Things were completely different. We know that today, in many cases, cancer can turn out to be just a chronic disease. And the positive outcomes, I have won the fight, I am a winner, they may have made sense when they were first said, but not today. That's not the case today. I mean, is it my mistake? Did I do something wrong if I don't win? This actually creates an extra source of stress for the patient, an extra hurdle for the patient. So empathy is not about abiding by what I say. It's about understanding what the other person is saying. And that's where I need to focus on before I say anything, before I think anything. And I understand that this is very difficult, because that's the way I have learned to think. This is how my parents thought. This is, I mean, in my household, in my parents' household, the word cancer was not to be mentioned. It was a word non grata. Almost. So, these are rules that need to be shifted, that need to change. What is it that patients want? Terms, words that show care, that highlight the true state of things. The fact that a person is going through a difficult period in their time, really challenging, which might leave a scar. This, however, is lighter than the previous demonization of cancer. And I'm very happy because today is the World Cancer Day, and we have this panel here in order to shed light on the need for a more humane approach. We are all people sitting here today because of an experience, but we are optimistic. We look at life with optimism. We look at problems as problems to be solved. And we're very happy because we have the state standing by our side. We have the press standing by our side. Ms. Agatsa and the Athens News Agency, the Secretary General are here. They're honoring us with their presence here today, announcing such important steps. And I believe, my dear friend, Ms. Christodoulou, that this way we will be able to reverse, to overthrow stereotypes that have existed for a long time. It is true, because it's true that journalism helps shape new beliefs, helps overthrow stereotypes. And Yorgos, based on your experience with international stakeholders, have you noticed something similar happening abroad, or is it that finally we are doing something as pioneers? Well, there have been initiatives abroad, similar initiatives, primarily by stakeholders coming from the civil society. For example, in the UK, they have reached out to official bodies and mechanisms in order to create new forms of communication. Some things are being communicated differently, some things are talked about differently, and in this way, people hear a different narrative that does not maximize, that does not demonize, but also does not annihilate, does not neutralize completely. And I'm very happy that we have the right people at our side. So there have been 2 countries that I know of that are doing something, and they will be our allies, and I can tell you that we are among the pioneers. That's very important. It's lovely to hear. So, Ms. Agatsa, already, with your first statement, you set forth some guidelines, and it's true that as a journalist for a long time now, throughout your career, you have become familiar with what needs to be said and what needs to remain unsaid. If we started drafting this code of communication, of ethical communication today, what would be the first do and what would be the first don't? I'll give you 3 do's and 3 don'ts. We've looked at it in the Confederation of People with Disabilities, and as a journalist, this has always been an issue I was intrigued by. The first do is dignity. The first fundamental principle. Every patient has the right to be treated respectfully. Don't is bias, prejudice, and stigma. Second fundamental principle, do, reliability, trustworthiness. The information conveyed by journalists needs to be based on scientific papers that are publicized and thus allow for trustworthy information. Don't is about unconfirmed, unvalidated information conveyed. The third do, responsibility / accountability. The way media present issues should not lead to the creation of stereotypes and should not have an impact on the perceptions that can become harmful to patients and their families or their caregivers. And you can understand what the don't is in this case. Let me commit by saying that as a chairman of the news agency, the Athens News Agency, we are committing to changing the narrative, moving towards a positive direction, trying to avoid representation of issues under a negative light or with negative connotations. We need to be useful to. And I am certain that throughout the days of this conference, there will be conclusions, very, very useful conclusions that will be derived from this conference. And maybe this is the beginning of a more tight, a more fruitful, productive collaboration with you. So we're looking forward to the recommendations that will stem from this conference so that together we can trace a path towards the future. Thank you.
So we keep these 3 yeses and these 3 do's and don'ts because they will form the basis of a code of conduct. Training journalists in using a certain wording is very important. Sometimes we use words that you don't know whether they are harmful, and it's very important that training is included, the academia is included. You've both worked with the university as well. Can you please elaborate on that? Can we focus on how we can train journalists, educate them? I think that it's true that we often make mistakes in the words we use as journalists, well-intended mistakes that mean to empower patients, but they have the opposite result. You talked about phrases such as win the fight, win the war, wage a war. This creates an extra burden for patients that apart from their own disease, they must also deal with how society looks at them. So what we are doing now and what we've just announced is something very inexpensive. We have the will to do it, and it's not something that requires resources. It's about helping patients feel better about themselves. That's a first step. You, Ms. Christalidou, and let me say that, you have empowered people with your own example, acting as a role model. I knew your husband, Dimitris Chiachos. He was a dear friend of mine. When I was really young, he was a person who believed in me, and we've all lost people to cancer. And I think we all feel that we should do our part in order to avoid the mistakes made so far and open up new roads, new ways, and share the responsibility. So today, nobody should be defined through their own disease. Everybody is more than that. And this code is people-centered. And through this people-centered approach, we will stop using these only powerful words, but commit to powerful actions. So in the next meeting, hopefully, we will have something much more practical to present to you. That's all on my part. Thank you very much. Thank you. I have a last question for you, but you've already answered it. It was about your personal experience. Thank you for referring to my husband, Dimitris Chiachos. Yorgos, a few concluding remarks on your part as well. So, after today, well, when we change words, we change the way in which we look at people, and this is very important. It is much more important because fear disappears. Fear creates a huge burden, and somebody has to carry this burden on the top of the burden of the disease. Care shows that this burden is shared, so we built an environment of trust, an environment of cooperation, an environment that's friendlier from the people suffering from the disease. And we all know that it's not an easy thing to do. It's very hard for those people, all those of us that have had the experience of cancer. The role of the press is crucial. Journalists play a key role because we read articles, even we read posts, we browse through journals, we will hear something on the news, even when we are alone and we don't discuss with anyone. So all this information enters our home, our brain, our mind, and they influence us, even though this might be done unconsciously. So a commitment was made here, an announcement was made, and this is very important because I believe that through this we will help change something, we will help people with cancer. So a big thank you to both of you, to all three of you, for this tremendous effort. I think the concluding remarks should be given by you. Yes, Ms. Agati. I would like to say that even though we live in times of technological advancements, very fast technological advancement, we've all heard about AI, fact-checking, etc. These are necessary tools. But the ultimate goal and the center of all our of all our efforts should be people. People at the center. That's the title of the conference. Of course, we do need technology. It's necessary. We want to move forward, but always in a people-centered manner. When it comes to citizens with cancer, people with cancer, I would like to mention that this disease is also a burden for the entire family, and we should also take care of the families. That's a key message I wanted to share, and thank you. Thank you as well. We've managed to save 10 minutes, Maria, for you, for the rest of the conference. So let's keep the power of words, but let's focus on the power of actions as well. And let's not forget the families, not focus only on patients. Yorgos, this was another victory by ELLOK. Thank you all for your attention.
Ευχαριστούμε θερμότατα.
A warm thanks for your remarks, for this major announcement, and for saving us time, dear moderator. And now we can go straight away to the next panel, which focuses on brain tumors. Please welcome on stage Mr. Kostas Athanasakis, Assistant Professor of Health Economics and HTI at the University of Western Attica, who will be the moderator of this panel. Thank you for the invitation. Allow me to invite the panelists on stage. Mr. Helen Bulbeck, Ms. Evangelia Razi, Mr. Konstantinos Foudas, Mr. Trifon Alexiadis, Ms. Maria Dzima. So this discussion in this round table will focus on brain tumors. I'm very happy that this topic entered the agenda of the conference on the initiative of George Kapetanakis, who saw this need to discuss this topic. And I concur. There is this need as a research team, and based on the study we've conducted, although the results are not published yet, but let me share with you that in the last period, we've undertaken a study focusing on glioma, one of the types of brain tumors, not in the clinical perspective, but on the perspective of how people that have this diagnosis can navigate in the system. And we realized things that we can generalize to all brain tumors, especially in relation to younger generations. There is difficulty in getting a diagnosis due to the low level of information of both patients and healthcare professionals. There are major navigational difficulties, especially highlighting the role of navigators in the system and the role of information dissemination. And since we've been talking about people that are young, they are in productive age, So there are issues related to their reintegration in the workplace. So society is losing people, but if we introduce the right policies, we can stop this problem, stop losing workforce. This discussion can be rather helpful. It can help starting to realize and talk about the importance of this topic, start talking about how important policies are and the difference they can make. And of course, we should be able to listen to all perspectives by all stakeholders. This roundtable is well represented. Let's start with Ellen, who has a major advocacy experience when it comes to brain tumors. So I will ask my question in Greek, and we will translate it for Helen. Can you share with us your opinion on this topic? I'm talking about awareness raising around brain tumors, and what can civil society do in a dialogue with the health system in order to raise awareness, to build knowledge, and develop policies? Please, Helen.
Thank you for inviting me here. It's wonderful to be at such a conference that puts the patient at the centre. And if you'll forgive me, I'm going to start with telling you a story about a patient I'm currently supporting. My journey with brain cancer started 20 years ago when my daughter was diagnosed with a brain tumour, and then I got head and neck cancer, so I will need to keep drinking. And we're both survivors. And that's what set me on this trajectory. So every day I'm working with patients and their caregivers who are living with brain tumours. And I want to talk to you about Andrew, who's 42. He's been diagnosed with a glioblastoma. He's probably, with treatment, got about 9 to 12 months to live. He's recently divorced from his wife. He's got 2 teenage children. He's lost his job because he's lost his driving license. He's a man's man. He was a carpenter. His problems are existential. He's got the pressure of teleological time, the sense that time is running out. He's got the knowledge that he's going to have progressive neurological and neurocognitive disease. He's got a high symptom burden with epilepsy. He's got no income. At the moment, he's sofa surfing, so he's sleeping on sofas in his friend's house. He can't host his 2 children, so the time he's got left, the quality of life that he's going to have with his children is very limited. And he lives in a permanent heightened state of emotion. He feels guilty, he feels angry, he feels sad, and he feels fearful. And when you look at the patient pathway, every single interaction he'll have in hospital is about his treatment. Or he'll be filling in a holistic needs assessment or a quality of life assessment, and all that does is reinforce what he can no longer do. So we've got a very low baseline that we have to start from with brain cancer. In the UK, it's an auspicious day today. It's the World Cancer Day, but we've also just launched the National Cancer Plan. But survival outcomes for brain tumours are the poorest in Europe for all countries, and actually the UK comes below Croatia and Romania. So we are starting from a very low base, and we've got a lot of work to do. We've had historic underfunding of brain tumour research, despite the recognition that brain cancer is a cancer of unmet need, and that's partly because we've got low cohorts of patients. There are over 140 different types of brain tumours, so trying to get patients, the large enough cohorts to get them into trials is really hard. The brain too is a privileged site. You can't just hack away at it to remove the tumour. And then you might have trials, but until we get genomic sequencing done as routine, it's very hard to find the targets. We have an absence of national awareness campaigns. Symptoms, as you said, are very vague. Public awareness is low. We find too that there's a lot of emphasis on early diagnosis. We would prefer to see prompt diagnosis. What's the point in being diagnosed earlier with a life-limiting disease if you're not going to change the outcome? And then we've got the low-grade gliomas. So these are always at risk of exclusion. They're the indolently malignant ones. They will always become malignant, usually within 5 to 7 years of first presentation. And as you've commented, they tend to hit the younger generation. So these will be people in their 20s and their 30s when they've got high responsibility, probably financial responsibilities. They've got mortgages, they've got good jobs, they've got small children. And then prioritizing of brain tumours within cancer-specific quality standards as well is absolutely key. And I think that the patient-reported outcome measures, if you think about what Andrew's suffering and what he's living with, the patient-reported outcome measures that we report on aren't really relevant to Andrew at all. He's got very existential needs that are not being met. So I think for rare and less common cancers, brain cancer is a less common as opposed to rare. You need to place it firmly as a priority, as a national priority. And I'm really pleased today to see that in our cancer plan, although there's a lot missing for brain tumours, we are going to have a new national lead for rarer cancers, and also an emphasis on breaking down the barriers for commercial industry to invest more in brain tumour research. Is that the kind of answer you were looking for?
Yes, absolutely. I think it's the first kind of material to start off a discussion towards organizing an effort for advocating for brain cancers, but also, and I know you've worked extensively on this, on practices such as bringing closer the patients with their physicians and sharing decision-making. Do you see any ground on this going on?
So we have, I led the National Vanguard on Shared Decision-Making Neuro-Oncology with Paul Grundy. And we see increasingly that the people are going in at a level playing field. We support patients and caregivers before their consultations, so what would be a good outcome? What is the information you want to ask of your consultant? And we're finding that due to shared decision-making, patients are going into the consultation room much better informed and much better to have an equal conversation with their clinicians and more confident about expressing what their context is, what their values are, and what their appetite for risk is. And that's different for everybody. But increasingly we see the conversation just reduced to, it's called the COD. So these are your choices, these are your options, what's your decision? And it's not a genuine shared decision-making conversation because they take time. But it's going to take a long time to get those kinds of conversations in the DNA of any public health system. But patients and caregivers have a role to play. They need to be educated just as much as the clinical team in how to have those discussions.
I couldn't agree more. Thank you very much. Κυρία Ζή, έχετε...
Mrs. Zini, you have a lot of clinical experience. How do you think that Greece is doing? Which are our advantages, disadvantages, how we can move forward? We are a small country with a few brain cancer cases yearly, and of course that creates extra difficulties on the state level, meaning that we focus more on more common diseases, so to say. There is less awareness raising in the media when it comes to the symptoms that may lead to such a diagnosis. And I have a lot of patients that they receive a late diagnosis because before doing an MRI, they send them to do other tests, even if their symptoms do not fit, let's say, with multiple sclerosis. So one problem is the less awareness raising within the neurological community itself, because in Europe, most neuro-oncological patients start with a neurologist and they stay with a neurologist or with a pathologist oncologist focusing on neuro-oncology. So for the one part, we should keep training neuro-oncologists in Greece, and I now discuss with Mr. Stefanis, a professor of neurology, when it comes to that issue. Our second problem is that our pathologists are not very good, if I may say so, in those kinds of diagnoses, and this is a huge problem, a huge problem. We don't run the main tests, the basic tests, when it comes to brain tumors in centers, and on the contrary, neurosurgeons are wonderful. Neurosurgeons in Greece are of a very high level. I'm not saying that our pathologists are not good. However, when it comes to neuropathology, we're not doing that good because they have not been trained, we haven't been focusing, it's not a priority. So, in my opinion, the solution that I see is that we should have centers of referral. Internationally, everyone agrees that brain tumors are not tumors that should be faced in every small hospital in the region. There should be a number of cases in order for that physician to have experience, to gain experience to face, to tackle this tumor. It is not bad to refer your patient to a more specialized physician in order to receive the best possible care that they can. Now, since right now, when it comes to pathologists, we don't have a center focusing on brain tumors in the state public healthcare system. We don't have a public hospital focusing on brain tumors. My opinion is that we should establish one, we should build one. There are some oncologists both in Athens and Thessaloniki that focus on those cases, and they should have the opportunity to focus more. For example, I love this area, but I work for the private healthcare system, and patients cannot always pay for private healthcare. They don't have the financial means. Therefore, we should focus, and I am willing to contribute into training neurologists and pathologists alike in 1 or 2 hospitals in Thessaloniki and Athens alike. Why not in Crete, because there are a lot of cases there, in order to be able to serve the needs. We need 3 or 4 centers maximum, and patients should be referred there in those specialized centers. We cannot send patients with brain tumors whenever. I agree with you. There are... Kindly keep the microphone. So, specialized cancer care needs specialized structures. So, in this standard of care, that it is evidence-based and scientifically proven, how can we safeguard that there will be a continuity of care for those patients? And how can we ensure that those centers will have communication with the other levels of healthcare, the primary and the secondary? Yes, neuro-oncological patients cannot travel. You are right. So we should have those centers of referral, that patients should be referred after their surgery, because we have a lot of good neurosurgeons, as we have said. Then the follow-up is a problem, so to say. They should be referred to those centers. The pathological assessment should be done in the best possible way, and then a treatment plan should be proposed there. And chemo and radiology, maybe those treatments should start over there in those referral centers, and then in collaboration with physicians in their place of living, then they should finish their treatments. They cannot undergo chemo or radio treatment everywhere. I agree with you.
Mr. Foudas, how do you see the topic of brain tumors? Would you like to discuss with us whether there is an early diagnosis or a late diagnosis usually? Or we can talk about continuity of care. You are providing specialized care, and you should be able to follow up on these patients or ensure the continuity of care in their place of residence, because traveling for them is very difficult. First of all, I would like to thank you for your kind invitation and congratulate you for this exceptional initiative to talk about this topic, because it's a topic quite often neglected. before talking about how we treat these patients, it's true that patients with brain glioma, yes, their number is not that big, but as Helen said, they experience the diagnosis in a very specific way. It's a very sudden diagnosis. It changes their life radically. We have characteristics examples of people who start in the morning to go to their work using the metro. They have an epileptic crisis and they just find out that they have brain tumor. So this major change in their lives makes this person very difficult to handle. And I have possibly the most awkward role because I am the one who is... patients are afraid of me because when they come to me, they may have their diagnosis and their fear, you can see the fear in their eyes. First of all, because they have to undergo surgery. This surgery intervenes with an organ which is valuable because it determines their way of thinking, their behavior, their reactions. And they are not okay with this, of course. And it is a surgery they are not that familiar with. They don't know a lot about it. So what we're doing today is very important. And it is also equally important to say that there have been steps forward. And surgery has progressed a lot in the past 5 to 10 years. We're better surgeons today. Are we better surgeons today? No. We became smarter because technology moved forward. We are now smarter because we have neuroradiologists that allows us to have a more accurate, precise diagnosis. We became smarter because technology allows us now to be very precise and personalize our treatment. We became smarter because our colleagues, radiologists, oncologists, they can now be more precise and we can safely now, more safely treat these patients. We've taken large steps forward. When I came back from the US and started exercising neurosurgery in the University of Thessaly, in the hospital university, it seemed ridiculous to have a person undergoing surgery without harming key brain functions. Now, it is a standard practice. It's what's happening in most hospitals around the country. And that's huge progress, in my opinion. Do these people live longer? Yes. But most importantly, they live better. Their quality of life is something that in the past 10 years has been a concern for people with such brain tumors, and this demonstrates the progress made. It's very important. What you said is very important. But I want to ask you a question about such progress. Is this progress uniform, or do we need further standardization? The centers that exist now, or the centers that should be established, how can we assure that the same level of care, standard of care, is provided in all of them? It's precisely what Ms. Razi said. We need centers of reference in order to abide by high standards. And the treatment of these patients, whether we like it or not, should be holistic. You cannot undergo surgery and then start an odyssey and go to Athens in the private hospital where Ms. Razi works, then take the drug, go to Evangelismos Hospital for the pathologist's report, and then go to a different radiologist for the radiation therapy. That's an entire agony for not only for the patient but for the family as well. We want reference centers. How many? I don't know that. Once our healthcare center is restructured, we will find out. I don't want to be I want to be honest with you. We need to restructure the map of healthcare and then designate reference centers that will be very good, equal to those abroad. We have people, we have expertise, we lack organization right now. What you said about this odyssey, this agony, this is indeed reflected in our study. And we all agree with that, with the establishment of reference centers and the establishment of certain standards for the level of care. I know that in Greece we don't like metrics very well in the healthcare system, and that's possibly a source of non-efficiencies. But I think it's something that we should start doing. And now, the floor to you, Mr. Alexiadis. Can you give us your perspective? What are the policy gaps in the healthcare system? What are the steps to be taken in order to improve care? Thank you for the invitation. Congratulations to ELLOK and its president and everybody organizing similar conferences. It is a quality conference with a variety of topics treated, and maybe you should expand it over more days. The material treated here is very important, and it needs to reach the right ears. I'm not going to talk as a physician. I'm going to talk as a patient with a brain tumor for the past 6 years. It appeared suddenly, luckily, thanks to my trust to Greek physicians, headed by Ms. Razi. She has been my treating physician for 6 years now, so I have a good quality of life, and I have a lot of factors in my life that help me along, such as my faith, my grandchildren. I talk publicly about this matter because all of us who have access to publicity, all of us who have been politicians in the past, we have to be open about it, to persuade people that it's not the end of life when you encounter cancer, especially a brain tumor. It is yet another fight. And I do believe that the state has taken steps forward. Many more need to be taken. Similar recommendations have already been submitted in this conference. In my opinion, the state should eliminate any red tape and paper-related process related to cancer care. You don't have to go through 3 guichets in order to get your papers when you are trying to get your treatment. Everything can be solved digitally now, I think. Also, the money we spend, all of us who have cancer, they should be deducted from our income and not taxed. Because right now, they are not deducted. We are taxed for this income that we do receive and we paid in order to manage our disease. And a concluding remark, I was happy to hear about all these developments with databases, registries, etc. But when it comes to cancer patients, we need speed. Cancer patients have a particular relationship with time. They're running out of time. So we need fast collection of digital data. Thank you very much. Let's continue on a topic that I know that has been of major concern to you.
Apart from these 3 points on which I believe we all agree, can you please share with us a few thoughts about cancer and the workplace and labor, employment? Should there be any policy change so that people that face cancer, mainly younger people, how can we help them with their employment? A few days ago, there was the publication of the OECD report for the state of cancer in Europe. There is a chapter dedicated to the distance in Europe between the percentage of people that live with the disease and those that work even though they have the disease. Unfortunately, in Greece, we are ranking very low. There is a very low percentage of people who could work, but they are not in work. And this demonstrates the gaps of the healthcare system and of the employment system. Well, the state must take care of that, starting from very simple issues. For having a parking spot for a person who goes to visit a public service and is a cancer patient, or procedural issues need to be taken care of. There is room for improvement for policy making, and I do hope to move forward with them. Also, I'm still working as a politician in the political party I used to be. Well, everybody had doubts in the beginning. They thought that I might be getting dumber because of the brain surgery. Now they're convinced that this is not true. My wife is the only one who believes that I'm saying silly things. Anyway, this is a fight that we're going to give. The state can indeed help from very simple issues to rather complex ones.
So when it comes to working patients with brain tumors, there are two cases. The people who want to work and they should work, and we should facilitate them in order to keep working, because as we've said earlier, there are a lot of young adults and teenagers that suffer from brain tumors, and usually those people, they have a good prognosis. When someone is young with a brain tumor, they have high possibility to continue living, and they should be facilitated to work a normal life with a family, with a job. An example is that nobody ever asks them if they want to save sperm in order to have children on a later stage. One should bear that in mind. This is one group of people that want and should work, and the state should help them work. So the other side of the coin are the people that become incapable of doing their job, because when your job is to drive a truck, a lorry, and you will have brain tumor, at least for one period of time you won't be able to work, and they should be informed about their rights. For example, to get a disability funding, and the state should support them accordingly, not only them but also their families. So those tumors change not only the patient's but also the family's life in a very drastic way. So it is necessary for the state to help them in order for that human being to continue live their life, and why not be productive, at least to live a good life. And it is also a matter of social corporate responsibility that should also be included in the conversation, because as we all understand, the demographic development of the country does not allow for people that can work, and we do not facilitate them to work. This is a double loss for the country, if I'm allowed to say so. So, it is very important for us to give voice to the organized voice of patients. So we should also raise awareness and motivate the people and the system. First of all, I would like to thank you. I would like to thank you on behalf of the BOD of ELLOK for being here today. I had the chance this year to visit Rome for a conference for patients advocacy in brain tumors, and we understood in ELLOK that there is a gap in Greece, and this is why we have organized this table, this round table, this panel. Of course, this is a very burdening disease, a very difficult disease, but I would also like to talk about the secondary tumors, the brain metastasis, because I represent an association in Yanina. Most of the patients that have a tumor in the lungs or in the brain, they may suffer from a metastatic cancer. Believe me, because I have noted down the patient's problems. Those people do also have all the cognitive and neurological effects of the other brain tumors. So they have good days, they have bad days, and they don't. Their path is not linear, because they have to face something new each day. My dear friend, she died from breast cancer, and when she suffered from a metastatic tumor in the brain, her physician, her only one oncologist, he didn't have the luxury of time to focus on her. So if you allow me, I would like to talk about the psychological effects of the disease. And also I want to talk about the caregivers. We have a patient and a physician, a treating physician in this roundtable. This is something wonderful. Let me say that brain tumors, they play a very important role in the person's identity, because they affect a lot of executional functions, meaning that the patient may lose its emotional regulation, its linguistic skills, and even more for the patients that are metastatic and they have undergone hormone replacement therapy. I don't know if this is a kind of comorbidity, how do we call it today? Nevertheless, the daily life of those patients is extremely difficult. So, both those categories with primary cancer and secondary cancer, when it comes to the primary brain tumors, those patients, of course, have faced a very difficult diagnosis with a very difficult journey. So let us introduce new treatments, molecular treatment, for example, that changes the treatment plan. And they need regular imaging controls. So the clinical course is something that could be improved with the referral centers, but we shouldn't forget the social path and the mental path of those, and the mental health of those patients, as well as the social isolation. So, in my opinion, there should be a series of political interventions in order to take care not only the patients but also the caregivers. There is a need for an interdisciplinary specialized care, but also at the same time for psychological support with structured programs for patients and caregivers alike. Access to clinical trials, we know that this is a more restricted pool. And we know that the geographical inequalities in Greece does not allow a lot of patients to have access to clinical trials or to hospitals or to care. So equal access is also very important. Patients that live in islands, they should also have access to molecular biology to know that those tests may change the way that their treatment is selected. Of course, there are a lot of researchers, research centers, physicians, excellent physicians. However, the voice of patients is very important in order to put pressure to the government to participate in international networks of research. There is an effort now with the National Cancer Registry. You know it better than me that if something is not measurable, cannot be organized or faced. The voice of patients is very important because experience is not something subjective. Experience is knowledge, and it is a scientific tool. So in an ideal environment with referral centers, an early and prompt diagnosis, if the experience should be scientifically and centrally organized, and I'm sure that patients' organization can help towards this direction with the questionnaires that we give to the patients, then the outcomes would be better and more structured. So, patients should have more access. The access to the new treatments should be more transparent, but also the information, the language of the information should be more understandable, and they should also be allowed to participate in the decision making. And how difficult is this when there are no oncology councils in the hospitals in the region? Let me conclude. So, the services provided should take into consideration the mental and the cognitive burden of those kinds of patients, and we should go towards a new standard of care. ELLOK believes that hope is not something vague, but it is something that we can build with systematic work by all the stakeholders. Thank you very much. Thank you. Thank you.
Thank you all for your interventions. I think it was an exceptional roundtable. Thank you, ELLOK, for giving us the opportunity to see multiple perspectives in this topic. I think it was a good table that gives food for thought. That's the end of the roundtable, but not the discussion. It's just begun. So I think progress will be made in the period to come. Thank you. We would like to thank our speakers. Let's go to our next table about another important type of cancer, ovarian cancer. And I would like
to give the floor to Mr. Alexandros Drodolakis, Professor of Gynecologic Oncology at the Athens University and Coordinating Director of the EASO Center for Gynecologic Oncology. He will be the moderator of the next panel.
Σας χαιρετούμε και σήμερα θα αφιερώσουμε λίγο χρόνο στη...
Today we will spend a little bit of time to talking about ovarian cancer. Ovarian cancer is a disease, a bad cancer in fact, with the largest number of deaths compared to other gynecologic cancers. It is a type of cancer which unfortunately is not diagnosed at an early stage. There is no primary prevention and secondary prevention as well. It cannot be diagnosed early. There are not proven screening methods, so most women with ovarian cancer are diagnosed at an advanced stage, 70 to 75% at the stage 3 or 4. And this is one of the reasons why it is difficult to treat this disease in combination with the aggressiveness of these type of tumors. The treatment of ovarian cancer is something which requires a multifactorial approach. Usually, it has spread, and we need a double treatment. We need surgical treatment, of course, at the beginning and maybe later as well, and then systematic treatment. Treating ovarian cancer is a very challenging treatment. It requires aggressive surgeries to remove the tumor from all the focal points, and then, of course, we need chemo, systematic chemo. In this context, many factors play a role. It's a chronic disease in which new data should be taken into account. Molecular analysis and classification of these tumors,
genetic data, genetic predisposition, and consulting in some cases for a small part of these gynecologic cancers, and also a systematic handling by all healthcare providers that are involved in the treatment of these women. As you can all understand, treating ovarian cancer is a very specialized type of cancer. This is why we need reference centers where surgical intervention and systematic chemo treatment following the surgery can take place. And then, of course, genetic consulting and molecular analysis. All these things should be done in these reference centers. We have to link clinical research with the treatment of this difficult type of cancer. We have to take care of these women, and this is a major need. We want to better contribute to the treatment of these women. We want to help them survive this exhausting cancer. I would like to welcome and give the floor to Floridia Fostira, a clinical lab geneticist, to share with us a few thoughts about the contribution of genetics in the treatment of these cancers. Hello. This is a very good opportunity to discuss this very challenging topic. Your introduction was exceptional. You set the framework. This is a very difficult type of cancer. It's difficult to get diagnosed, and there are many challenges for patients. For us, geneticists, ovarian cancer is very interesting genetically for us. About 1 out of 4 women that are diagnosed with ovarian cancer have some kind of genetic background, and this is very valuable for reasons of prognosis, for reasons of treatments, and for the family as well. And in the past 10 years, we've been able to molecularly designate this type of cancer in order to provide targeted treatment and increase survival. So in my opinion, this very nice center of reference Mr. Rodoulakis talked about should indeed be established, as well as cooperation between geneticists, molecular biologists, and clinical physicians. This is needed in this type of cancer. And if this is achieved, it will be easier to identify women that could benefit from more targeted therapies. Today, I have the pleasure to share with you something very important. The professor said that it's difficult to have an early diagnosis. Let me tell you that since last September, we are able to explore possible and test biomarkers that could help have an earlier diagnosis. It is an EU project, Cancer Mission, and ELLOK is part of the Cancer Mission effort. as well as the Alexandra Hospital. And in the next 3 to 4 years, thanks to this project, we may be able indeed to early detect ovarian cancer, both in women that have that are more prone to it because of family and genetic reasons, and other women as well. So that's an optimistic message.
Thank you very much, Mrs. Fostira. Now, I would like to ask Mr. Yorgos Kapecios to talk about the molecular footprint of the disease and how we can contribute into the better treatment. I would like to thank ELLOK and congratulate it for the organization of this conference. Of course, most patients with ovarian cancer will receive the diagnosis in a metastatic stage. The contribution of molecular biology will help into the early diagnosis within the years to come. There are some trials for testing based on the analysis of the molecular biology, even in patients without symptoms, the so-called liquid biology, where we might find some signals of existing cancer without any symptoms. So during the last years, research has changed radically the way that we understand ovarian cancer. This is not it is not faced as a singular entity, but we have different histotypes, and each of them has a different treatment. And since we're talking about precision medicine, laboratories should also be very precise in the testing that they conduct. The protocols should be detailed, ratified, and should be easily reproduced, because the result will lead the treating physician to prescribe a specific drug. We should be certain that the whole procedure follows ISO standards that safeguard that the result and the drug is given to the right patient at the right time. That will have the best possible benefit based on specific biomarkers. So biomarkers, we have a lot during the last years, and now based on the biomarkers, we have new drugs, the so-called ADCs, that combine targeted treatments with chemotherapy. And even if they are innovative drugs, and the labs in Greece can do those tests and the drug can be prescribed, the problem is that biomarker, the test of the biomarker, is not reimbursable. So yes, theoretically, a patient may receive a targeted treatment, but in cases that we should do a molecular analysis, the patient cannot pay that test out of their pockets since it is not reimbursed. We are waiting for a lot of new biomarkers to be reimbursed, ovarian cancer included, biomarkers for ovarian cancer. And clinicians should be able to prescribe those tests, because the more people that will get this testing, the more people will be able to receive the best possible drug that will allow them to have better outcomes and allow them to live longer. As Mrs. Fostira said earlier, we shouldn't forget genetic testing, because usually ovarian cancer is due to hereditary reasons. The epithelial carcinoma, there is a test for epithelial carcinoma that can be partly reimbursed for gene sequencing. And this is very important not only for the patient herself, that might change the treatment with some drugs or may receive some other prophylactic treatments such as to remove her tubes, but in order to inform the family, because by having that information in the future, they may state the status of their screening for various types of cancer. Because, truth be told, the better treatment is the prognosis, the prevention. The earlier the stage of the cancer, the better the life of the patient. Thank you very much. So we understand that managing a disease such as ovarian cancer is a big challenge right now for modern gynecological oncology, since this is a very aggressive cancer. And of course, all those factors that we have mentioned should be taken into consideration. We have cases of hereditary ovarian cancer. We should try to understand the histotypes and the subtypes of those cancers in order to propose specific drugs and improve their prognosis. But last but not least, we should strive for a coordinated effort to manage those types of tumors at referral centers when the disease should be treated holistically, because until now the disease was managed in a fragmented way, and right now internationally ovarian cancer is managed in the so-called centers of excellence that have the knowledge to manage it on a surgical level, but also to manage it, meaning to receive targeted continuous treatment. Those centers can also manage the recurrence of the disease, and of course to try and include all those patients in clinical trials, since this might be the only way to manage some kinds of those patients. So research in combination with clinical trial and a better standard of care, because patients with ovarian cancer are chronic patients and they need various interventions during the progress of that disease. This cancer has a lot of recurrences. Thank you very much for everything that you have told us. I want to ask 2 or 3 questions. First of all, how can we manage an early diagnosis? Can we do a structured effort in order to have an earlier diagnosis? And that population should be limited in Greece. I'm talking about the patients with a genetic predisposition. Not only a genetic predisposition, I'm talking about patients with ovarian cancer. The number is limited compared to other kinds of cancer. Do they have access right now, access to contemporary treatments? Thank you for this question. Unfortunately, when it comes to ovarian cancer, we don't have a primary and secondary prevention. All the methods that have been tested in order to detect the disease in an early stage have failed. It will not have any early signs that would allow women to go to the doctor. Even the even with the ultrasound, is not always the case for the early diagnosis. And it is usually diagnosed in stage 3 or 4 in the 70% of patients. And that, of course, is an inherent difficulty in its management, because the later the stage, the worse the prognosis, but the management also is more difficult. This is the big problem, the later diagnosis. Now, when it comes to the percentage of the hereditary cancer, Mrs. Fostira can answer it. This is a very good question, because the genetic testing can allow us to work on prevention, because even if the MRI and the ultrasound cannot allow us to safely promise a woman that she will detect it early, genetic testing allows us to recognize women that have an increased possibility due to a faulty gene, and through this identification to allow those women through a safe process, after completing their family planning, to remove their tubes and remove their ovaries, especially in ages after 40 and 45 years old. So if we want to talk about prevention for this high-risk group, is a surgical intervention. Women that remove the fallopian tubes, some of those women have cancer in the tubes of stage 1. Something else that has been tested, and there are 2 or 3 studies about this issue, is to do this intervention in 2 stages. First stage, to remove the fallopian tubes in order to allow that woman to have the monthly cycle, and later on to remove the ovaries at the later stage near the menopause. How safe it is, we cannot know yet, but it respects the biology of women, because we know that the majority of ovarian cancer starts from the fallopian tubes, and this is why we have chosen this method. Which is the percentage, Mrs. Fostira, that there might be a genetic consulting in the totality of women with ovarian cancer based on the, let's say that 7 or 8% of those women have hereditary cancer? No, the percentage is higher. Out of 1,000 women without any screening criteria, we found 24% with women with genes, not only the very well-known the BRCA genes, but also more genes. So 1 out of 4 women seems to have some genetic predisposition. This is a large percentage, but those women do not have the same clinical impact. Yes. And when it comes to molecular classification, because if we do both molecular and genetic testing, then we will find that 50% of those women have some kind of marker that will allow us to propose a better treatment to that patient. So all women that are diagnosed with ovarian cancer, in your opinion, should undergo genetic testing and molecular analysis? Yes. correct. Right now, the state reimburses only the gene testing and not the molecular analysis, even if there is a clear indication that this is something relevant. And of course, new biomarkers are reimbursed every day, and it is very important to allow patients to have access to those kinds of tests, to biomarkers, in order to propose the best possible medicine. This is a rather oxymoron. A drug may have a monthly cost of 3,000–4,000 euros, and the laboratory test costs 800–900 euros. So how can we give access to such a costly drug without having given access to a more affordable testing, so to say? Genetic and molecular analysis used to be a luxury for women with ovarian cancer, and only in very specific cases with a strong family history we could propose that. However, nowadays things have changed, and genetic testing and molecular analysis are necessary because they are part of the treatment, they are part of the plan in various stages, not only in the primary intervention, but also in cases of relapse and recurrence. However, those women should be sent to excellent centers, as we have said, and from the first time of the diagnosis, from the primary diagnosis until the primary treatment of the disease, since for the ovarian cancer, the primary treatment of the disease is very important when it comes to her survival. Not only the correct surgical procedure, but also the primary systematic treatment. It has been proven that all those interventions play a different role. The treatment of a patient that is informed by biomarker testing and genetic testing is far more better, because it will allow that patient to have a better quality of life and a longer survival. So the referral of the patients to centers of excellence is a sine qua non condition nowadays for the people that face this chronic and difficult disease. I don't know if we have any other questions.
Let me ask one more question. This shows that in this population of women, we need to act quickly. We need to meet their needs of this sensitive population. So do we have access to the right treatments for this, population? And second question, do we need further support? Are there any psychological needs that need to be met for this particular population? This population group is not lucky, so they have to be diagnosed at an advanced stage, where you're absolutely right. So when these women are treated in centers of excellence, all these support services are provided as well. Internationally, globally, in Europe, the European Society of Gynecologic Oncology allows and recommends that ovarian cancer is treated only in centers of excellence. And I'm not talking only about the surgery, but the systematic treatment as well, and all the other interventions that you mentioned as well. Because this is the only way to provide quality of life and better survival. There are centers of excellence in Greece right now. There are recognized centers of excellence for ovarian cancer in the Alexandra Hospital, in Papageorgiou Hospital in Thessaloniki. So fewer and fewer cases are treated in a fragmented manner in centers that are not recognized as centers of excellence. That's the only way to allow women to participate in clinical trials, to be enrolled in clinical trials, to receive molecular tests, to be administered genetic analysis, and a treatment that will help them with their survival. Thank you.
Νομίζω ότι ολοκληρώσαμε την...
Αν θέλετε κάποιο συμπερασματικό σχόλιο.
If there is no other question or any other comment, let's conclude the round table. Thank you very much.
Ευχαριστούμε πολύ και ήρθε...
Thank you very much. It's time for lunch.
Καλησπέρα σας.
Hello. Hello, please be seated in order to resume with the next panel. Dear Minister, welcome. Now, we will continue to the next roundtable titled Transforming Hospital Care. So I would like to give the floor to the moderator, Mrs. Dimitra Efthimiadou, a health journalist, in order to moderate this panel. Hello everyone, my name is Dimitra Efthimiadou. I'm a health journalist for a lot of years. So without further ado, I would like to invite here my co-panelists in this roundtable titled Transforming Hospital Care. Cancer patients end up in hospitals, and there, dear Minister, I think that we need your support. Mr. Marios Themistokleous, the Deputy Minister for Health, So, Mrs. Olga Balauras is the governor of the first health region. I think you're the only governor, woman governor in the health regions. Mr. Dimitris Tsalikakis, he is the governor of the third health region. He is also an associate professor at the University of Western Macedonia. No? The president of the Association of Pathologist Oncologists, Mr. Michalis Saloustros, he is participating in this panel remotely online. Professor Aristotelis Bamnias at the National Capital University of Athens. Welcome, Professor, and Mrs. Irini Throuvala. She is a nurse. She is a specialized nurse for cancer. She is experienced in the system from within. She works at the hospital Elena, so we welcome her to share her knowledge and her experience as well as the problems of the patients. Because, dear Minister, I think that the problems are a lot. Despite the fact that you say that the national healthcare system is changing, we want even more. We want to improve our daily life. Reference is made to how things are going to change when it comes to cancer. The minister mentioned yesterday the National Cancer Action Plan. 20 years ago, we had the so-called National Action Plans of the previous minister, and they have never been implemented. So, dear Minister, is this action plan going to be implemented? Are we going to see changes to the hospitals or not? How are we going to organize it? Please, your first remark, your first comment. Thank you very much for this kind invitation. Thank you for inviting me along with Mrs. Efthimiadou, because she always, I'm always on my best behavior when I'm together with her. So, before speaking about the National Cancer Action Plan, let's discuss about what has been the changes in the hospitals. There are some things that will change shortly. Buildings, new buildings and some other changes, and then we will also do more as needed. Right now, we have improved accessibility in hospitals. In the European Commission, I mentioned that right now, patients in Attica, when it comes to the 8 cancer hospitals, can find appointment with a pathologist oncologist and also medical oncologists in 4 days in Agiosavas or 5 days, shortly. This is a big change, a great change that was not the case in the previous period. Mr. Pisakas is here with us. We have discussed many times the problems when it comes to radiology, radio treatment. And of course, the donation of Stavros Niarchos changed the delays. Right now, we have bought new machines, such as the new machine for radiology in Rio Ontario and in Lamia Hospital and also in the Soteria Hospital. Those machines will let us get closer to the European average when it comes to the delays. For the first time in Greece, the delays are monitored. Those are the hard indexes when you want to monitor cancer care. So those new machines that we have bought will allow us to decrease the delays. Right now, access to radiotherapy is more or less 60 days, because right now the allocation is not equal to all hospitals. So when it comes to chemo and radiotherapy, now the time of the delay will be shorter. And the third big change is the digital oncological councils. The system has been delivered, and the great difficulty that we have is to adopt it by physicians, by healthcare professionals, in order for things to get better. Of course, we support the short-term hospitalization units. Right now, we prepare the new Kourkoulos unit in Rio, and in 8 months, more or less, the building in Leophora Alexandras with the donation by the Dimitra Katsafadou will be ready. And in 12 months, the new Cancer Hospital of Thessaloniki will also be ready. So in your second round, I have more questions about digitalization of the health records, because it seems that there is a big problem in hospitals that are funded by the RRF. The electronic cancer health record has been delivered, and now I would like to give the floor to Mrs. Balaura. She is the governor for the first health region in Athens, and knows which is the case in the hospitals. The difficulty is mainly the access of patients to the healthcare system. Let's say that we have a patient who lives in the regions, because I understand that we need a total reform of the healthcare system. How can this patient understand that they have to go to Agios or to choose between Agios and Metaxa Hospital. What about this path? Have you designed this path? Thank you very much. Thank you for inviting me here today on the World Cancer Day. Thank you for that question. As the Minister have said, we have already improved the access of patients to hospitals. This was a great achievement, and we can measure things right now. We know the times that a patient needs until they can come to a hospital. This is a very serious institutional change. In the hospitals of the First Health Region, there is a huge volume of people from the Peloponnese, from Central Greece, and from Thessaly. What we should do is that we should institutionalize a path for cancer patients, a pathway for cancer patients. Right now in Greece, we have only one comprehensive accredited cancer center, and the second will be at the Alexandra Hospital. And this is why we should establish those pathways, how those centers will be the center of excellence and how they will be linked with the regional hospitals in order to allow cancer patients to have access to centers of excellence, meaning that the regional hospitals will be linked with the centers of excellence. Yes, that would be ideal. We have discussed it a lot of times with the minister himself. However, this is something that should happen step by step. We are not there yet. This is of the breast centers will be the first step. We will accredit 6 breast cancer centers that will be manned with an interdisciplinary team of radiologists, oncologists, pathologists, and those first pathways will allow us to build the pathways of cancer patients in general. We want the service provision to be one-stop comprehensive. Thank you very much, Mrs. Balaura, for the first answer. Mrs. Balaura played a very important role, and it was at her initiative that she managed to accredit the center in Agios, the only so far accredited center for Europe.
We know that Agios has been accredited while Ms. Balaura was the administrator. Thank you, Minister. Thank you, Ms. Balaura. Mr. Tsalikakis, what happens in northern Greece? You have the Theagenio Cancer Hospital, a single hospital for cancer cases. Is it enough? I know that the Minister will say that they are now building another one, but right now, so far, what happens with the patients? Is Theagenio enough? First of all, thank you for the invitation. I would like to thank Mr. Kapetanakis. Theagenio is not part of my health region anymore, but I used to be in this area for quite a few years. I was the administrator when the design for a new hospital was made, and we said that we don't simply need a larger hospital with more beds. The new Theagenio Hospital was a hospital that was designed to provide holistic cancer care, from prevention to end-of-life treatment, end-of-life care. The waiting time was below 20 days, as far as I can remember. And the Papageorgiou Hospital, which is now part of my health district, is enough together with Theagenio, but we do need a few more things, and we're going to mention them. The third health district whom I administer involves Central and Western Macedonia. When I began, we started looking for data for the access of people from Western Macedonia. We wanted to build a map for patients for Western Macedonia. We understood that there was no answer to this question in Western Macedonia. This is why we called Mr. Kapetanakis and Ms. Kaitelidou, and we are very close. I believe next week we will submit a proposal to ministers for a comprehensive cancer care approach in Western Macedonia. I won't go into more detail. We do hope that the proposal that you will submit will be approved. Well, I think the ministry is looking forward to our comprehensive proposal, and they don't doubt the necessity of such an intervention. It will be a major shift for an area with major problems. Of course, I should mention the Papanikolaou Hospital, an iconic project, the new wing for hematology that provides novel treatments. The cost is 100,000 each. Once in-house treatments are being prepared, then the cost will fall and more people will have access to these treatments. Thank you, Mr. Tsalkakis. Give me one more minute. I would like to thank personally Mr. Kapitanakis. It's the World Cancer Day, and on the occasion of this day, I would like to say that he has always been by our side. Everything we've built and what we have prepared for our citizens, not only patients, but citizens in general, is very important. So thank you, Mr. Kapitanakis. Everybody's in love with Mr. Kapitanakis. That's very good. He's very helpful, always has been. Thank you, President. And now, let's go online to Mr. Manolis Saloustros, the President of Medical Oncologists, the President of the Hellenic Society of Medical Oncology. So, Mr. Saloustros, can you please tell us what problems you've encountered inside hospitals? Is it lack of staff? What's missing? And something is going wrong. Many patients complain for the level of care. There might be delays. President, we welcome your remarks. Thank you very much, Ms. Efthimiadou. I would like to thank Mr. Kapetanakis and ELLOK for the invitation. I apologize for not being able to be physically present. I have the flu, influenza, type A influenza. This is why I'm not there. To answer your question, Ms. Efthimiadou, what's missing? What are the problems in hospitals? Well, I've chosen to present, instead of talking about the problems, I've thought that it would be better to present our proposals to the Ministry for the improvement of hospital care, which is indeed an imperative and should be a priority of the Ministry as well. There are problems in daily hospitalization units, which are at the heart of cancer care. Many of these departments, including the University Hospital of Larissa, where I work, are under a lot of pressure, and as a result, there are delays, and we are trying to serve very fast more patients than we can actually afford. Yes, we have evening appointments as well,
but some of the procedures have to have been completed during the morning shift. So you propose all-day operation? Yes. Which requires pricing of the cancer treatment as a medical procedure. As another intervention would be the development of palliative care in hospital and in community, not only end-of-life care, but throughout the cancer journey. If you ask me what's the biggest problem in cancer care right now, yes, it's palliative care. And throughout my mandate, I will keep stressing that. We need facilities, interdisciplinary team, and a clear reimbursement framework to provide psychological, psychomotor support, and that should be a sine qua non part of cancer care. Finally, we have a proposal for the development of cancer care outside the big urban centers. There are medical oncologists being appointed in centers of excellence. To conclude, our society, the Hellenic Society of Medical Oncologists, is always available to provide its assistance, to submit recommendations and proposals, and of course we need patient involvement. This is a decisive factor, and together with ELLOK we can co-shape a new cancer care model that's designed with the involvement of patients. Thank you, Mr. Salustros, for the proposals you've made. And now let's go to Professor Bamnias. You are also a member of the Hellenic Society of Medical Oncologists. You work at the Attikon Hospital, and as the Minister said before, this is a hospital that experiences delays. I said reasonable time period. I didn't say delay. 10 days. I will check it, Minister, because 10 days for people that are in agony, it's quite a lot. Yes, but we are doing very well when it comes to waiting times for an appointment with medical oncologists, way above the EU average. Well, 10 days is a lot for a patient. Give me just a moment. I do recognize the need, but accessibility and the possibility of a patient to be able to book an appointment with a medical oncologist in 10 days is something that's not happening in other EU member states. And that's a victory of the healthcare system. You shouldn't doubt it. It is a success. And I do have the app at hand. In Agios Avas, it's even 2 to 3 days. But you would like to be the same at the Attikon Hospital. Is it your goal as well, to reduce waiting times in Attikon as well? Let me remind you that even you couldn't do that a few months ago. So it's a major progress. Yes, we do recognize it, but don't you aim at making the waiting time 0. We always strive for the best, but let's recognize the achievements. Thank you. I managed to upset the minister anyway. Mr. Bamnias, you work at the heart of the NHS. You work at the Attikon Hospital.
You are a professor, you are in contact with patients, you know the system very well. Who's to blame? When I came back from England, from the UK, I have been serving the public sector for 30 years now. So I would say that cancer patient care is not a matter of a single specialty, definitely not the medical oncologist. So counting the waiting time is not the only way to measure things. Well, normally cancer patients shouldn't book their own appointments. There is an institution that's working fine, the so-called tumor boards. So the tumor boards through the tumor boards, there should be a pathway that would lead the patients not to an appointment with a medical oncologist, but to its treatment, throughout its treatment. This is why we have the tumor board. Cancer patients sometimes, most times, need a surgeon first. And before that, they need a diagnosis. So I don't doubt at all that metrics matter, numbers matter. Of course, we have to monitor figures and numbers, but cancer care is very complex. A single metric won't do. So I want to request something today, because the Hellenic oncology meets very high standards. So I am saying that Hellenic medical oncology, both its staff and the services provided, meet very high standards, and we need to safeguard this. So we've been hearing about this national cancer plan. This is a very good step because we need holistic care for the cancer patient. Cancer patients shouldn't request for an appointment. Those that diagnose the cancer should allow the patient to enter an organized pathway so as not to lose time. Time is not lost in order to book an appointment with a medical oncologist. Time is lost with a diagnosis, with the initial treatment, let's call it surgery. So we have the tumor boards that bring together all specialties that are involved in cancer care. We need to utilize them and start through them a pathway. And the only thing a patient should do is just to appear on the set time and date. Before this process, do you believe that there should be a person that will act as an intermediary between, let's say, a physician outside Athens with a physician inside the Center of Excellence? That's extremely necessary. And I'm very sad when I see people from the islands, let's say, patients, cancer patients that have been diagnosed, trying to find an appointment with an oncologist. This shouldn't happen. We are available to all colleagues, to all regional hospitals. I have recently participated in some telemedicine projects. Money has been given to promote them, and let's utilize them. Diabetologists use telemedicine, and they can examine a patient with diabetes. Why not do the same with cancer patients? Cancer patients shouldn't just be handing the tissue exam, the histological exam, and start looking for an oncologist.
I understand that there should be a system in place in order to guide patients. Now the floor to Mrs. Irini Throuvala. She is a specialized cancer nurse. She works at Elena Hospital. Is there someone who refers patients to you? Hello, everyone. Before answering your question, I would like to thank ELLOK and Mr. Kapetanakis. However, I have also to mention some positive things. I have been working for a lot of years there, and the hospitalized care has been changing. Digitalization allows patients to have in an app all the health data, and physicians also have access. That will allow us to plan for better services in the future. So this is an innovation. And there are also processes. IOSAVAS is an accredited center, and shortly, in my opinion, Elena will be one of the accredited breast centers. Right now, in our hospital, we have 2 specialized surgery clinics that specialize in breast cancer. Usually the surgeon is the first point of view, the gynecologist or the surgeon. Later on, after the mammography, the tumor brain takes place. Tumor boards are very important. Interdisciplinary approach is very important because sometimes a woman with breast cancer should undergo chemo before the surgery. So all the healthcare professionals should decide together on which is the best possible treatment. Now, let me also mention a problem. It is a problem that is not unique to us. We are understaffed when it comes to nurses. There is a lack of nurses. World Health Organization has also mentioned that the understaffing of nurses is something, let's say, a traditional problem in Greece. And nurses are next to patients. But right now, I know that we cannot immediately hire new people. We can alleviate red tape burden. We can establish new processes, use artificial intelligence. Other countries have introduced artificial intelligence in the workflow that allow nurses to spend more time by the patients and not on red tape. Young people do not go to study nursing. This is something very sad, and we shouldn't forget that. We should give more responsibilities to nurses. They should be more autonomous when it comes to their role, and we should give young people a vision, because it is them, along with physicians, that spend time with the patients. They should be independent, and the patient's needs are not always met. There are a lot of unmet needs, and there are also needs for awareness raising and training. There is the role of the navigator, nurse navigator, that helps patients navigate this healthcare system. We have specialized staff, and our physicians and nurses are very well qualified. So I will keep what you have said, that we should give motives to nurses, since they are understaffed. We are understaffed on a European level. So there is a difficulty in that, I would like to ask you the following question. Apart from a nurse that can help a patient navigate the system, do you believe that we should establish a mechanism that would help patients? For example, let's allow a patient from Trikala to come to Attiko Hospital, or to come to Ayosavas. I don't know. People don't know where to go. They don't know how to navigate the system. This is a new role that maybe it would transform the health care system and the hospital care as a whole. Mrs. Balaura said that she wants to build a network. Is this going to happen shortly or not? All right. Now, I happen to be working for a lot of years in the Ministry of Health. Let's start from the beginning. First and foremost is the fact that cancer care in Greece, no matter what the problems may be, and no matter which improvements should be made, is at a very high level. We have excellent physicians, excellent oncologists, and patients have easy access. Compared to other healthcare systems, patients cannot call their physicians abroad. How many patients have called you on your personal phone number? Would that have been possible in another country abroad? No. Let's say things how they are. Of course, there is no clear guidance in Greece. Patients don't know the next step. This is because our system inherently allows people to have very free, they can roam free in the system. In other systems, the steps are pre-described. First of all, patients abroad have to be referred to the family doctor and then get a referral. People abroad cannot choose their oncologist or their surgeon. They cannot choose in which hospital they will undergo radiotherapy. You are in a pre-described system without any flexibility whatsoever in other healthcare systems abroad. You've said it yourself, Professor. Greek patients can choose. Greek patients in Trikala, the healthcare system allows that patient to come and to go to a surgeon in Attiko. Patients choose to collaborate with this doctor or that doctor in another hospital. If we want to copy other healthcare systems, we will have to lock things down on a geographical level. You could be then sent to the surgeon only of your city, of your town. You wouldn't have the chance to go to another hospital in another area. So in Greece, things are different. In other healthcare systems, such as Germany and Finland and Sweden, patients cannot pick and choose their own physicians, their treating physicians, only if they have a private healthcare system, healthcare insurance. And also patients in healthcare systems abroad don't have the chance to call the treating physician after hours. Things are not so personal they are they are not so flexible as in Greece. So the Ministry of Health, our first duty in the Ministry of Health is the following: to increase the capabilities of the system, to increase oncologists, to increase cancer clinics, and increase positions for chemotherapy. I have heard that it is a very specific proposal, and I want to discuss it. Increase radiotherapy also, because you can give multiple choices to the patients. After having done that, then maybe we can help patients navigate the systems. Patients can find a surgeon and can find an oncologist rather easily, with less or more difficulties, one would say. However, patients that cannot do that, they have to get a point of reference. This is the hospital that you have to go, and the hospital, that point of reference, will refer you to this or that spot. And this is why we should measure the times, and we shouldn't stick on the theoretical level.
Allow me, Minister, to ask a question. We know patients from the countryside come to Athens, that even though there might be some departments outside Athens, they all know, they trust a certain physician, and they might believe that regional hospitals don't have so specialized medical staff. Have you thought of specializing physicians throughout the Greek territory to specialize in cancer care? No, that's not the problem. Outside Athens, there are large university hospitals that do provide care to patients. What we need is more capabilities, more cancer departments, more cancer clinics. Rio needs more medical oncologists. The Rio Hospital. Open up new radiotherapy departments, new oncology clinics. This flow towards Athens is the same flow for patients with all difficult diseases. There are cancer patients in hospitals outside Athens, especially university hospitals. We need more medical oncologists. We don't need to train the people already there. We just need more. This axis between Thessaloniki and Alexandroupoli, there is no other department for radiation therapy. It would be normal for Kavala, for example, which is in the middle, to have devices for radiotherapy. That's the planning that we want to do. You talked about the nursing staff. Yes, that's the single number one problem of our health system. What you said is correct. They don't opt to go to nursing school, and it's not only about money, because in other EU member states where salaries are much higher, still there are fewer people that opt to become nurses. Right now, we are going to open up more vacancies, and since last year, we've had the opportunity to open up more vacancies. So next month, the relevant platform will open up, and everyone who has made a request will be hired. I think there are no incentives for nurses, so an increase in salaries might be an incentive. Of course, this concerns the entire NHS staff. Ms. Palaoura, in Agios Savas, you've been there as an administrator in the past. Can someone say that there is a holistic method for cancer care? Can somebody go to Agios Savas? What do you mean comfortably? That's a very relative term. But in Agios Savas, and especially after its accreditation as a CCC, now there are very specific pathways and measurable inside the hospital. So a patient that goes to Agios Savas receives holistically the care needed at a specific time. We are trying to stick to the timeline, so there should be no more than 2 weeks from the diagnosis to surgery. We are trying to abide by this protocol. So yes, they do receive the necessary services, and they are quality services. And they will receive guidance internally as part of this pathway. It is a one-stop shop. This is what we request, Minister, a pathway, guidance, because patients don't know what to do. Mr. Tsalikakis, a last comment on your part in order to conclude this panel. I can talk about a reform that I have experienced. We are now able to provide chemotherapy to 150 patients per day, whereas a while ago it was just 41. So there is progress. I'm just going to talk about PET scans. There was a large discussion about it. We installed the PET scan device at Theagenio. You have two in public hospitals, in Papageorgiou, in Theagenio, and one in Alexandroupoli. Well, the numbers that came for PET scans were not all that big. I'm just going to mention an event that happened. A lady from Sweden called me. During the pandemic times, she couldn't get a PET scan because she didn't meet the requirements in Sweden. So she asked whether she can have her PET scan in Greece because she was coming to Greece for Christmas. And she did that. So she came for Christmas holidays, she had her PET scan done, and she was very happy about it. So just this to make a comparison. It's true that in NHS, everybody, all staff, is very enthusiastic in providing services. Well, let's do justice to the ministry as well. The ministry has done a lot in the past 2 years. Well, the governments are elected to do this. No, not everything should be taken for granted. They've done a good job in the past 2 years. Ms. Palaoura is off the microphone. This is why we love NHS despite its problems. Let me give you an example from Papageorgiou Hospital. In September 2024, we had 14,500 patients waiting for the surgery. This has been reduced a lot, and now the waiting time is just 4 months. It's not, we need to shorten it further, but still progress has been made. Mr. Bamias, a last comment on your part as well. We don't want to restrict the patient options. We want to help hundreds or even thousands of patients that get confused, that they come from the countryside with histological exam and they're trying to find the right specialist to go. This is an existing problem, and if we solve this problem, then we will be able to solve other problems as well. That will help with research. Patients that are lost from clinical trials are many in number, and this means loss of income for the state. There was now a new ministerial decree that changes and amends certain things around clinical trials that will help. Well, I'm talking about patients that would be eligible for a treatment. They get lost in the system. So there are patients that ask for guidance. We don't impose this on them. Ms. Struvala, a last comment on your part. I think we are doing rather well, but the enemy of good is always better. We have to keep improving and make sure that we monitor indicators inside the hospitals, indicators of quality that are measurable and help us. Because healthcare professionals also need a guidance to know that they do their job right. And indicators help along. And it's important that we are here, we discuss, patients are here, we discuss all together, and this is an exceptional initiative. Thank you very much. President, a last comment by the President of the Hellenic Society of Medical Oncologists, Mr. Salustros. While we've been talking about the transformation of the healthcare system, it would take weeks to exhaust this matter. Mr. Salustros, it is seen, as you specialists go, that the number of cancer cases increase. The minister said yesterday that the needs for drugs for cancer patients doubled within a year. How soon we have to change things in NHS to cope up with the increased number of cases, new cases? Well, first of all, thank you for this discussion. I truly enjoy it. And I do hope the same applies to all panelists and to the audience. A lot of concerns have been heard, a lot of problems, and that's the first step. I'm also very happy because the state and the Ministry of Health shows willingness to cooperate, listens to our proposal, and finds them interesting. Thank you, Minister. We are always available for the state to provide documented proposals and recommendations in order to help cancer patients. Let's not conclude by saying that cancer cases increase radically in Greece and the needs double. Yes, indeed, there might be increasing incidence in specific cancer types that might be relevant to the change in our lifestyle. But on this very important day, let's send the message that we've managed to have better 5-year survival rates for cancer patients globally. Of course, this means increased expenditure for cancer care, which we need to manage, but I'm confident that the state doesn't look at this as a cost, but as an investment to public health. Thank you very much. Thank you, President.
Thank you very much for your proposals. We would like to thank Mr. Salustros, the President of the Hellenic Society of Medical Oncologists. I would like to thank all panelists. The Minister is always very polite, but I think we managed to put some pressure on him and upset him. Yes, the floor to the Minister. Can you make a commitment? Well, it's a personal scale. Not everyone upset me. It's your personal scale. You managed to do that. I would like to wrap it up by repeating what I said before. We are doing well, but we can do better. We are open to all proposals in order to find what will make patient journey better, easier. Yes, there are challenges, but that's the ultimate goal. Thank you very much. Thank you all for your patience. I hope it was a lively and interesting discussion. I do have this skill of upsetting ministers. Thank you.
Σας ευχαριστούμε πάρα πολύ.
Thank you very much. I'm sure that you have heard a lot of time the importance of this special day, the World Cancer Day. It is a day with high symbolism. This high symbolism is understood by Mrs. Sonia Theodoridou, a soprano, international soprano. I would like to ask you to join us and address the congregation. It is a great honor to have you here with us, Mrs. Theodoridou. Hello, everyone. I would prefer to stand not behind the podium because I feel that I'm very short. Nevertheless, I have listened carefully to what we have heard in the previous roundtable. I participate as an artist because I have been living abroad for 39 years, and a few years ago I received a phone call, and the Patients Association from Kastoria called me, and she opened me a new world. She opened up a new world for me, the world of cancer patients. I have always believed that the mission of art is very important because apart from the beauty, it allows us to influence people and help do our best. So I volunteer, and I still volunteer, and I'm not saying that because I want you to congratulate me, but in my opinion, all artists have a duty to stand by society, to stand by the people. The ministry is not here because I wanted to share with him that recently I experienced cancer in my family. I have lived for 39 years abroad. I have experienced very bad things, such as physicians asking for bribes, etc. Because I don't want to end on a negative note, I would like to say to the minister that everything sounds great, that we have new machines, that there is an effort. However, let us not forget that the Greeks are people that have suffered. We need an emotional approach. So we have physicians and nurses that do the extra mile every day to cure our people. I would like to encourage everyone to take advantage of us, in inverted commas, because we are here available to help you, even if it is just a simple concert in order to raise money for your mission and your goal. Thank you very much, and thank you for giving me the opportunity to serve the society through your cause. Thank you.
Ευχαριστούμε θερμά την κυρία Σόνια Θεοδωρίδου.
Thank you very much, Mrs. Sonia Theodoridou. And now, let's continue with the next panel. We are going to discuss about ECOS and the national hubs. We are going to discuss health literacy, health data and artificial intelligence. Mr. Kapetanakis is going to give the floor to the moderator of the next round table.
Ναι, τον ευνηδίασα.
Ευχαριστώ.
Thank you. As you know, since last summer, ELLOK is the National Cancer Mission Hub. Today we have the honor to continue this partnership that started this summer. A lot of important things have begun with many partners from the private sector, from the research field, the academia, the state and patient representatives. So, the next session, which will be the last session of our conference, is in cooperation with the National Documentation Center, our official ECOS partner. The coordinator of the project is here. Who is here? Hugo. Hugo Soares.
Coordinator team of ECOS One, please come here with me. I'm very glad to have you for one more time here in Greece, and it is very important the support and the collaboration that we have been begin more than 1 year ago. So, please, the floor is yours, and we will be honored to have you here and begin this session for our 10th Annual Congress and in World Cancer Day. Okay? Thank you very much. Please.
Thank you very much, George. And first of all, good afternoon. It's a pleasure to be here at the 10th Annual Conference of the Hellenic Cancer Federation. On behalf of ECOS, I would like to extend my deepest gratitude to George and the entire ELLOK team that I know that you have been making a great effort to make all this possible. Also for organizing this vital gathering that you do it annually. It's my third time here, so I can see the developments that happen from 1 year to the other, and this is very important, that we ensure continuity on the actions that we are doing. Also a special word of appreciation to the work that is done, especially in the scope, it's not this presentation yet, also in the work that is done in the scope of the Hellenic Cancer Mission Hub that makes ELLOK an example of success, and it's a pity that the ministry is not here to listen to this anymore, and a reference in Europe on this matter. And actually, the work that ELLOK has been doing, it's not just of value for the Greek society, but it also strengthens the vision and the perception that this kind of organizations, the National Cancer Mission Hubs, have in the implementation of EU Mission on Cancer and EBCP, and that was heavily and strongly highlighted by the European Commissioner for Health, Oliver Varelli, in his message yesterday, and it makes us very proud of it. As we align with World Cancer Day, we are reminded of challenges of international instability, challenges on the health systems, and challenges with cancer research. And we are reminded that these are real. Nonetheless, I also want to remind, and we are also reminded that our collective motivation, effort, and capacity for progress are also real. And that's what we are doing here. I'm well aware that we have reached the afternoon of the third day, and this is usually the legendary graveyard pit, where people start leaving for flights and so on. Nonetheless, I have to say that looking at this room, and for the speech that we just had from Mrs. Sonia, I believe, that our collective energy is far from depleted, and we have motivation to keep going. So, and in fact, I'm incredibly honored and quite frankly proud that we are delivering this specific session on the World Cancer Day, despite being the third, despite some tiredness that we all have. It's very special to us to be here. And for that, thank you, George, for this opportunity. Having said this, it is my pleasure to introduce this session organized by ELLOC in its capacity as Hellenic Cancer Mission Hub. We believe that innovation does not happen in vacuum. It happens through collaboration with different sectors of society. Today, we will explore this through concrete examples in the 4 roundtables that Maria has also alluded to: health literacy, the European Health Data Space and the Cancer Mission, biobanks and artificial intelligence in oncology. The pathway of care we want to build rely on these dialogues and collaboration between the policymakers, the scientists, the industry, the civil society, the healthcare professionals, and most importantly, patients and patient representatives. Let us use this collective energy to move beyond discussion towards realistic, actionable, and meaningful actions, initiatives in Greece and also beyond Greece. Thank you for being part of this mission. And so it is also my pleasure, I thought it was on display already, to introduce to you the new logo that we have been developing together that symbolizes and qualifies ELLOC as the Hellenic Cancer Mission Hub. This is a very proud moment for us. This is a big step through in the fight against Europe in cancer, and you are the proud members of being the first one to have this logo associated with this fight, and for that I'm also very proud for you. Thank you very much for your love.
Ευχαριστούμε θερμά και θα...
Thank you very much. Now I invite the moderator of the first panel, Andreas Haralambous. He is the former president of a European Cancer Organization and a professor of oncology and palliative care, to join me here in order to undertake the moderation of the first panel. Thank you very much. I would like to thank ELLOC for yet another time for this invitation and for the opportunity to speak here for a very important issue. Reference is made to health literacy, when it comes to digital health and cancer cases. I invite my panelists, my co-panelists. If memory serves me right, we also have a colleague that will be joining us online. We understand that the time has passed. We will try to make this as interactive as possible. We will give you a scan code to participate in this discussion when it comes to digital literacy and health literacy. So, my co-panelists are Mrs. Nikolina Dodlek, who is a research fellow and teaching assistant from the Cyprus University of Technology, Mr. Adonis Billis, who is a postdoctoral researcher and fellow from the Medical School of Thessaloniki of the Aristotle University. Christos Tsagaris needs no introduction. He is a member of EU Cancer Mission Board, and he also represents the Institute of Cancer and Crisis. And online, we have Marios Gianta, who is president and co-founder of the Center for Innovation in Medicine in Romania. We understand that this is a very challenging roundtable because my fellow co-panelists have flights to catch. So without further ado, my first question to Christos. A first comment. In your opinion and based on your experience, health literacy and digital literacy when it comes to cancers, does it affect the provision of high-quality services or not? Thank you very much. I would like to thank all of you for sticking with us here, and ELLOK, of course, for extending this kind invitation. Literacy is a common ground and a bridge that allows for patients, clinicians, researchers to ask common questions and common goals and work together for the common future. Then we have the traditional literacy, which is the ability of people to read. There is the critical literacy, meaning the possibility to understand what I'm reading. And for the last decades, reference is made to the digital literacy and the health literacy. The first grade of that literacy is the structural literacy of digital health, meaning to know how I use an application, how to use an SMS, that I receive an invitation or a referral, or electronic prescription. And not only on a personal but also on a collective level, we have to go to the level of critical digital literacy, not only for patients, of course patients, but us healthcare professionals alike to be able to understand how to utilize electronic means and electronic information, which information is credible and which is non-credible, and above all, what's the difference between guidance and information. We all know that we need a screening for breast cancer after the age of 40. How are we going to navigate this digital world? The best possible physician, who is paying? Is this reimbursable? Is mammography reimbursable? But I believe that shortly we will have a questionnaire and you will share with us what you know and what you don't know in order to take it up from there. Thank you very much, Christo.
Funded project Intervene, which is designed and developed in order to address health literacy in the cancer framework. Can you elaborate briefly on the project so you can set the scene? Thank you.
Thank you very much, and I would like to seize the opportunity first to the organizers and Mr. Kapetanakis for the kind invite to share our project Insight. So Intervene project is EU for Health funded project and coordinated by Cyprus University of Technology and by Professor Harambous. It's a multi-level, multinational EU project that started last year in September with aim to explore and increase health literacy in cancer prevention and care. Given that said, it's important to emphasize that this is not yet another project that will be based on theory, but we will start with a firm basis and a firm framework, starting with searching what's already available in different EU countries and synergies with also other EU for Health projects. What trainings are available? What is the gap in health literacy? Accredited and also non-accredited. Our targeted populations in this project are patients, caregivers, healthcare professionals, but also general population, general citizens, as this is highly important to receive the timely feedback. What projects also focuses on is accept the mapping. Two frameworks that are really important. They're called REAIM and Kirkpatrick. So the framework will explore who are the targeted population, but also accept the education and skills, What changed? Did the behavior change? Did the health behavior change? And what is out there that is missing in communication in between the healthcare professionals and general citizen population and also the patients? We are also very pleased to have a diverse advisory board with all different targeted population, as well as Mr. Kapetanakis, as the voice of the patient is very important to us. As when we speak about health literacy, we don't speak only about individuals, we speak about the whole healthcare system, not only the hospitals or cancer centers or such, it's broader, it's rather the national and EU level as well. So when we have the firm basis, we will continue to build up a living lab. Living lab means that the project will have a living input from patients, from caregivers, from healthcare professionals, as well as the citizens. And now with you also today, because we want to explore and gain experiences and your opinion, what do you think is missing and how can we together build up a more sustainable cancer health and health literacy world and trainings? We will also approach specific cancer centers in EU to assess what is the status of health literacy within specific cancer centers, what is the quality. And from that, we will combine something that is called Living Lab. Our partners here from Aristotle University of Thessaloniki will develop for us a living lab to be able to have a live interaction as a project output. So for us, it's important to let you know that this is not going to be remained as a leaflet, as a booklet, or something that's not tangible. It's important to say that the project is going to be implemented and sustainable. That we will provide different trainings and education for all of the categories, and we look forward to receive your input and your opinions. We will share a bit later the QR code and kindly invite you to be engaged, because we want to have a user-centered design and approach, and to hear what you have to say and how we can have the input in real time from you as well for this training and the materials that will be available. Thank you.
Thank you, Nicolina, for describing the project in such detail and in such short time. Thank you so much. I now turn to Marius online. Marius, are you with us?
Yes, hello, and I hope you can hear me.
Yes, Marius, yes, we can hear you loud and clear. Can you please share and describe very briefly your curtain projects that you are leading under the same EU for Health call? Thank you.
Exactly. First of all, thank you very much, George and ELLOK, for the opportunity to join you even online for this session. Is very, very important. And thank you, Nicolina, for setting the stage, actually, for the topic of the health literacy part of the EU for Health projects. Indeed, Carton, it's a sister project with Intervene that you just presented. And the Carton stands for Beating Cancer Inequalities Through Literacy in Europe. We are 15 partners from 9 European countries. And from our perspective, cancer literacy is more than awareness alone. And in Carton, we'll try to build basically a system capability, a shared competence between citizens and patients and professional and institutions. We have in the project 5 pillars: cancer literacy among citizens. We aim to build practical understanding of prevention and early detection and risk reduction. Then the second pillar is the cancer literacy among patients. We like to enable patients really to navigate the care pathways, different medical decisions and technologies, and to do this in full confidence. Then is the cancer literacy among healthcare professionals. The idea is to equip doctors and nurses with training and for them to communicate better, with more clarity, and hopefully more empathetical. The fourth pillar is the organizational cancer literacy, aiming to improve the ability of the health and social care organizations and other organizations, and to contribute to create a cancer literate environment with systems that are much easier to be navigated than happens now. And the fifth layer is to bridge the knowledge gap through digital tools. And I think this is a very important dimension of our project, because we will go in the already established living lab in Lăreș village in the center of Romania, and we'll co-create with citizens and patients and the local authorities a framework on how to use large language models for cancer literacy. And this way, probably this is the most evident dimension on how using cancer literacy and cancer literacy innovation like large language models can contribute to dealing with different types of inequalities. And I will stop here, and I'm very much looking forward to build synergies with Intervene and other projects.
Thank you so much, Marius. It's very interesting to hear that your project is specifically targeting inequalities that are generated by health literacy, and take our word for it. There's many more that we can report during this session. And
And now I will give the floor to Antonis. He is here representing a joint action, the so-called ECAN Plus, which is not established to fight specific health, the lack of health literacy, but he has been working a lot on the topic of digital capacity building of healthcare professionals, and he will share us more on how they plan to tackle this issue, and at the same time how they are going to tackle the issue of health literacy too. Thank you very much for inviting me. Andreas, Mr. Kapetanakis, and ELLOK. I come from the Aristotle University of Thessaloniki, and more specifically from the Medical Physics and Digital Innovation Lab. For more than 10 years, we have been working on new technologies that can be used for training physicians and healthcare professionals. And within the framework of our work there, we moderate the work package in the ECAN Plus joint action. This is a joint European action about telemedicine and cancer, which continues a previous joint action, the so-called ECAN, that lasted for 2 years and has now been completed. Therefore, in the framework of those two joint actions, our goal is to develop tools of telemedicine for cancer across its whole range, from prevention to survival and cure. We have developed digital tools and applications for patients and healthcare professionals in order to be able to manage cases, cancer cases, especially of people who don't have access to centers of excellence, cancer centers, and our goal is ultimately to map the existence or not of health literacy, to understand what is happening with the curricula in the universities, what is happening with the professional training, and what about lifelong training of patients, caregivers, and whatever else might be there when it comes to digital skills. However, we are doing more than that. We're trying to participate actively or engage patients and healthcare professionals actively in order to understand the existing gaps. And we do that by using living labs, the so-called living labs methodology, since the skills that patients and healthcare professionals are taught to be able to transfer them to real life. And this is the value of the methodology of living labs. We are trying, in a very hands-on way, to incorporate theoretical knowledge in clinical practice or in the everyday life of our patients. And on this note, I want to finish my initial remark. Thank you very much. Within the framework of the collaboration of ECAM Plus and Intervene, there are clear synergies and overlaps, and I'm sure that information and results from one program will be sent to the other with mutual benefits. Now, I would like to ask if we can have the PowerPoint presentation.
Okay. Επομένως, πιστεύω ότι
I hope that I'm guessing that you all have smartphones with you, so either scan the QR code on the left or go to Minter, and there you can enter the code and you can start replying to the questions of the survey. Do not worry, this QR code will be visible on all slides. The more the better.
Αυτά είναι κάποια δημογραφικά στοιχεία τα οποία
Here we have some demographic data. We would like to urge you to answer so that we can correlate your replies either to your professional profile or your role as a caregiver or a person that has has personal experience with malignancies. I can see that we already have some answers. Nicolina is in charge of the Menti.
Next. Okay. Okay. Next slide. Is it too quickly? Okay. Is it okay now? Okay. Maybe now we can move. Okay. Thank you everyone for your patience. Η πρώτη ερώτηση αφορά
First question is about what you consider to be the most important needs related to health literacy, and in particular within the framework of cancer prevention and care. You can reply either with a single word, or you can use a brief statement to be more descriptive. We see some answers already sent to us by participants. So information, understanding information is vital when it comes to our needs. Could you give us a few words regarding this weakness or need? And of course the audience continued to reply. This is a very clear reply, and having looked at the demographics very swiftly, this is an audience that by at least 50% comprises postgraduates and postgraduates that work within the field of health. So irrespective of the educational level, let's call it that, or personal experience with the field, we all have access to information. We all need information and need to understand what we are talking about and what we are doing. I'm very happy with the reply, understanding information, which has been stated both succinctly and in a more descriptive form, because it's one of the pillars of our actions. Before we can move to quality treatment, we first need to truly comprehend what we are talking about, what we are doing, be it biology, be it clinical practice or health economics. Thank you very much, Christos. So we're on the right track with the replies. Perhaps we can move on, Nicolina, to the next question. The next question, therefore, is about the main difficulties that people experience as regards both understanding and interpreting information related to cancer. Adonis, would you like perhaps to comment some of the first replies? You can feel free to reply in Greek if that works better for you. Definitely, the fact that we have medical terminology that sometimes is difficult for patients to understand and makes it even harder for them to comprehend what is happening to them, especially at the level of diagnosis, so that they can later on convey that accurately to other physicians, to other teams. This is something that I believe is an obstacle. In Greece, for example, I believe that the patient is always attached to information. They always need to know, they always need to have information, but it's also very important for them to be able to comprehend that information and to be able to communicate that information clearly to other members of multidisciplinary teams. Thank you, Adonis. The next question is about main difficulties that people might experience when they try to interpret such information related to cancer. And we can see here some of the replies, absence of validated sources of information. We all know that online finding information is far too easy, even for people that do not have the necessary knowledge to assess and understand the information that they are able to reach online. So this can lead people to drawing the wrong conclusion. I would like to ask a question. Marius, can you see what we see? Can Marius see what we are seeing on our screen? Or not? It's a technical question. The speaker who is with us online.
I'm not sure if you can hear me.
Marius, do you see what we see on the PowerPoint?
Yes.
Okay.
Yes. Yeah.
Okay,
Yeah.
that's fantastic. Would you like to comment on the previous findings in terms of the challenges and the difficulties in interpreting health-related information? Just briefly.
Exactly. Yeah. So are actually two components of the same challenge. So if you go online, you can find, of course, information that are not true, contributing to disinformation and misinformation. But I think also very relevant is the quantity of the low quality informations coming from reliable sources. And that's why people sometimes feel that the information is too generic, because there's this tendency to somehow to translate into a plain language, but sometimes is too much, you know, and we should keep somehow the scientific integrity of the wording, but to make people understand in a different way. So I think the two major components are very relevant, and the solutions are totally different, because on disinformation and misinformation and fake news, we should act, let's say, maybe from a regulatory perspective. And for the other one, it's a matter of education and being able to come together really in multidisciplinary teams, you know, doctors and scientists and patients and citizens and healthcare communicators, people working in the public relations, including in the pharma industry, because the industry is contributing a lot actually to, at least in our region, to health literacy, and to come together and find the right messages. And I was so happy actually to listen Antonis and Nicolina speaking about living labs, because this allows us actually to really build personalized messages based on the citizens and patient input.
Well, thank you, Marius. That is very clear. Can we please go back to the PowerPoint presentation? Thank you. Great. I think that was the previous one. Let's see the next question. PowerPoint. Okay. So, next. Η επόμενη ερώτηση αφορά ποιες είναι οι...
The next question pertains to what challenges might exist when people try to navigate across the various services related to prevention and care, cancer prevention and care. It is actually a question that was asked, that was set to the minister, and one of the panelists earlier spoke of the nurse navigators. Nurses that help cancer patients navigate the various steps of the journey. Here we see a mention of limited access, financial issues. So we see that there can also be mental health issues that might affect the capacity of a person to navigate the various services. I don't know if Christos or Adonis would like to comment on that. Sure. We see here a very bad trifecta, unfortunately. The first still seems to be that even though services are free for many, access to those services is so convoluted that for many people it resembles a labyrinth. And in their efforts to navigate this labyrinth, they come up with solutions that cost money. And it appears that the patient that will be able to navigate this labyrinth and perhaps escape the Minotaur, hopefully, is the patient, precisely the patient who is goal-oriented. But we cannot expect cancer patients that are already experiencing psychological and physical shock to be goal-oriented. In Cancer Wall, we were able to look into literacy as regards rights of patients. On one hand, we know what we need in order to be healthy. On the other hand, we're not sure how to reach that objective. And I believe that this sample of the poll actually highlights this deficit, that we need to be able to reach answers, to reach steps in a way that is financially affordable to all. Thank you. The next question: what factors limit people's ability to make informed decisions related to cancer prevention and/or treatment? That is a very interesting question, Adonis. What do you think? Definitely. It comes as no surprise that the first reply, number one reply, is lack of information. Information that is actionable, that allows us, I mean, decision-making is about agency based on information. And this is unfortunately not feasible. I see several reasons. They may pertain to financial hurdles or systemic obstacles. And I guess that this is linked to the lack of transparency, perhaps, when it comes to access to information. And the aspect of digital literacy also plays a part here. I've been following the actions of the ministry here in Greece that excludes some people from having access to information. People that are elderly, that do not have the digital skills that would allow for access to information. So this could deepen this deficit. I would like to challenge us with the following question. We talk about patients, about caregivers. Do we believe honestly that healthcare professionals by default are literate or literate in a high level? That is an excellent question. I would say let us not take anything for granted. Literacy of healthcare professionals is different to that of a patient. We would expect an HCP to know what cancer is, what treatments, frequent treatments at least, are, and of course to know the difference between a prospective or retrograde study. We would expect them to be able to assess a conflict of interests in a study. So literacy is a dynamic parameter. It depends on the person. Of course, it has a collective dimension as well, but it becomes increasingly more difficult for healthcare professionals as well, especially given that this is a time where healthcare professionals have such a huge workload that they may not have time to retrain, upskill, or deepen their knowledge when it comes to digital skills. For example, which journals are reliable and which journals are predatory. There are unfortunately studies that make it clear that for some healthcare professionals this is unclear. What types of support do you believe are currently missing that could help people better understand cancer-related information?
Take on this and maybe comment on some of the responses.
Thank you very much.
You can also see them there.
It's okay, I don't see from the flowers, but I'm good. I see the personalized guidance from healthcare professionals and appropriate resources. So of course we can't impact, will we have a nurse navigator or dedicated healthcare professional that is going to navigate? But we can surely do our best, as well as with the educational resources. But my opinion is that caregivers here also play a crucial role in support. There are a lot of elderly people or young children, and they require a caregiver. And sometimes we as a healthcare professionals don't understand the importance of including the caregiver timely and specifically for decision making. So for me, this is also a type of personalized guidance next to the healthcare professional and maybe a nurse navigator as well. Regarding the appropriate resources, it can be also cultural barrier or barrier in linguistic communication. Sometimes we often use medical language, which patients don't understand. So I think this is also one of the main barriers.
Thank you so much. Can we move to the next slide, maybe? Well, this is
This is a very interesting question, especially given the next panel on digital health. What challenges do you face when you're using digital tools or digital services related to cancer prevention or care? Adonis, I believe you are the right person to speak about this. I believe that this is common knowledge. When we're talking about patients that cannot utilize technology, it is because primarily this technology is not user-friendly, either because the language is too inhumane, too impersonal. And then when we look at the terminology, it's not just about medical, purely medical terminology. There's also the purely technical IT terminology that sometimes patients have to try to understand. And quite often, whenever we run a pilot application with them, they drop the application because they fear that they might make a mistake that could lead to, I don't know, World War III, the destruction of the application, the destruction of their smartphone, the end of the world as we know it. So it's all about not having a systematic involvement of these patients, both patients and physicians. Whenever we create new technologies, new tools, there needs to be an inclusive development of such tools, starting from the inception all the way up to the assessment of a new technology. The patient, the treating physician, the carer need to be at the core of each such attempt. Thank you, Adonis. And let me also repeat that one of the greatest challenges that we need to address within research projects is when we have the end of the grant and we realize that these studies do not have the right capacity to allow for a continuity which would enable better integration within clinical pathways that would be necessary in order to ensure the sustainability of all those technologies long term. Yes, and I believe that a real challenge is how to implement these technologies in real clinical environments. This is missing. It might exist, but it is quite restricted, quite limited, especially when we're talking about R&D projects. So one last question. What difficulties do individuals encounter, in evaluating the accuracy and reliability of cancer-related information? As mentioned earlier, we have an overabundance of information right now. Would you say that these obstacles truly reflect real-world evidence, the difficulties of people to evaluate information? I believe that all the answers are quite useful. It's about translation, but it's also about interpretation. Interpretation varies depending on the user's level of education, culture, language, many parameters. Very often we've pointed out that a text, a document, even in excellent Greek, might not be accessible to people that belong to linguistic minorities. To put it plainly, to immigrants to this country whose Greek is not fluent. Also, if we're using the popular Greek language, if the document is too official, too formal, it will be unable to be understood by a person living far from a major urban center, or that might be speaking a dialect. And then we have the younger generations, Gen X, Gen Z, that use specific terminology of their own dialect, let's call it. So the question is, are we talking to one another, or are we shooting out monologues of information?
I think
I do apologize, says the speaker. I think this is all the time that we had. You can continue answering to those questions on your own time. Right now, I would like to give you each 1 minute for a final remark.
In terms of, you have 1 minute to give us your concluding remarks in terms of today's workshop. Marius.
So I think was really insightful and the start of a great conversation and collaboration between Intervene and Carton Projects. And indeed, to the last point, the digital tools, I do see a risk that large language models and generative AI to contribute actually to the increasing the inequalities. And this our task actually to make sure that we involve vulnerable people from the beginning in the design of the implementation and the use of large language models in real life.
Thank you, Marius. Nicolina?
Thank you very much. Firstly, I want to thank the audience for the input because it's been highly significant for the project and for us. It's important to hear what's out there, not only to look at the documents, literature, evidence. It's important to have a real-time input, a living lab to hear you, to listen from you. If you're a patient or a caregiver or healthcare professional or citizen. So thank you for engagement. Also, I would like to emphasize that the synergies and joint actions are really important to join collaboration, to see what's already out there and what is the gap and how we can work together. So thank you very much.
Antonis?
By listening to my co-panelists, I have now a more comprehensive approach on what health literacy is all about. The fact that patients should know how they have access to healthcare services, things that affect their everyday life and we might not know them. Marius mentioned earlier AI. Digital literacy nowadays is much more than the use of ID. We are talking about European health data space. We are talking about patients who are going to donate their data, but they haven't really understood what this is all about and how they can ensure that they enjoy their rights. So reference is made to AI literacy, not only for patients, but also to physicians. And in my opinion, if we want to use and utilize all those technologies in the best possible way, we have to offer personalized training, not only for patients or physicians, but on other communities, such as the linguistic minorities, but also we should offer it to other groups based on their unmet needs. We have all understood that literacy is a map. There are all kinds of maps. A tour guide may have a more detailed map. A tourist or a young person needs a simpler map. However, if we want to navigate this new environment, this new space, such as cancer, we all need a map. Of course, we also need a point of reference, a meeting point, such as this panel and this conference. So I want to thank my colleagues, my co-panelists, the audience, and ELLOK for organizing and bringing us all together. Thank you very much to all of you, Antoni, Christo, Nicolina, Marius, and thank you because with your engagement, you made this panel successful, if I may say so. We hope that this will be just the beginning, since ECAN, Joint Action, Intervene, Curtain, all those programs have been launched quite recently, and we are looking forward to understand how the goals and the targets will be translated into action and how they will affect clinical practice. Thank you very much to ELLOK and ECOS for one more time, and we will see you soon. Thank you very much.
Σας ευχαριστούμε πάρα πολύ.
Thank you very much. We will continue to the next panel. Mr. Charalambos Karanikas, Associate Professor of Medical IT and Health Technology Systems, the moderator to come and invite the other co-panelists. Mr. Karanikas, you have the floor. Hello. I know the time has passed. We will try to have a fruitful discussion. I would like to invite my co-panelists to join me, please. Join me here. Is Hugo here with us? I haven't met him yet.
Ωραία, ωραία. Το κάνουμε δυναμικά. Έχουμε ένα θέμα.
Today, my opinion is that we should discuss in a practical manner. A lot of things have been said about the European health data space, but also I want to talk about the Greek health data space. Which are the practical steps that we have to do within the next 1 or 2 years so as to allow Greece to follow the developments? We want to be ready. We have distinguished co-panelists. Hugo, who is science manager of the Biomedical Engineer Institute from Portugal. Charis Vassiliou, who is a European health data space expert, and he understands both the Greek and the European environment. Alexandros Bella, who wears a lot of hats, such as interoperability. He is also survey director in Gnomon Informatics, and he will talk about how those data will be exchanged. Mina Boubaki from the Ministry of Health. She is the head of the director of Electronic Health Services, and Mr. Paschalis, who represents the Department of Contract Negotiations, and he will discuss on how we can utilize the data for health technology, and we, of course, we will try to focus on cancer. We will try to speak more about health data and cancer. I will propose some topics for the first initial remarks, and then we will open up the floor to dialogue. So, do you have microphones? Yeah, all right. I will start from Hugo. The 3 keywords for this panel is the European Health Data Space. The second keyword is utilization of national data to a European environment and vice versa. And third is the means that will allow us to do so. Which is the means? It is the European Health Data Space, and the framework of impact is European Cancer Mission. And this is why I will start by giving the floor to Hugo. He is a coordinator in the ECOS project.
April of 2026 is near to the end. Okay, what is interesting for us is to understand what are the challenges, ποιες είναι οι προκλήσεις.
What are the challenges?
Dimension of collaboration, these dimensions are critical to our discussion, and to understand which are the fundamental challenges and needs for the cancer mission. Άρα, ας αρχίσουμε από τις ανάγκες.
So let's start from the needs of cancer mission, not only when it comes to data, but also to synergies, and later on to understand if this European Health Data Space and the interoperability tools will allow us to do so.
To express the challenges for the cancer mission concerning data and collaboration.
Thank you. Thank you very much, Professor Karanikas. So just for the audience, some clarification. The ECOS is not about digital tools. It's about implementation of EU Mission on Cancer. Within EU Mission on Cancer, you have also the digital tools. In 2020, it was launched, so the discussion started before that, but let's put the date in 2020. Advisors to the European Commission have identified a series of needs in the fight against cancer in Europe. Some of them digitals, such as the share of data, the share of data related with research, the share of data related with patient data, the secondary patient data, but also images, diagnostics, tests, and so on and so on and so on. So for that, they have come up with fundings and with structures to implement what we call the federated structures at European level that will be feeding all this information so that in the end, and the final goal is always to fight inequalities that we still have in Europe when you compare north, south, east, west, and countryside regions with urban regions. For you to fight cancer, you need to have data, otherwise you don't know exactly what you are doing. We say that data is like managing with the eyes open or with the lights open, so you know where to go. For that, we needed to construct different infrastructures. European Commission was willing and is willing to put money on these structures, but even though we have money, we might have even the technical capacities. That's what we are building with the different projects. ECAN, it's one of them, but also the Candle, USIP, NCAN.EU, UKIM. You can name a lot of projects happening at European level towards this final goal. We have the money, we have people, we have technical skills, but there is one thing that is always missing, which is the country penetration. You don't have data, let's say, at European level. The data is within the citizens are within the country, so you always have to go to a given country to retrieve this data. And this is mainly where the challenges in the end we will face these challenges, because European money can build infrastructures, but there is reduced amount that will then come up to the countries, and is also a commitment that the European Commission asks to the different countries, that is, we can put a large amount, but we also need your commitment on this. It's not just our responsibility. Health is the responsibility of all of us. I can build something, but you have to show the commitment to use this something. You need to show your commitment also to contribute to this something. It's a win-win situation, so we also need something from you. And this is where it falls, because not always you have the priorities aligned, not always you are in the same level of development. Some of our countries already have data registries, some don't. Cancer registries, some don't. Some already have what we call the health data access bodies, or something that might easily become health data access bodies. Some don't. Some have regional structures, some are working centralized. And this is where the challenges begin, because then is the responsibility of the country to solve these issues, and there is no jurisdiction from the European Commission towards this. It always has to be at the national level. And we know heterogeneities at European, at national level exists greatly. So it's like imposing a country that now something like this becomes a priority, and that's not easy to do. So you can either impose, you can influence, you can suggest, and this is where we can contribute, for instance, with organizations like ELLOC, by getting people from the different sectors, policymakers and so on, as I was alluding before, and making it happen with the capacities, with the resources we have available. So at this moment, I would say that interoperability, you already said. Also, the opt-out and the GDPR ethics that are also entangled in a lot of legislation and regulatory frameworks that differ greatly from country to country. And the infrastructures, the health data access body, and of course, the money, the funding to make this happen in the different countries.
Thank you very much. Thank you very much. I think, yeah, you touched the core. The core is the data, the usage of data, η δευτερογενής χρήση των δεδομένων. I imagine
the secondary use of data.
If you have identified the type of data that you need for the cancer mission, and if you have done the matching with the European Health Data Space data priorities, that would be an interesting second round answer from your side. Αλλά είπες...
You have said, I think that now this is a very good pass for Haris Vassiliou. We want data, but we don't know how each country can give us those data. In the immediate future, with the European Health Data Space, it seems that national data access points will become a priority. So I want to ask Mr. Vassiliou how we are going to establish this in Greece. In order to be able to overcome the challenge of red tape, since this is usually the challenge in Greece. Thank you very much. Thank you very much. First of all, let me thank Mr. Kapetanakis personally and ELLOK for the invitation. It is a great pleasure to be here again. In my opinion, the national bodies should develop specific characteristics. First of all, to work proactive about what is happening, and of course, to be quick and to give the actual powers and authorities to the researchers to use those data in a safe manner. So we are trying to build a national body, and this is a very critical point because we prepare also the legislation in Greece, so we have to take this under consideration. So it is very important to bear in mind two characteristics. First of all, to have a contemporary regulatory authority that should respect the legal framework of national laws and EU laws, and the digital services, some digital services that will help us towards this direction. So we need standardization of the process. We also want to do triage and some kind of automation for those services. And of course, we should bear in mind the transparency of the results. Let's start from the first, standardization. The regulatory framework of EHTS mentions specific standards when it comes to requests, licenses. So, given the fact that we have the health data EDU, we can offer a digital portal in Greece that could allow cancer researchers to request for a specific goal, specific health data. Projects such as TEDAS2 have given us standardizations when it comes to checklists for this process. Therefore, that is a very powerful tool in our disposal in order to reduce the number of emails that we exchange in order to give a license, to grant this request. And of course, it will increase the automation in the checklist, in the monitoring, and it will help us reduce red tape. So let's talk about the so-called triage. A very well-designed research case study in cancer includes less risks or needs less controls, less checks. So if our data are anonymized and aggregated, then this process might be much more quick compared to other requests that use pseudo-anonymized data. That needs more time and more checking. So, both the legislatory framework stipulates that for specific goals and missions, the so-called first in, first out is not necessary. So, based on this first triage, we can make a first prioritization, a fast-track process in order to have a better control. So the third part is the need to standardize specific services and not discuss them again and again. So reference is made to the governance model. How we are going to bring the research code to the data
in order to ensure a common analysis environment. And the third aspect is also very important. We may have data catalogs, and they provide us with detailed descriptors of cancer data. What can be achieved with such data? What is the quality of such data? Where do we have shortages, deficits? These are all fundamental aspects that will allow us to move forward. In closing, also let me say that it is very important to ensure transparency. Already our legislative framework allows us, enables us to ensure that each body will provide reports on petitions, authorizations, permits, licenses, and this will ensure transparency and thus act as a catalyst to bring down red tape, because this allows researchers to submit better petitions, better requests, to form candidatures, and this will facilitate the process as a whole, which means fewer calls to the Prime Minister, the chairperson of AOP, the National Organization for Health Services, for Healthcare Procurement, anybody that we may know. So you mentioned a word that I will use to ask a question to Mr. Berler. It is standardization. Mr. Berler is very knowledgeable when it comes to the development of the cancer registry in Greece. So I would like to hear a few words about his hands-on experience on how standards and codification can truly assist this process of collecting and utilizing secondary data. Thank you. I will do my best to provide an answer, but I need to mention a few things to pick up off where Harris left off. Governance of all this endeavor is very important, and we see similar governance in primary use. For some reasons, we have made a distinction in between primary and secondary use, but let's not forget, we're talking about the same patients, the same physicians. So at some point, we need to close this loop. And the reason why we have to close this loop, and this is why we talk about standardization, interoperability, is because in order to have right secondary use data, we need to have the right primary use data. Otherwise, all the studies being conducted will be based on extrapolation from databases, and the analysis will be primarily statistical in nature. So in some cases, the data will not be very useful. We may have data catalogs that may lead us in the right direction, or we may not. If we're talking about the cancer mission and we truly wish to have the patient at the center of all things, because we want to ensure that any patient suffering from any type of cancer will be able to have access to the right treatment and potentially to future treatments, whatever that might be, like AMTPs, we need to link the two. And based on the registry that we are developing now, we are doing precisely that. We're trying to link the various pieces of the puzzle that will have an impact on the job of oncologists, hematologists, an entire ecosystem of physicians, and on also patients, caregivers, families, what have you. If we manage to connect the registry, the data collection mechanism that looks into medicinal use, surgeries, treatments, what have you, then we will be able to start considering how IVICA, who will be in charge of this project, can be able to utilize specific standards for secondary use. So we need to look into all this. Now, as regards the cancer aspect, there's a lot of effort has been placed in utilizing international standards so that we align at least with the technological standards that govern both primary and secondary use, be it for cancer, diabetes mellitus, or any other disease. This will be very, very helpful. It is the 875 that is primarily used as a standard, and HS7 there have been already some requests to harmonize with those standards by design, by default, let's call it. Because on one hand, we want proper infrastructure for treatment and potentially prevention in cancer care. And then we want to move to the next level, which is novel treatments, novel medicines, new radiation protocols, and so on and so forth, based on the appropriate therapeutic protocols. Thank you. And this could be a question for round 2 of questions. Given the data that we need, do we have tools, digital tools, and in what format, of what quality when it comes to the registry? Do we have sources that the registry can draw from? But let's keep this for the second round of remarks. Hugo mentioned needs and challenges. Harris spoke of the European direction on how to set up such a mechanism to allocate, to distribute data, to share data. And then you mentioned how this can be feasible with the use of standards. Now let's move on, because all of you mentioned governance. So let's move on to the government, the Ministry of Health, and Mrs. Boubaki. Now, Mrs. Boubaki, you need to inform us as to what the ministry is currently doing, having received quite a bit of input from the EU, from involved stakeholders. There is a regulation. So, in actual terms, how will Greece catch up with the European happenings? You are absolutely correct. We've got tons of input right now, and I should say that the ministry contributes to that input. We've got many initiatives, many projects that are preparing us for the legislative part that will govern the governance mentioned by everyone. Then we have European guidelines as regards administration and governance, organization, operation and governance. There is a large-scale project aiming at producing guidelines for all that Harris mentioned. Right now, we've got the Comitology Committee that will look at all the actions needed under the regulation, provided for under the regulation. And what is the ministry doing? We are collecting information. We are fusing, merging information. We may not have issued a bill of law yet, but we are drafting lots of legislation acts in order to tackle all that Harris mentioned: primary use, secondary use, the key authority, the coordinating body, what happens with requests, petitions. It is a deliverable that we are already working on, and we have standardized requests and petitions. We have discussed the need for auditing, checks, in order to avoid this multitude of this torrential outpour of emails, phone calls to people we know or may not know that well, so that we make sure that everything is done properly and therefore in such a way as to ensure proper audit of all requests and petitions. We are also close to having a national data catalog. We have begun with the digital skills coordinating authority that will ensure that private data, personal data of our citizens will never be threatened, will never become available when they should not. So we have concluded some studies, and we are working on the legislative aspect. Do we have a time frame for all that? Well, the official time frame is that this needs to have been concluded by March 2027. But I believe that within the coming months, we will have announcements to make. So that will allow for consultation. Yes, of course. So I'm guessing that Mr. Zohrafopoulos is going to come to take on an even greater role. He is the person within the ministry that receives all requests and petitions, a very dear friend of mine. And this, says Ms. Boubaki, this will change. It will not just be him from now on. We are already examining which existing bits and pieces of legislation need to be amended in order to facilitate moving forward. And I know I've been told many times that I seem to prefer IVICA, but today I have a representative here with us from EOP, the National Organization for Healthcare Services, a dear, dear friend, Mr. Paschalis. And I would like to ask you, with all this new data, processing of data, how prepared is EOP to utilize real data from real world evidence in order to look upon negotiations of contracts and so on and so forth? I used to be a radiologist both in the private and the public sector for many years. I've the past few years, however, I've I've been in administrative posts, but throughout this journey, I've always wanted to image solutions. And what I want to do is remind us all that, yes, we can say lots of things, but we need to listen first to the people that will benefit from what we're planning to do. So we need to know how things are as is. Where do we stand today? Do we have data? The answer is yes, we do have data. We have e-prescription that has been up and going since 2011. We have data, personalized data per citizen, both Greek and foreign citizen residing in Greece, if they have an official social security number. Since 2011, that's invaluable. We have closed hospitalization data since 2015, so all hospitalizations of patients, both in the private and public sector, since 2015, for the past decade. And this all comes with a diagnosis, the primary input that you mentioned. Because if we want to make a categorization of data, we will focus primarily on diagnosis. The first letter under ICD-10 is the letter C, coming from the word cancer. So we do have data on cancer patients, primary data. What else do we have? We have some other databases linked to EDAPI of ELB, which is about the statements of detailed analytical health documents. This is an application. So we've got this. We also pioneer. We are the leaders in Europe when it comes to radiation and radiotherapy. Since 2016, we have a clinical audit system within ELP with all clinical data of patients that have received radiotherapy in Greece, with the treatment plan for each and every one of those patients, both in the private and public sector. Do we have registries? I admit that we are still lagging behind in the integration of the registries, but we are building this. And with the central management of the oncology file within hospitals, we are building a single database. So where do we stand? 1, we can understand. 2, we have a regulation. EHDS regulation exists. So we have the institutional framework on how to manage this data. What are we missing? Coordination. The mediating authority that will play the part of the go-between in between IDIKA, the Government Center for Social Services for Health Services in Greece, and the remainder of the ecosystem, the healthcare ecosystem, because we will require the secondary information, secondary data that we've mentioned. And I would like to close by saying that what we really need is open data. In Greece, we don't have open data. If a university wants to run a study, a survey, they need to pick up the phone, as you very well put it before. Why? So let's resolve this. Let's end this now and forever with EHDS.
Yes, it is true. We have done a lot of steps forward in Greece. However, we have spots of good practices that do not communicate with each other and in the best possible way. Exchange also in our country is also problematic. There are islets, one would say. There is a large, huge volume of data in IDIKA, but all those are islets, isolated islets of information, and in my opinion, and now with this effort, we will be able to bring them together in order to utilize, make the most of them. Even In Portugal, when it comes to electronic prescription, they don't have ICD and ICD-10s. And when Portugal saw our system, said this is a huge pool of data. So when it comes to electronic prescription, we're doing better than Portugal. So a question to Hugo, have you seen any Greek data within the framework of ECOS? Have you ever received, was there any need for you to have access? And what do you think about what you have been hearing now in Greece compared to Portugal, of course?
Thank you once again. Sorry for the delay. No, I haven't seen any data from Greece. As I said, I'm not working on the digital. If something, I'm working on the governance and how to facilitate this governance. Then it's not up to me then to look at the data and compare. Now, what I can say, you were mentioning this before about the Mission on Cancer and EBCP. The data is very similar because you need one to get to the other. You need research and to better care, and then data care to trigger new questions. What I can say is that this will happen at European level, regardless. Either we are in or we are out. And the same thing for Portugal. Of course, if we don't do anything, Europe will progress and we will stay behind. And I think this is the key message that we have to bring to our decision makers, is that at this point there is money, there is consortiums, there is this support, this technical support, there is tools that will help us move forward faster. Otherwise, the train will take off, and after it, we need to run behind it.
Great. So, the data priorities, οι τομείς προτεραιότητες που έχουν τεθεί από το...
The data priorities from European Health Data Space.
Results, imaging data, these data priorities satisfy the use cases of the cancer mission. We need to define details on these data sets, or we need additional data sets. Υπάρχει κάποια άσκηση που πρέπει να πραγματοποιηθεί?
Is there anything that we can do? Anything more?
Yes, sorry, I guess delay.
Okay, directly in English then.
Yes, indeed, and that's why we have the ENCAN Connect project, which is funded with 30 million euros, if I'm not mistaken. They are running their pilot test, their pilot projects within ENCAN to gather this data, this initial data that will feed, that will be used to create the system, to see if everything is working, so then that they can amplify. But we are talking exactly of this data and much more, omics, for instance, as well. So we are bridging and bringing together what is the classical research data with the classical health data, so we can match, and we can say that from metabolomics, transcriptomics, whatever, match this with the clinical profile of, or the images or something, so we can better target, profile, and do personalized medicine, in this case, personalized oncology treatment.
Σωστά, correct. Οπότε, μετά από τη βάση...
So, after building the baseline, which is horizontal, Mrs. Vassiliou, we will need to specialize per sector in the future, meaning that data sets, we may need to specialize them according to their use and inform the validation rules. Apart from the basic rules of data priorities, in order to include specialized needs of priorities that might be decided on a European level, such as cancer. Cancer is such a priority. And then I will give the floor to Mr. Berler. So, national health hubs, data access bodies, and the national contact points for cancer, since those will be the points of reference, the hubs for each country. How do you believe that they could work together in the future? I know that this is up to your imagination, but Mrs. Vassiliou, Mr. Vassiliou? Yes, just let me say that this is very important. ENCAN has been mentioned. and ECHOS, in my opinion, national bodies should work as catalysts and not as gatekeepers of this process. I think that Mrs. Boubaki can say more on this issue. Let me say that everything that we have mentioned so far, governance, data, technical infrastructure, will help us bring together those islets if we would be able to understand the overarching picture, to adopt an overarching approach for the secondary use of data that will bring all those islets together. Thank you very much. This new program is what Mr. Bella mentioned earlier, that we should not discriminate between the primary and secondary use of data. A comprehensive approach is needed for health data. And then we can decide on how we will use them. Before giving the floor to Mrs. Boubaki, and Mr. Bella, kindly, could you talk about this comprehensive approach? How can we do this? I am in favor of that program. I believe that this fragmentation of health in various projects is not helpful. We have the General Secretariat of Strategic Planning. They should do that. They should plan strategically. Now, when it comes to cancer, you asked a question if we collect data. Right now, in the cancer registry, we have standardized 52 specific fields that have been aligned with the European guidelines. So, in my opinion, if the physicians do the data entry, they will have data. However, if we want to understand how the primary use will affect a correct secondary use, we have to find some multipliers in order to accelerate this procedure. One of the multipliers would be to take into consideration patients' rights. So, this will help us accelerate this process. The second multiplier would be to use LP funds for innovation. We should be able to prescribe electronic applications. Now I will give the floor to Mrs. Boubaki. Could you? Yes, I will also talk about the previous issue, yes. All two issues before. We have a lot of parallel discussions. So this was a very good question. And I wanted to mention that most countries, and Greece including, and the Ministry of Health, we are trying to participate actively in various programs, UKIM, ECHOS. UKIM is on medical imaging and wants to propose AI solutions for those cases because we want to be able to read better all those imaging data. And we participate because we want to have access to a European pool of data that should be linked with EHDS, should be linked with a European hub of data access, and we will use those health data on a European level, and we will share them. So Greece, the Ministry of Health, participates in those projects, also in other programs such as ANCAN. This was a very good question, so I wanted to give you a more practical answer. Thank you very much. And last but not least, a last question to Mr. Paschalis, and I don't know if the audience has any questions. HTA, Health Technology Assessment in Greece. Are we going to be able to use real-world data? Do you have any plans in order to be able to introduce new innovative medicines based on real-world data? I will start from your last question on HTA. When it comes to drugs, since this is a regulated procedure based on European rules, there is a regulatory framework. I think that we are doing well. That in Greece, we will be able to prioritize the best drug for the personalized care for each patient. However, when it comes to diagnostic tests and care, hospitalization, we lag behind. We have a lot of way and a lot of work in front of us, and this is why we have to collect data and even fragmented data, because data help us make decisions. Which treatment was the best? Surgical treatment, chemos, radio treatments, whatever. Now, when it comes to what Mrs. Baki said, how can we fill a diagnostic record with tests? In Greece, the scientific associations cannot agree. The scientific societies cannot agree on one model. We don't. A medical oncologist, a radiologist do not need all the raw data of a patient. The society needs to decide on one model in order to be able to read the diagnosis. The most important thing is what we have said now. When it comes to HTA, do you know that in Greece we have tests that are reimbursed without them actually taking place? We have prescriptions that are not executed, they are not done, but the patient receives the money, or the lab receives the money. So this is why we need the actual imaging and the actual diagnosis. This is an interoperability. And in order to conclude, I think that the magic word is the word interoperability. Reference is made to the personalization of the care for this patient.
Let us move on to questions from the audience. First of all, congratulations for a truly remarkable discussion. My name is Konstantinos Kostikas. I am head of the HIPAA and Dataverse companies that participated, and in fact we designed, implemented, and we're currently supporting the Hellenic Cancer Registry. So I would like to thank the participants for all your kind words regarding the registry. And I would also like to add the following. The National Cancer Registry is fully aligned with the ACIS prerequisites, specifications, and specifications of European registries. There are many fields that are now being expanded. We will have an even greater host of fields. Mandatory fields are 35 currently. For them, it is mandatory to enter data, and they need to be uploaded on an annual basis into the European Cancer Registry. That does not mean that we're talking about an obligatory data entry, but we are fully standardized, and we are finally uploading national data onto the European platform. And because we mentioned ICD-10, which is of course very important, the national registry is based on ICD-03. For those of you who are not aware of what it means, even though most physicians are currently familiar with it, this is the coding, the codification used throughout the world and in the EU for all cancer registries. It is the basis for a cancer registry. Last but not least, I would like to ask Mr. Paschalis a question. Quite often, physicians ask us, and rightfully so, they want to facilitate their work. They want to only have to enter data once and not multiple times. This has been mentioned multiple times. Do we have any prediction regarding an automated access through the interoperability with the system of electronic pre-approval? We have a wealth of data there because physicians already upload there very rich, documents and folders with huge content. So it's a wealth of information. A very brief answer, please. Those folders, SIP folders, are unfortunately not digitized, so it's crude data. It's PDF files that doctors upload, so it's very difficult to codify them. What would have been best is if the system of SIP, electronic medicine pre-authorization, was already digitized. If we had digitalized boxes, digital fields, where the physician would be able to fill in specific information. This, unfortunately, is not the case yet. Also, unfortunately, we don't have much time. We don't have any time left. There was an old song that said, "Rain will save us all." I will paraphrase that and say, a new mechanism, a new body will save us all. And hopefully we will have that new body available soon. Thank you all very much for your input.
Ευχαριστούμε πάρα πολύ. Δυστυχώς έχουμε μείνει πίσω στο χρόνο, οπότε θα παραλείψουμε.
Unfortunately, we are faced with a remarkable delay, so we will have no coffee break. Instead, we will move on to the next panel, which will be moderated by Mr. Papazesis, Professor of Clinical Pharmacology in the Aristotelian University of Thessaloniki and Hospital Papageorgiou, Head of Clinical Research Unit. Thank you. Good afternoon. Let me invite all our panelists to join me.
Λοιπόν, καλησπέρα, σας ευχαριστώ που...
Good afternoon. Thank you for sticking with us after so many long hours of very interesting topics. Thank you to those following the works of this conference online. The title of this panel is Biobanks with No Frontiers, the cornerstone of European precision oncology. Let me first of all introduce the panelists. Next to me, we have Mr. Hugo Soares. Welcome.
At the Agency for Clinical Research and Biomedical Innovation from Portugal. Thank you for being here. Η κυρία Μαρία Γαζούλη.
Ms. Maria Gazoulis, Professor of Biology, Genetics, Nanomedicine in the National Kapodistrian University of Athens, in the Faculty of Medicine. Hello, Maria. We also have with us Ms. Sisi Koliva, molecular biologist, a researcher with the Hellenic Pasteur Institute. Ms. Evi Lianidou, Professor of Analytical Chemistry and Clinical Chemistry in the Chemistry Department, Faculty of the Kapodistrian University of Athens. And we also have with us Mr. Nikos Pissimisis, in charge, the Head of Development of Molecular Diagnostics in the Όμιλος Ιατρικού Αθηνών Medical Group of Athens. I would like to come back to some key points of the previous panel. They spoke of personalized treatment, of precision medicine, and of course this also entails precision oncology, a key component for us to be able, especially within oncology, to speak of personalized and precision medicine. Another component, a key component for that to take place, is biobanks. Let me make a brief introduction. What are we talking about? Biobanks. And we need to discuss with this panel what are the key challenges when it comes to organizing, maintaining, and of course ensuring the sustainability of biobanks in order for them to be truly beneficial for the patients, allowing for an individualization of treatment, which is what we've all been clamoring for within the framework of precision medicine for years now. I would like perhaps to begin with Ms. Gazoulis. Professor Gazoulis, would you remind the audience what exactly are biobanks? Good afternoon, and thank you for the invitation. We're actually talking about organized structures that collect, store, and manage biological material of the patients. This can be anything: blood, urine samples, fecal samples, tissue, anything. And in biobanks, the fact that we collect and store this material is not much. This needs to be correlated to the demographics and other statistics regarding patients. So biobanks need to go hand in hand with records, with registries, so that throughout the treatment we can monitor the data that is derived. This is a library of biological information, of biodata, and it allows us to better understand a condition or various conditions and diseases, and therefore develop precision treatments. And when we look at this through the lens of cancer, we can understand how important, how primordial this is. But also when it comes to rare diseases, rare cancers being rare diseases themselves. What we're missing is that we don't have sufficient material in order to have statistically significant evidence that will allow us to develop treatments. So biobanks, both at a national scale and their correlation with other biobanks in other nations, and therefore at an international scale, have a lot of input to offer in order for us to achieve what we call precision medicine. Thank you. You have been truly, you spoke of things hitting the nail on the head. Biobank can provide us with the information accompanied by clinical data with clinical data of the patient, pertaining to the patient. This is something that we will need to discuss later on. These data needs to be linked, connected to the folder of the patient, the registries, and perhaps national and the European cancer registry down the line. After some primary introductory remarks, I would like to ask Ms. Koliva to also describe the network, I believe he was said, because it was off microphone, she works for. Thank you very much for the kind invitation. I'm here today as a representative of BBMRI ERIC. Why is that? Our head, who is in Austria, could not make it. Initially, he was invited. I am just a member of BBRI ERIC, and I am here to provide you with a description, a brief description. First of all, BBMRI ERIC means European Research Infrastructure for Biobanking and Biomolecular Resources. It is the outcome of a research policy of the EU that required the existence of infrastructures around Europe that would be open to all scientists. Greece is a member of this research infrastructure, because the country, the member state, can only join as a member. We have a national network which is coordinated by the BBMRI of Greece. Mr. Thanu is in charge from the Research Institute in Athens. Why was BBMRI established? All of us who have worked in labs of biomedical research know that biomolecular material is very sensitive, very specific. Each sample can be 100% different to the next, even if we are dealing with the same disease. So to standardize samples as much as possible is a huge priority. And this led to a state of play where lots of findings publicized in excellent journals around Europe were impossible to reproduce to a large extent, almost 80%, 70 to 80%. So we needed this infrastructure. We created this infrastructure. This infrastructure has grown, and it ensures, first of all, that there is actual collaboration in between countries, member states, scientists, so that the research conducted on samples, and nowadays we speak of, today we're talking about oncology samples, in such a way as to allow for the interconnection and interaction of scientists and findings throughout Europe. BBMRI in its own is not a biobank. Samples remain where they are collected, as is the case for the data extrapolated from those samples. One might say that BBMRI is a mediator, a mechanism that ensures efficient access to samples by means of a procedure that is ethically and legally appropriate. It safeguards patient rights and the protection, of course, of their personal data. It allows for equity in access to samples and as such to research and as such to precision medicine. Moreover, it functions nowadays as a hub, allow me to use that term, fostering learning and standardization of the biobanks participating biobanks. So it has developed, or rather, quality assurance and quality management scheme developed by BBMRI is available as a training tool, as a collaboration means, so that participating biobanks will be able to reach the quality standards set forth by BBMRI. Because let us not forget that biobanks and collections, because in many cases we're talking about collections, not biobanks. Biobanks are governed by standards. And of course there's data that comes into play. A collection might not have data in its possession, but a biobank is obliged to maintain data. Thank you very much for this excellent description of the state of play. You touched upon quite a few issues. I will linger a bit on standardization and the need to adhere to specific standard operating procedures that in some cases are governed by specific ISOs. Especially when we're talking about biobanks, these should be common, shared by all those claiming to have a biobank, because you raised an excellent issue, you touched upon an excellent issue. What is the difference of an official biobank and a body collecting samples? So for those who are interested in establishing such a bank, they need to contact the competent bodies in order to gain guidance on how to implement specific standards, ISOs, and establish biobanks that will be truly useful and open to physicians and the pharma industry. So let's keep all that in mind. Moving on to the second round of our discussion, we could come back to them, but for now, let us continue with the perspective of Ms. Hezuli. First of all, I would also like to thank the organizers, especially Mr. Kapetanakis, for the invitation to participate in this panel. It is a great pleasure for me. I have been dealing with clinical samples for years now. I'm also a member of the European Association for Cancer Research Board and the European Liquid Biopsy Society. It is very important in our times to be discussing biobanks. And I would like to point out a very important matter. Pro-analytical steps in the collection of samples need to be very strictly standardized. And we need to look at the standards governing storage. You mentioned reproducibility of repeatability of outcomes and the lack of it, and it is something that many physicians underestimate. Let me just point out that we participated at the Cancer ID and IMI program. Many countries, many member states of the EU, and many pharmaceutical companies participated in this program. Our lab also participated, and there were lots of publications on a topic which was considered simple, but is extremely important. How do we isolate plasma? How do we isolate DNA? How do we define sample quality? These are all very important questions, and we need to make sure that a biobank functions based on the right answers to these questions. So biobanks need to be aligned with a broader framework in order to ensure that we're all speaking the same language. And we also need to have ISO certificates for labs undertaking analysis in order to ensure the reliability and trustworthiness of the outcoming analysis. Biobanks can offer important results, and it is important to have them. Let me bring forth the example of the MammaPrint, which is a test for diagnosis of breast cancer patients that can early on tell us if there will be a metastasis or not. The development of this test was born out of a biobank that existed at the time in the Netherlands with frozen samples frozen in a standardized way, and when BBMRI came to being, data was already available because we had the analysis, we had the test, and we knew which patients had relapsed, which patients had moved on to metastasis and which have not. And now this is a standard test for breast cancer patients. But this data was already there. And when the biobank was created, then, at the time, we didn't have the right technology to truly capitalize on that. Now we have that technology, and this is a wealth of information that can be very beneficial for the patients. Thank you very much for those remarks. It is true that clinical physicians tended to underestimate the right way of collecting, storing samples and so on and so forth, which are a cornerstone to the entire procedure, because if those steps are not taken properly, the sample is useless. And based on the standards you mentioned, both you and Ms. Koliva, the standard operating procedures, ensuring the quality and future use of these samples, I would like us to move on, because we heard from a university representative, Mrs. Razzouli, Mrs. Koliva representing the Pasteur Institute, the chemistry faculty from the university. Let's listen a bit to the private initiative angle. I believe that Mr. Persimisis, as head of the development of molecular diagnostics in the Athens Medical Group, can truly tell us what the private sector believes about biobanks. Within the private sector, have we managed to achieve what we've been wishing to do for ages now, be mature enough to interconnect with international biobanks?
Thank you very much for the invitation. I will talk with the head of the Associate of the Medical Faculty of the University of Athens, and I am also International Health Inspector. So I can bring an international experience, and the first thing that I would like to say is that Europe had understood that it is very important to utilize biobanks, because knowledge produces ethics. It should follow some moral rules, and then and only then it can produce innovation. On a practical level, right now we might not utilize those data, but if everyone is going to adhere to the rules, things will be better. HDS is the road, and each country should include their islet in order to be able to take advantage of that road. So all those data can be utilized for statistic reasons, and thus metadata from all the other institutions. Now, when it comes to the private sector, not for Greece, because Greece is going to change the framework, the regulatory framework, I would like to announce that there's an effort with a scientific group of cancer, HERSCO. We want to establish an organized biobank that would give extra added benefits to the patients. Look, on a practical level, I have to say that we have been talking since 2009 for biobanks and DNA. However, DNA is not always useful. In cancer cases, RNA is more useful, not DNA. transcriptome is more useful than DNA. And given the time, we understood that it can be interpreted various ways. Let's read a sentence of Pythia, the oracle of Delphi. That sentence might say in ancient Greece, Ixis affixis oukan to polemos nixis. There's a quote from ancient Greece. You will go, you will come back, you will not die in war. This is a translation of the oracle. However, if you change the comma, it means something completely different. That you will go to war, you will come back and you will die. So, you can interpret the same sentence with two different ways. This is the meaning. So we have the data, we have the technology, and we have the trust of the patients. There is a prevalence of cancer, huge percentages. And this is based, of course, on our lifestyle. Our lifestyle affects. But even if there is a prevalence of the disease, we have also a higher trust on behalf of patients. And now there are ethics. We can use the data in the best possible way. We have done enough. So now we have the chance to continue. You have the chance to continue to give sample in order to help your co-patients. In order to have access to personalized medicine, to have in silico analysis, and to create the so-called digital twins in order to work with other scenario. So the basis is the right use of the primary material. And there are machines that can eliminate human bias 100%. We waste money, resources to train researchers. But we shouldn't waste those scientists and researchers to the biobanks. There are machines that can work in the best way that will eliminate human bias. So those data will be read in the best possible way, and AI might help, and then no matter how many times they will be read, nothing will change. They will be able to, we will be able to interpret them in the same way. The private initiative also can use the cloud and safety. AWS, Amazon that is, has managed the following, has managed to work with UK biobank. Let's say that you work with a sample from the biobank and you ask a question. All those data are enclosed to an internal system that does not allow for a malware or you yourself to see all those data. Those are encrypted, but you can still work with them on an encrypted level, meaning that only if you have the credentials to go to this internal encrypted level, and you will get answers only for the questions that you have answered. You will not get the full report. This is the best possible case, in my opinion. All those points are very important, and I will keep them because we will discuss them in the second round of that question. Now, I will give the floor to Mr. Suarez. Last but not least, Mr. Suarez has got a PowerPoint. This is why I have left him now. We can give him the floor.
Mr. Suarez, what's your presentation about, I think?
Thank you. So, first, just a disclosure. I'm not here now in the quality of ECO's coordinator anymore. Now I'm the coordinator of the National Cancer Hub. And basically, the challenge that at the time ELLOK questioned me, also asked me to bring here, and also in the quality of now the Hellenic National Cancer Hub, is what can be the role of a National Cancer Hub in the area of biobankings. As we have heard, and I will not repeat, Dr. Maria Gazzulli has explained perfectly well how a structured and qualified and efficient network and biobanks individually can do for research. Advancing cancer is also about having high-quality biobanks. Mrs. Cicis Coliva has also expressed how Europe, in this case through the BBMRI, can help us advance our infrastructures, national infrastructures on biobanks, but also the standards. BBMRI is also working on standards, sharing the ethical, the legal, the societal issues that are connected with this. So now we have this new structure, these national cancer mission hubs. How can we interact or connect both worlds? National cancer mission hubs are a large definition, so it can be about policy, it can be about research, health. It's basically making it happen. We already have here a structure that is similar to what I've described for the National Cancer Mission Hubs, but specific for biobanks. How can we collaborate together? So the story I bring here today is a little bit maybe out of scope for Greece in a way that you already have a network, you already are part of BBMRI, and you already have this functioning network of biobanks. In Portugal, we didn't. So we have a lot of things that work very well. Biobanks was not one of them, unfortunately. So this doesn't matter, is what is the National Cancer Mission Hub. When we started the National Cancer Hub 3 years ago, we have consulted the community about priorities. What do we need to do to advance with biomedical innovation in cancer and clinical research in cancer? There were a lot of priorities, I will say, 11 high group categories of priorities, one of them being the biobanks. I must say, unfortunately, that biobanks within the 11 priorities was the second to last that we tackled because of, many things, as you can imagine. But they were not forgotten. And 1 year from now, we start picking up this again, limitations on human resources and so on. 1 year ago, we picked this again. We consulted specialists in the country, those that were running the biobanks, those that were responsible for the network of biobanks that we had, and we still have, of course, but yeah, with challenges every day. Those that were using samples from biobanks, patients that were donating their samples to biobanks to understand what could be improved. What were the phases that, for instance, a researcher that wanted to have a sample from a specific sarcoma, blah, 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 phase to get that sample in. Also the technicians, how to preserve, you have a biobank that is there since the 90s. You have these technicians that are more used to sample and to do the maintenance of more classical samples, let's say from histology. And nowadays we have complex systems like organoids and this. How can biobanks keep the pace and help the investigation, but also being part of the investigation? They are not just a support unit, they are part of the investigation. We have consulted them, we have identified issues, some of them are there, heterogeneity of biobanks, heterogeneity of samples, fragmentations, shortage of human resources. I think we all relate to this. And December last year, we organized a meeting where we invited international specialists in each of these areas to speak with us. One of them, Jens Haberman. We also have Zizis, and let me see. Exactly. Zizis Kotslakidis from IARC. He was here with us Monday and Tuesday to share with us the best practice that they have. We have identified the way to go through, and this was the work of the National Cancer Mission Hub, again, connecting those that have the needs with those that have the solutions and those that can facilitate delivering it. And I think I have just pictures from the event. At this same event, of course, the event was the visible part, but it's like the tip of the iceberg. This is what you see, but there is a lot of work done in the backstage. And at this event, ICIP, which is the agency I work for, Agency for Clinical Research and Biomedical Innovation, announced that Portugal would be joining BBMRI this this year in 2026, Jen was there, very happy, as you can imagine. We also announced, as an agency, a national agency, we have responsibility over the community, the national community. So it was not just talking, we also have and put forward with some money for boosting the biobanking community to move forward. So it will not be much. Unfortunately, we are not a very wealthy agency, but we have some. And with this, we create the first steps to move forward. I have also the list of problems, but I don't want to focus on problems, but on the solutions. Now we are doing a green paper with these recommendations, getting it to the ministries, health, research. In the past, we have also involved finance and economics in different aspects, not in the biobanking, so this is also a possibility. So we try to push forward this. And this can be the role of a national cancer mission hub, in this case in Portugal, with our reality. In this case, ELLOK and Greece, with their reality, they might do something different. But this is what we can bring, for instance, because if now Portugal is part of BBMRI, we are also more connected. We can share samples, we can share knowledge, and we can advance together. Thank you.
Thank you. Thank you so much. But maybe an issue, there are major points, and issues. You want to mention the problems. However, there are some. One of them is the sustainability of biobanks, βιωσιμότητα. So, because biobanks have a cost, and they have a long-term cost. Ελληνικά. No. Okay. Yes.
So, sustainability of biobanks is a major issue. Okay, let's say that we find funding in order to establish a biobank, but on the long term, the cost is rather high. Have you found a way in Portugal? Could you share that with us on how to work?
We have in this discussed the sustainability. The sustainability is an answer with multiple layers, as you can imagine. So one thing might be the better use of resources. Does it make sense that we have 5, 6, 7 biobanks scattered all over Portugal, and they are all collecting the same type of samples? Can we, in some cases, it's not possible because things must be coupled with something else, like the clinical registries, for instance, but can we organize it better in a way that, for instance, I just mentioned organoids. Maybe organoids, they are so complex that we don't need to have specialized technicians all over the country, because we also don't have the volume of organoids compared with histology samples. So histology, yes, we definitely need them all over because samples are too. So sustainability comes also from organization. Sustainability can come from new business models, dealing with the private sector, for instance. We cannot sell samples, that's completely unethical. But we can provide samples and demand the data back. By the way, biobanks are not just repository of samples, as somebody was saying here. I think it was, yes. I don't have your name now anymore, sorry. They are also a repository of, I mentioned, images, but also data. So it's not just the physical thing in the -80 or liquid nitrogen, is also data. So what we can do is open access, foster open access by coupling or partnering with the private side, the private community, and demand for the sample back. They will process the sample, maybe with high technology, and we have access to data that otherwise we would not, as biobank, be able to afford it, or even the academic centers cannot afford it. So this is one way of sustainability. The other way is definitely the European networks, where we can also connect. A third level of sustainability is relevance. Why? Tell me, if you are an investor and I ask you for money to keep my storage full of something that you don't understand, will you give me money? No. Now, if I tell you that I use this to better understand the community, so feeding on population-based screens so we can better adapt, so we can do studies so we can better adapt, for instance, the treatments that we do. We know that in the north of Portugal we have a population with a genetic background that is different from the south, and so we can also adapt our clinical guidelines. This is the type of things that will build on sustainability. New business models, relevance, and organizational. I would put it in these 3 lines. So when I was showing the slide with, I don't know, 10 or 11 bullet points, in the green paper, this elaborate a little bit more, and we have this.
Thank you. Ευχαριστούμε για την...
Thank you very much. There are no magic bullets or magic solutions. As Mr. Suarez said, this is a multifaceted approach among various stakeholders coming together on a European level. We should try to attract some funding, European funding. We have only a few minutes to ask a final comment from each of you. I will agree with what we have listened. It is very important, especially for Greece, since we have specific geographical and dietary characteristics. We should have biobanks. They are necessary. Even countries such as India have biobanks. We should know our genetic background because thus will allow us to design precision medicine. Now, there are ways for a biobank to become sustainable. It is a national matter. It should be part of the health register. We can buy raw data, as it is the case in more countries. The interesting party that wants to pay the data, they should pay something. In Switzerland, patients that want to know if they have some mutations, they pay a very low fee, and the biobank allows them to use the data. We have the infrastructure. We just have to start collecting the genetic material in a very controlled, in a very structured way. Along with the registries, we have a lot of collections, but nothing organized so far, so we should work towards this direction. Sustainability is always something difficult. Is always something that cannot always be achieved. We should distinguish between the population biobanks and the biobanks that are specialized for specific diseases, such as cancer biobanks or neurological biobanks. BBMRI tries right now to standardize a contract with the private sector. There are a lot of difficulties, especially on behalf of the private sector, because apart from the financial part, there is the moral issues and the legal issues, and at least for the general population banks that are not specialized for specific disease, meaning that there are also samples from healthy people, which are very rare and very valuable. In my opinion, this is a national matter. Until now, at least in Greece, supporting the national network of biobanks is done by the state budget, by the General Secretariat of Research and Innovation. The funding is not allowed. It is difficult with that funding, with that amount of money, to establish biobanks and train also the staff, train the personnel. Nevertheless, this is the only solution for the time being, for the moment, unfortunately.
I will be brief. As regards sustainability, I fully agree with the previous speakers, so I will not repeat what has been said. I would just like to reiterate that a proper biobank, or to establish a proper biobank, is a national emergency. It is a national necessity. So once we're talking about a necessity, the state, it's up to the state to find the requisite funds. It's like discussing infrastructure for power supply, for any utility that allows a society to keep functioning. A biobank is necessary, it is vital, it leads the way towards the future because this is the era of AI, of machine learning. So the opportunities presented to process big data is endless, and we need to have material in order to process it. Another thing I would like to say, in order to improve cancer prognosis, multiple cancer tests, MCTT tests, are a hot topic right now. The healthy population, that, as has been mentioned before, is very, very important. Right now in the UK, we have samples from 100,000 healthy subjects that have been analyzed, and we were able to detect cancers that were impossible to image through liquid biopsy and cellular DNA. So the future is here, and we need to capitalize on it. Even for healthy subjects, we need to have a registry where we will be able to go back in time and detect the very, very early signs that can help us with biomarkers and early detection of cancer. So once again, it is a national necessity. Sustainability should not even be a topic that we are discussing. It's not up to us. It's not our concern. It is something that just needs to be resolved. I guess that sustainability has been covered. I'm not sure if there is a benefactor that could provide the funds, because there's lots of people that have had personal experience and are very sensitive, very aware, very willing to contribute, not sure, though, how to contribute in the fight against cancer. And this is truly extremely important, not just for our country, but for the world as a whole, because we are talking about, as I said before, a highway, the highway of Europe. And if private initiative could also be included, I believe it would help. I think there's lots of people that would love to become benefactors or donors. Comment off microphone, unfortunately, cannot be heard, and as such cannot be translated. Thank you so much. We need to highlight the importance of biobanks, especially for the field of oncology. As you've realized, a biobank is no simple task. It requires trained personnel, specialization, infrastructure, equipment, funds, and synergies. And this brings us back to the starting point, to facilitate the way towards precision medicine. Thank you to all the panelists. Thank you to Mr. Soares. Enjoy the rest of your afternoon.
Ευχαριστούμε πάρα πολύ και περνάμε στο τελευταίο τραπέζι της σημερινής μέρας.
Thanking our panelists, let's move on to the next panel, dedicated to AI, artificial intelligence in European oncology. I would like to invite Mr. Nikolai Kocharenko, head of the National Cancer Institute in Luxembourg, and Ms. Ioanna Michalopoulou, a health lawyer, to moderate this panel.
Good afternoon, everyone, and I would like to ask the panelists to also join, and I think we should have also some panelists connecting online. So.
Καλησπέρα σε όλους.
Good afternoon.
Κύριος Κόλλιας είστε. Ωραία, ωραία. Ναι, ναι.
So, good afternoon, everyone. We would like to start the session. First of all, I would like to ask if our panelists online can hear us. Can you just confirm?
Yes.
Okay, good. So, thank you very much for our session today. So, the title of the session is Artificial Intelligence in European Oncology, Scaling Innovation with Quality, Trust, Inequity. And so we will be co-moderating the session together. So my name is Nikolai Goncharenko, and I'm joined by my dear colleague panelist.
Thank you, Nikolai. I'm Ioanna Michalopoulou. I'm a life sciences lawyer.
And I think firstly we would like to start by introducing our panelists, and maybe we should start with in the order that we have here. So firstly we have Stefanos Koulias, who is the chairman of National Infrastructures for Research and Technology, and is specializing in machine learning. And from 2025 to 2028, he's also coordinating the Greek AI Factor initiative. We have also online Jakob Kater, who is representing the Technical University of Dresden in Germany, and he is a physician scientist and full professor for clinical artificial intelligence.
And we do have Ms. Eleftheria Hadjimichali, who is an associate professor of hematology in the University of Ioannina.
And I also would like to mention Ketil Vidarberg, who is the general manager of the Oslo Cancer Cluster, who has long-standing experience in managing the projects in oncology, and also is working with many international institutions and partners, and has a background in preclinical medicine, and also has an MBA.
And we do have the pleasure to have also Ms. Vaia Mendesidou, who is a medical oncologist and clinical research fellow at Gustave Roussy Villeuf in France.
And finally, we have Ivo Petrov, who is the head of strategic planning and board member of the Bulgarian Joint Cancer Network, who has significant experience also in managing deep health initiatives and has entrepreneurship background. So we finish our round of introductions and would like to start with our discussions. Firstly, I would like to say that artificial intelligence is starting to penetrate every area and every domain, not only of health, but across the board. We're all aware of different applications, which I think we're all using daily. But here today we'll focus on the domain of health, and specifically in oncology, artificial intelligence can be employed and is being employed across the board all along the patient pathway. So starting with prevention and screening, where it allows to perform profiling and maybe do more targeted intervention. It's used in diagnostic and diagnostic technologies. It's also used in treatment, and it can also support the discussions in multidisciplinary tumor boards can help to guide and align different kinds of medical equipment used in the treatment, as well as to support patients during their journey, also during rehabilitation, during survivorship. And finally, last but not least, we have a huge domain of cancer research, and we heard some things about it today, but also it plays a big role in innovation. And of course, beyond that, there is another aspect which is linked to trust, which is linked to legal and ethical aspects. And maybe Joanna would like to say a few words about this.
Yeah, thank you, Nikolai. So as a life sciences lawyer, I work where innovation meets responsibility. And actually in oncology, that meeting point is particularly sensitive. AI promises scale, faster research, better use of expertise, and more precise cancer care. But in this field, scale without quality is meaningless, and quality without trust does not last. What I hear most often from clinicians is not whether AI can be accurate, but whether it is safe to rely on, and what happens when something goes wrong. From a malpractice perspective, AI does not remove responsibility, it reshapes it. As AI becomes part of everyday oncology practice across Europe, the real question is not whether it belongs, but how we integrate it responsibly with quality, trust, and equity at the center. So, given AI potential in oncology, let's start with the ESMO abstract presented by Ms. Mendecido. How does this example show AI actually helping either in research, clinical decision-making, or patient outcomes? Ms. Mendecido, the floor is yours.
Thank you very much. Can you hear me? Yes, excellent. I would like to thank ELLOK very much for the invitation to participate in this year's conference, and especially in the particular roundtable about AI and oncology. I would like to start by saying that this is a poster presentation that we created for the most recent ESMO AI and Digital Oncology Congress that was held in November 2025 in Berlin. And it is worth noting that this is the first ever ESMO Congress dedicated on AI and digital oncology. So this took place at the end of 2025. It is worth noting, I believe, for this roundtable today. Our study was in particular a feasibility study, highlighting the role of digital document structure. So our study was conducted in a particular subset of patients that had a very rare tumor disease called von Hippel-Lindau syndrome. And those patients received treatment within our clinic in the private sector in Thessaloniki, in northern Greece. Our director, Dr. Bukovinas, is the president of the Greek Sarcoma and Rare Cancers Group, and he specializes in treating patients with such rare tumors. So what we did is that we identified 14 patients with this rare disease within our records. We first conducted a manual review of their files regarding 4 specific domains, which is the treatment history and response, toxicity to treatment, related to treatment, the most recent disease evaluation, and also the molecular and genetic profiles that they have. This was conducted by an experienced oncologist, and after that, we used the OncoAI clinician tool, which is an experimental tool embedded within the OncoEHR system, which is the EHR system that we use in our clinic. And we asked this model, the AI tool, I would rather say, to prompt the exact same information. What we saw is that in 8 out of the 14 cases, which is around 52%, the data extraction failed at a technical level due to the document structure, the internal document structure and formatting. But in the rest of the cases, where we had machine-readable data, There was 100% concordance between what the manual review had as a result and what the OncoAI clinician prompted as results. So I believe that this particular study at first shows that if we really want to unlock the potential of AI in oncology, we should have a data-first strategy. That is, we should focus on digitization of our documents. This is, again, very important, especially in Greece, but not simple digitization. We should focus on creative, high-quality, digital native documents in order to unlock the full potential. And to move these thoughts even a little bit forward, I would like to mention that we also have another poster presentation coming up in the ESMO Sarcoma and Rare Cancers meeting that will take place in March in Switzerland. Again, we're moving in the realm of rare tumors because this is also a very important and unique area in oncology. Sometimes left outside of novelty for many years. So this is a slightly different study because at first we should keep in mind that managing rare tumors demands a clinical expertise, but also administrative support. And in Greece in particular, the drug reimbursement for certain drugs requires a specific request to the national healthcare system that is accompanied by an attached specific scientific literature evidence. So this is the reason why we decided to create another pilot, let's say, model within the OncoEHR system that is called OncoAI Bibliography, in order to enhance the automated retrieval of high-quality scientific evidence from peer-reviewed journals, such as the NCCN guidelines, the ESMO Open, which is the official journal of the European Society for Medical Oncology, the New England Journal of Medicine. And this time we decided to apply the model again in an ultra-rare tumors group. This time it is called epithelial cholangiothelioma. It's an ultra-rare disease, meaning that we have less than 1 case per 1,000 people. So we identified only 6 patients in comparison to the 14 patients that we identified in the first study within our records. And what we did was that we, again, conducted a review of all the patient files regarding the 4 domains that we mentioned before. But this time, the results guided targeted literature search. And based on those results, we could see that there was a confirmation of our previous maneuvers, let's say, of our previous medical decisions. And also in 4 out of the 6 cases, which is around 66%, there were also predictive analytics offered, meaning that the model suggested a scenario-specific recommendation as well as to what we should be doing next in treating those patients with such ultra-rare tumors. Again, based on this very high scientific evidence. I do think that this particular study, the second study that we will present, is moving our thoughts a little bit further down the road and closer to the research-grade component that you mentioned and the integration within the clinical workflow. Because even the most accurate AI model is not really efficient if we do not manage to integrate it efficiently in the everyday clinical workflow.
Thank you very much. It's very interesting research and it's really astonishing results. I would like to make a link, so I wanted to ask if Jakob Kata wants to extend on this based on your experience. What do you think are the elements how AI can help to bring research more into translation and application in clinical care?
Thank you very much. Thank you very much for inviting me. And thanks for mentioning the ESMO AI and Digital Oncology Conference last year. It was indeed a very fun event. I was one of the organizers, and I think we were very happy with the turnout, and it will be repeated every year. It will be again in Berlin in November this year, so mark your calendar and hope to see you again, Vaya and everybody. When we speak about AI in oncology, I think we should distinguish two different types of AI. One is specialized AI models. For example, in cancer screening, there are now very good and well-validated AI models to screen for breast cancer in X-ray mammography, or to screen for colorectal cancer in colonoscopy, or to review pathology slides of prostate biopsies to find cancer cells. So these models have been trained for one single task and have been validated for this task, and many of them have come to the market as medical devices with regulatory clearance, so you can use them today, right? But of course, it is super exciting, but it's not the end of the story, because AI methods have evolved much more, and now, of course, everybody is using large language models such as ChatGPT or Claude or others. And these models, they don't have just one application, right? You can ask them anything, and they have a bit of knowledge about anything, including oncology. And indeed, many of our colleagues and our patients are already using ChatGPT and other generalist models every day. And in current surveys, it's probably like 30% of doctors who are using this every day. So, there's many problems here, right? These are not approved for medical use. These are not validated. These can make mistakes. But our colleagues in many cases don't care. They still just use it. And of course, I also find it very, very helpful sometimes, although I'm very careful that I'm not putting any patient data in these models, and that I'm not using it directly for clinical decision making. So I think we have to confront basically these two sides of AI, right? Specialized AI tools, for example, for cancer screening, and these generalist chatbots that are evolving very, very fast. And how do we deal with this? Well, I think we need to educate the oncology community to use this responsibly. And we also have to run validation studies and think about which type of validation we need. It's a very, very exciting time to be alive, and I'm very happy to discuss this here with you. Thank you.
Thank you very much. Very interesting feedback. And of course, we have so many different solutions. So next question would go to Professor Koulias. So many solutions that we have, so many emerging. How do we decide which one deserves a place in everyday practice?
So you can't avoid having different solutions. So in all cases, what we do, we try to find something, the best that fits well with the whole the cures that we have, the data, and so on. But in any case, I think that what we should really look for is the first one, that we use solutions that respect everything with respect to with reference to the patients or to the people that the data refer to. So whatever we do, we are technologists. So I am dealing with AI technology models to be used by experts and doctors and so on. So we try first to have everything safely developed. That means even the processing comes physically, so that it not interferes with other processing elements that we have running in parallel, and to which one maybe some other researchers have access, and this could be a means. So we have in general the security that we have to respect. So you don't send your data to everyone. You had to go to trusted research and teams. And so with respect to models, we have to deal with models that are called that are trustable, that are trustworthy. So we can define which their knowledge and the data they have used for training, if they can explain to the patient why the specific decisions, how the specific decisions were made. And this, of course, it is not very easy because sometimes you deal with much information. But now we have all the, if you are a trusted research team, then you should keep, you should use all the technology provides you with, for example, to have included all the available knowledge about that, so the knowledge is related to your decision. Then you have to also show which data sets were the ones that you really were. So you have to justify, to validate in a persuasive way, both to the doctors, to the experts, and of course to the public. So I think what we say today, that models that are trustworthy, that means you don't use a general ChatGPT. You have to have a refined whatever model that is refined to the data, includes all this, and is governed by all these issues. I think I gave you a first answer.
Thank you.
Thank you. Thank you, Mr. Kollias, and thank you for pointing out safety, security, trust, validation, and I guess many others will be brought by Ms. Hadjimichali. So, if we had to choose, what are the top criteria for bringing AI into daily practice as a clinician, of course? First, clinical benefit. Second, safety and bias checks, or fit into workflow and implementation. What's your opinion on this?
Νομίζω θα μιλήσω ελληνικά για όσους είναι στην αίθουσα και νομίζω υπάρχει μεταφραστής για τα αγγλικά.
So, if we were to choose amongst what you have said, the first and foremost is safety and security. This is what we implement when we try new drugs within the clinical trials, safety first and then efficacy, and so the same criteria should be used when choosing an AI model. The first principle is do not harm in medicine, apart from having a clinical benefit. Then, of course, a clinical benefit for the patient, meaning that we should use those tools that will help us either to have more precise diagnosis or more precise treatments, and of course, let us not forget prevention. What is also very valuable for us clinicians, and Mr. Kollias has already mentioned that, is that all those models that will be used in clinical practice to be characterized by transparency. We should be able to know how they have been trained and developed. The clinician should be able, when they get an output from the algorithm, to know how the algorithm came up with that decision. And it is very important to put emphasis on validation, meaning that when a model will be implemented in our daily lives, first of all, it should be validated based on a population and not just stick to the training that this algorithm accepted, because algorithms can be trained very well with data that might not be representative of our own patients. Therefore, if I, as a clinician, want to use the tool, I should know which is the population that this algorithm was trained based on. It should be implemented regardless of the gender, age, socioeconomic status, meaning that it can be implemented in the real-life patient that I have in front of me and not just in the training data set that it was used to train the algorithm. Last but not least, we all know that artificial intelligence is becoming part of our everyday lives. We should also not forget to monitor. The clinician should be the person that will give feedback to the engineers in order to correct or to rectify any omission or mistake, because at the end of the day we should have the clinical benefit for the patient. Thank you very much.
Kjetil, we all know that Oslo has a very advanced setup, and there's plenty of technology and AI tools being used in oncology in the Oslo cluster. From your experience and from your knowledge, how has this affected patient journey, and what experience or which suggestions would you like to share with the other countries who are just at the beginning, who are implementing different AI solutions? And I think we have no sound.
I can hear you properly.
No, we cannot hear you. Just a second.
I can hear you.
Yes. No?
I can hear you.
Please bear with us. We just need a minute. I hope.
We can still hear you. I can hear you, yes.
Okay. Yeah. Okay. Yeah. Okay, maybe we can jump to the next question and then come back actually to Ivaio. I would like to ask Ms. Mendesidou, Ms. Hadjimichali, and Mr. Kollias. I think you both actually mentioned about trust, clinician trust, at least, in AI. But what about patients? What do patients need to know or experience in order to trust AI, and actually AI supported oncology care? What's your opinion on this? Let's start with Ms. Mendesidou and then come back to the rest.
Well, I believe that they should feel that they can trust us as clinicians when we use their data, which means that, first of all, they need to know that we have a very strict consent framework, very safe environments where we keep their data, and also a very, how can we say this, that their data are only going to be used for the purpose that they were originally gained for, that they have signed a specific consent form for certain data use, so we will not move forward to unjustified use of their data. So I think that this is important, and also that they know that there is always a clinician oversight above the use of the AI tools. So the AI tools are not mature enough to be autonomous. I don't know if and when they will ever be. They still need the clinician's approval. This is important both for us and for the patients to know.
Okay, thank you. And Mr. Kollias, what's your view on this?
I think that what we describe goes towards what we all know about personalized medicine. So think what happens in Greece now. If each one of us can access their own medical file, okay, the patient file. So if there is a system that can assist, can adapt whatever it has learned, as you mentioned, generally, to the specific data that the patient has, of course, so it can provide some cues. Some say that, you know, what happened in this CT that you have resembles to that, or is like that. Of course, the patient cannot really understand if it's true what is said to him. So certainly, I believe that we need the assistance of the doctor. That means any system that we use as artificial intelligence system, I think it is not an AI, but an IA, you know, intelligent assistant system. So it needs to provide cues that a doctor, an expert, can really understand or consider whether they fit or not, and can give another opinion. If this fits, this is shown to you, to me, that as time goes ahead, if this was something that was helpful for him, I think this will help building trust. And as much this happens, I think this should go like that. I think that we're going together.
Okay, thank you. Yeah, it's very so. But I guess that clinicians need time, more time maybe, in order to educate patients. Is that right?
Αυτό που είπατε είναι πάρα πολύ σημαντικό.
What you just said is very important because it means that the physicians themselves need to be trained. And let me just point out that we've already had guidelines by ESMO. Mr. Kapetanakis is a co-author of said guidelines because the clinical physicians need to find out how to navigate a new era of AI. They need to know what are the restrictions of AI, that there may be a bias within the algorithm, and therefore we need to train physicians so that they can inform the patients about all these aspects. And of course, at each point, the physician needs to reveal that there is use of AI, either for diagnosis, assisting in diagnosis, or even in order to record an interview and keep notes for the folder, or in order to write a medical note. So we need to train the physician, who will then transfer this training to the patient, and this will truly increase trust. Another aspect which I think is very important is that we all need to know the legal framework in which we will be working. Physicians need to know the legal framework, and on the other side, of course, patients need to know their rights. And Ms. Medisidou has already mentioned that data needs to be protected, anonymized, and that there will be no risk of any confidential information leaking. So it is very important for the patients to be aware that there is strong, robust safety and security of the data, and on the other hand, the treating physician needs to know the legal framework in order to not forget that the responsibility lies with them.
Patients consent before.
I believe that we need consent for just about everything. First of all, there needs to be information. A consent needs to be informed if it's going to be used. And once again, we need to come back to the example of clinical studies and trials and point out that patients need to participate in the creation of those algorithms as well as in their integration, the same way as patients are currently co-designing clinical trials, clinical studies, protocols, and we need to take into consideration, do they accept to undergo, for example, a CT scan once a month? This is something that we need to acknowledge and respect. And with the integration of AI in clinical practice, we will need to have patients that contribute so that we can together create a set of values, a code of values.
And inclusion of patients is very important, and I would like to still go back to Ketil. Can you confirm if you can hear us now, if you are connected now?
I can hear you well.
Great.
Can you hear me?
Yes, yes, very well. So I just want to get back to my question about your experience in Oslo, about the setup and use of AI systems, and you have been very successful. So what would be your suggestions for other systems and other countries?
Yeah, I had some technician now. I hope you can hear me.
Yes. Could you hear my question?
Yeah. So, thank you. First, saying is that if Norway see us as technical advantage, I say it, my background is from health and digital space, so I would say health is in Norway, and I would say that AI in oncology is in a relevant. If I compared, for example, how Europe invented AT cell therapy, look at how we invest in AI as an infrastructure the same way. And I think this the sound I have to do again.
I think we have a problem with the sound, and I think now you froze. I'm very sorry, Ketil, we will try again. Maybe I will just ask a similar question. I will go to Ivo, to Ivalo Petrov from Bulgaria, and I will ask you, you're involved in many initiatives, setting up new innovative structures. Could you tell me which steps are you undertaking in Bulgaria, and how do you think, what would be important to integrate AI in your country in clinical practice? And of course, you know much more of the environment, you know, what the work that we do within the cancer mission hubs.
I think this conversation, first of all, have to start from the beginning with one clarification, because within the wording of AI, there are two deviations. And the one road is the road to the machine-learned AIs. The second road is the road to the large language models and the open models. In both roads, there are totally parallel way of how we are validating, how we are constructing, how we are testing, and because we have mentioned trustworthy AI process, actually this process was established exactly because of the era at the boom of the ChatGPT or the open source large language models, and there are 6 principles, which 6 principles were mentioned into the expectation of the clinicians, actually, and they're very well described there. So backing forward to Bulgaria, I could say Bulgaria is a zone in which we have less investment in digital health. That's why I will not talk about the Bulgaria. I will talk from my perspective as a part of the working groups through the WHO guiding working group, also the AI on sustainable healthcare systems working group, a part of the WHO also, and many other working groups where we are exactly not by theoretically, but really trying to practically challenge also ourselves, because most of us are also researchers and developers. The story here is actually from the real practice. The real practice showing the same thing, and I will stop with that, especially about the large language models, something which nowadays is working. ChatGPT, by the way, last week they have announced and opened the ChatGPT Health system, in which through 1 week we have more than 230 million people entered. So can we imagine how much of those people they have relied on the conclusions which were disclaimed there and came back to the healthcare professionals asking them if this is true or not. So here is the dilemma, and it's the dilemma of our mindsets. And the dilemma of our mindset is actually that in one moment when we are using those models, more and more we are starting to interpretate and to think like the models. And it's going to be very hard for us to assess true or false of what we have detected. The totally different stories with the machine-learned language models, because there we have coding, there we have mathematical processing, and so on and so forth. But stepping back to the large language model, I think now we are at the era of the challenges behind those models. And here, also a good example is the example of Anthropic. Anthropic actually is the biggest and much better company which is working on large language models in general, and even they have tried to interpret that into the healthcare. And honestly, if we are taking on the PubMed and going the meta-analysis, we will see that most of the large language models, still now, they're failing. They're not so failing into the diagnostic interpretations, because more or less there we are using the numbers, right? Which is much better to be predicted. We have professor here on that. But when we are talking about the narratives and the narrative interpretations, the results are still not good, and the results are still not good exactly of the main reason, the hallucination, and how we're integrating the trustworthy process, how we're going back to the auditing process. So what we have at the enter point, and how trusted this is what we have on the enter point, and what we're expecting on the exit point. So actually, the discussion will be exactly the beginning. But here also, I would like to hear also Ketil, because he have very good experience on that.
Thank you very much. So trust remains the issue. Ketil, is it better now?
I don't know. Can you hear me?
Yes, we can.
Okay.
So maybe you want to share your experience in just a few words, so we can connect you back into the discussion.
Yeah, no, it's sort of a mess. No, I think just to the last comment here, in Norway now, and maybe in the rest of Europe, there's a lot of things happening for speaking language into text for the physicians, right? And in the sense then, you are actually using these large language models to build the data that you later do the research on. And I think that this build up kind of a potential conflict of what kind of data do they do the epidemiology on, so I want kind of, what we're discussing in Norway is not if AI is coming in health and oncology, but it's more who does it work for, under what variants and conditions, and who carries the risk. So it's more like the algorithms that we see, the digital biomarkers, they work. But what are the systems? What are the incentives and the governance we're putting up? So I spent part of my life working with digital pathology and founding a company called Diagnostics. It works. But what are the systems to get it used? What are the incentives to put it into work? I've seen that very clearly. And then another company, Nordic RWE, works on how you use AI on epidemiology data to understand and build control arms and see how disease works. And then, how can that be utilized? Because I think that in Europe, compared to US, for example, we can use these kind of analysis to understand what happens if we don't treat. Can we get advice on a system level on where to have interactions? And I'll stop myself because there are other aspects, but they are too broad.
Thank you very much. I think we still have some time left, or are we over time? So we still have some time left. So would you like to?
Yeah. Okay, I would like to ask actually all of you a question, starting from Mr. Kollias. So, Mr. Kollias, looking ahead, what single change in practice, governance or culture would be most help patients trust AI-supported oncology care in Europe?
I think we started discussing it now what the issues are, as there will be fake news everywhere, fake images and so on. Here we will have many, as you mentioned, sources of information which might be not correct, at least. Okay, so I think both the states, the European states, as well, I think Europe tries to do that. They try to create some ecosystems that are based on trustworthy decision-making. So, for example, in Greece, now I'm coordinating one of the European AI factories. It's called Pharos for Greece. And the idea is to create our own infrastructure, resources for running systems in a safe way. Then we will have data that will be reliable, there will be no bias in there, unbiased, and so on. We'll have some models that can be used for adaptation in specific cases. And this would be, at least in the first 3 years, for free. to the researchers, to the small enterprises or and SMEs, and this will be according to, we respect the AI Act, we respect the GDPR, and so on. So the idea is this could be a trusted, that we define in the country, a trusted ecosystem that can provide with assistance, not necessarily some resources can be really efficient, but it could be also not trusted. I think this is one way that we're currently trying to be implemented, tested.
Thank you. Ms. Hatzimichal.
Could I have one comment?
Maybe he wants to talk.
Yeah, of course. We cannot deny.
Thanks. No, just one comment, which is necessarily wider than oncology, but in Norway now we have a serious discussion about replacing the GPs with a AI tool that take the first question from patients before they go to experts. And this is not because we want to be advanced, but 1/4 of the Norwegian population use ChatGPT to question, also about medical questions. So it's also a kind of an effect of population, how they use AI. And I think this is also something where we can discuss about making ethical and correct AI, but in practice, while we're discussing that, populations start using AI to get questioned on the first line before they go to experts. And I think this is, to me, a big concern. How do we utilize the European health data, which has far superior understanding, or data that can help us understand, than the US-based healthcare system? How do we utilize that we have in Europe, in oncology specifically, to really deliver that care better than we do today? And I think we have a unique opportunity to do that, but it happens now.
Okay, thank you for your perspective. And shall we continue in the room or shall we continue online? I think we can continue online. Maybe we can pass to Jakob Kata. Maybe you would like to comment on the question.
Sorry, can you repeat the question?
Yes. So looking ahead, what single change in practice, governance, or culture would most help patients trust AI-supported oncology solutions? So what do you think would be important so that patients actually do trust AI?
I think patients already trust AI. I mean, 50% of the young patients or more are using AI. There's data that 25% of teenagers talk about mental health to chatbots, to large language models. They trust it already. They trust it more than their parents. Teenagers trust ChatGPT more than they trust their parents. So I think it's already here today, and we basically have to cope with it and have to provide validation. And actually, I think we have to work on patients trusting us as human oncologists, because they already trust AI. And sometimes even patients come to me and they say, well, but ChatGPT told me something else, right? And we have to convince them that they should trust us. So I think that's the reality, especially with younger patients.
So I think we're just living at the time of paradigm shifts, right? And maybe it's indeed, those are the questions that we should be asking, how can we get back into human world or integrate AI into human world, which is basically taking its own course. So we have one more person online. Would you like to comment?
Yes, of course.
Ms. Mediciu?
Thank you. I believe the patients will also learn to trust AI a little bit more if they see results, like enhancement of patient outcomes, and mostly if they see, for example, that there is a reduction with regards to the inequality in oncology. Of course, this means that all the AI models will have been created not just within one particular country or one big entire university hospital, but they will be easily transportable and applicable to other populations as well, much like what Professor Hadzimichali mentioned a little bit earlier. So if they feel and know for a fact that an AI model was created without having excluded specific populations, I believe this will help them trust it even more.
Thank you.
Νομίζω ότι δική μου πλευρά αυτό μετά.
So, after everything I have heard, in my opinion, we should let patients know that artificial intelligence is not just large language models. LLMs is the models that we use in our everyday life, and of course, patients have easy access to LLMs. However, in medicine, AI is much more than large language models. Algorithms developed by specialized scientists with a specific goal and specific task. And they have a specialization, not a general algorithm that will predict our next words. This is what LLMs are on about. So this is part of the trainings of clinicians and physicians, and this is what we have to communicate with our patients. Of course, we will coexist with AI. We need it because 50% of our cancer patients until today die. So we need all the help we can get. And we should trust it and we should use it knowing its limitations and explaining all these aspects to the patient, what AI is all about, how it can help us, which are its limits and limitations. And step by step, we will leave LLMs behind. All our patients will go to LLMs. We had Dr. Google, now we'll have Dr. ChatGPT or Dr. Health, or I don't know what. Medicine should remain having humans in the center. Everything is happening to the benefit of our patients since they are the receivers of the services, and humans should be kept in the loop.
Have two different uses of AI, the use by professionals and by use by patients. Ivo, what's your view on this? How can we bridge the gap?
I'll start with one example. So, beginning of last year, I was invited at the European School of Oncology, taking the notes regarding one new model, one research concept for the large language model into the healthcare. And there, one colleague, healthcare professional, stands in front of me and says, "No, I don't want to be replaced by such kind of models or instruments." And I says, "This is not the reason. I mean, to driving the research. Actually, the reason to driving research is really to trying to helping you saving time and generating the evidence-grade decisions for you. I mean, to be considered." But why I'm saying that? I'm saying that because when we are talking and also having all of the bureaucracy, all of the elements of the regulatory processes across us, so generally across Europe and on the member states level, actually we are more and more working on the serverless flow. And when we are talking to the other continents, when we are talking to the US and when we are turning to the Asia, we are seeing a totally different story. And this is a story of stimulation of the research together with the end users, which is the success story. And when we are still thinking and doing the things on the servers, the others, they're progressing. And this is my biggest afraid for Europe, honestly, and what we can do, because this will reflect also our patients, and most of us, sooner or later, could be also patients. I mean, yeah.
We have heard many arguments today, and I have to admit that I'm also puzzled, and I would like to thank from my side all the panelists for putting those arguments on the table. And I think it's time also for us to reflect and to continue those discussions after this wonderful Congress and after this meeting. What do you think, Iona?
It's on the table, actually. Long discussions will continue. We'd like to thank you, first of all, our great panelists, both online and here. Mr. Kapetanakis, of course, for the great organizations and for the actually initiative and the great honor to have us here. And I think the future looks bright. And as you mentioned, with the patient in the center, we have lots to do. Thank you so much. Thank you.
Thank you very much to ELLOK for organizing this and to the panelists for joining. We will continue the discussion soon. Thank you.
Σας ευχαριστούμε πραγματικά.
Thank you very much. Thank you.
Yes, of course. You can stay with me. Yes, of course, of course. You can stay with me. It's no. Actually, is the
Now it is about time to wrap up the 10th annual conference.
We have this roundtable, which is the future. So it will be a connection between this and the next, because I believe that the next time we will have the need to give more time to these topics and focus it, of course, in an earlier hour, so we can have more audience here. I've been recorded. Okay. Maria knows something for me, but Maria, don't speak, please. Λοιπόν,
Okay, so this was the third day, a day about digital health. We started this morning with the digital tools, the new reality in medicine. We saw the development of the digital transformation in oncological care. We are really optimistic for the future because this effort promises to bring about something different. We continued later and we understood that research and innovation can be supported and that we can hope for a more targeted funding for the future. What the state should do. And we also talked about the importance of words in cancer. This is World Cancer Day, and this is very important to shape a new culture, to adopt a new approach, a contemporary approach that will not promote fear but care. And we focused on specific rare cases that should not be forgotten. We talked about brain tumors, glioma, and we also took a look into ovarian cancer, two cases that should be seen. Again, we should focus on those cases. Those patients also need care. And this is something that we want to continue doing. We will continue shedding light to rare cancers. The voices of those patients should also be heard. And of course, we had the round table on hospital care, hospitalization. The minister was here with us and the head of the health districts. They talk about the future of hospital care and where we should focus in order to have a better cancer care. Then we had the pleasure to have with us ECOS and my dear friend Hugo Soares, and of course all the distinguished panelists. Dear Hugo, we feel that you are a large part of this effort, of this hub, the National Cancer Mission Hub, and we want to support it on an institutional level. we want to help to continue this effort that you have started with your partners. And all together, we want to do the best for Europe, not only for Greece. So we are trying to do our best, and we will continue trying, and we will invest on international collaboration, because this is the goal after all. This is the quadruple helix, and we should always look into the bigger picture, since this is the only thing that will bring us closer to our goal. We talked about health literacy. We should stop talking and we should start focusing on health literacy, not only for patients, but citizens. Citizens, before becoming patients, they should know a lot of things. And of course, we talked about synergies, EHDS, the European Data Health Center, the first space, health space, I apologize. And since now ELLOK is the hub, we have done a lot of things towards this direction. Then we talked about biobanks. When we talk about data, we should know that biological samples should be accompanied by data. Having the one and not the other is not very helpful. And we also talked about the challenges and the actions that we should take. We lag a bit behind. And last but not least, we had our last panel for artificial intelligence. We should catch up with AI. We should understand which is the best possible way to use it. And we should never forget the moral aspect of AI and take into consideration all the aspects of this very complex, because there is no accountability behind AI tools. Nevertheless, we saw that younger people tend to trust more ChatGPT rather than their parents or their physicians. Next time, I promise you that we will give more time to this discussion. We will try to deep dive into this topic, and why not draw some conclusions? So, on this note, I would like to thank you for being here, for putting up with us in this marathon, if I may say so. Thank you for being here with us. Thank you to all our supporters, our sponsors, but you, the speakers, and the participants, for the love, the support, and your participation and engagement. I wish you the best. World Cancer Day today, less cancer tomorrow. Let's work all together. Have a nice evening. Thank you.